Good morning. Look, so we have to start on time. Muthukumar, please do come. There's some chairpersons have. Okay, so welcome to the second day or third day of the scientific session, and it is actually a big session, technology in spine, which we have to learn. All of us are learning every day. And as the first speaker, we have none other than uh, Mr. Kulkarni from UK, who has spent lifetime. Yesterday, even Professor Ramani was alluding to Kulkarni's role in skull in spinal surgery in India. Anand, please come, run and come. And please, Kulkarni, stage is yours. Anand, I am inducted because you are not to be.
NSSA Committee, Hyderabad. Thank you for allowing me to share our experience from King's College Hospital. In, uh, I will be sharing experience from King's College Hospital. This is regarding robot in spine surgery. We got this robot this year, April, and we have done few cases. We just share our experience. Closures. We got this robot system, Measure X Stealth, which is quite recent one, and they help us doing cases. Their relatives are always there guiding us. This is an important part of this operation, and they help in training education. Robot is a machine, especially one programmable by a computer, capable of carrying out a complex series of actions automatically. Millions of operations done on spine, we get associated morbidities. Whole idea is we cannot stop these morbidities, but we try and reduce them as much as possible. With the advancement of robotic technology, we knew had to have tools that enhance surgical precision, reduce recovery times, and improve overall patient outcomes. What is AI and robotics? Artificial intelligence is a discipline that focuses on enabling machines to develop the same intellectual capabilities as humans. Robotics, it's a branch of engineering. Really, the other hand is the science of designing and building physical robots to improve automation and innovation. Robots are used worldwide. You can see there are in the uh, warehouses, in factories, offices, in agriculture industry, games, and as at home also helping people to do things. Also in medicine, we got robots. We do operations. There are nursing assistants. There are education for the doctors. There are education for the patients, and so on. What is a robot? It's a motion without emotion. Like I think we do spinal surgery. Can you imagine any spine surgeon putting a particular screw, how much stress it is? The robot takes out that stress. And I think that is very helpful. Our job becomes easy, stressless, and we do things with less complications, faster recovery and time, and greater accuracy and high precision. We got current available robots in this supervisory control, telesurgical, or shared control. Ours is a shared control where computers, we do some work, robot do some work. Telesurgical is something which you do it from distance. A teamwork guides you, and it is surgery is carried out in a different center. Supervisory controlled is something most of the work is done by the robot. Like for example, maybe cyberknife, you just put the button, job is done. Historical background. Horsley and Clark introduced stereotaxy, 1908, and we all of us done brain stereotaxy surgeries, biopsies. You know how stereotactic that procedure is. You just follow the protocol step by steps, and your job is done. Similarly, robot surgery is exactly like that. Similar, you follow the steps, protocols. More accurate you are doing and following your planning, the better, best is the result. Uh, is developed then later on lot of lot of computers or robots come in the market, Da Vinci, Major, and they used in brain biopsies and spinal blocks initially. Major came in 2004, 2001, and they had various sorts of different modifications. And there's lots of other robots coming in the market like GPS, Measure, Zimmer, Nuesive, Brain Lab. At least I saw 3, 4 here around in our conference here. So I think they are going to stay here, and we need to learn them to improve more accuracy. It's more scientific, and a lot of or on the horizons they are coming in. Initially, when we do put the patient on the position, then you put the reference frame usually on the spinous process, or maybe a screw on the iliac crest, and then you do adjust your navigation system, and you acquire the image with the C arm, O arm, etc. We use O arm in our department, and then this is the most important step here, which is screw planning trajectory. You have to spend good time with the representatives to plan this. Whatever you plan is executed by the robot. So this planning is very important. So path positioning with robotic arm movements, the robot helps to do that. You put the screws. After the putting the screws, again the O arm is run the O arm to get the images. So you know there and there itself, your screws are in good position. In remote control robots, planning and image verification done in a main center, and the operation is carried out in. So what are the indications for robotic spine surgery? Spinal fractures. In our department, we are doing thoracolumbar degenerative cases and spinal fractures. The whole idea of using robot is just putting pedicular screw through the pedicle. That is what we are doing at the moment. We just got this robot in April, and we have done some 32 cases. So we do that in our department. Also, in literature, you can see there is cervical, upper cervical, lower cervical, even lateral mass screws. They're used in spinal deformity, spinal tumors, excision of spinal tumors, or vertebroplasty, biopsy, and some anterior lumbar surgery using robots like Da Vinci and Celsius GPS. This is a video. I will take opportunity here. We got some extra time. Start the video. Can somebody start the video?
Can you play it directly? I think the extra time we are.
We'll play it at the end if
All
it works. Can you make it big? Screen size of the screen. So we'll try and play the video later on. We just discuss few cases which we have done. This is a 19-year-old boy who had a T12 fracture, expelled out from a quad bike, hit trees, and was using helmet. But he had this T12 fracture, as you can see on the CT scan there and the MRI as well, first fracture. So we got this Allen table. We use O-arm, and that's the most important thing is the planning of the screws going through the pedicle with the help of. So you see epi, lateral, and coronal views, and you see immediately when you run the O-arm post-operatively, you see the position of the screws. This is another case. This is a guy who is 28-year-old. He had a cycle accident. And see that he was going with high speed on the cycle, hit by the car, was tossed into the air. He was not wearing helmet. So he had a multi-trauma. It took time for him to settle down. It took at least 1 week to came for the operation. You can see that T3, T4, T3 fracture, which is burst again, and dislocation at T3, 4. I personally want to say that we are using other modalities, but using for cases like this, I think robotic surgery is very. So we do this Allen table. So this one, you can see the planning there very well, and all screws going into the pedicle. And this is a immediate intraoperative pictures of the pedicles going through that. So they are very accurate. So far, we are done well in all 32 cases. Obviously, it's our learning curve at the moment. This is another case, which is L4-5 spondylolisthesis and stenosis. You can see that this is an optical tracker on which you put the O-arm and run the O-arm to get the images, and then you do surgical planning. So this is the planning, and you can see the cage and screws, AP and axial and lateral, all views there, and you can see the trajectory of the screws as well. You will see this is open surgery. This is called midliff. Because there was stenosis, we decided to decompress the spine by doing laminectomy. But you can see while we're doing that, you can see some wires here in the picture. Why using wires when there is a robotic screw, robot available? Actually, in this system, there is a screw which is separate from his head. So the screw goes through the system, and when the screw goes, you put the head on the top of that. Screws are not available for us in Europe at the moment, but since probably we'll get it from December, and then probably we don't have to use the guide wires anymore. You can see this picture here. The screws which are going in a different direction, slightly different, use that. The length is small, they are thin diameter, and the threads are very high. So these are called cortical bone trajectory screws. You can see normal screws, they go from lateral to medial into the body, into the cancellous one. But these are the cortical screws which go through the cortex of the pedicle and also to some part of the cortex of the body. So they are more stronger. You can use especially in people with osteopenic bones or elderly people. You can see the same pictures here in axial cut. There are a lot of literature you can see that obviously robots have shown more accurate placement of the screws. This was the work done by Chinese robot, and 11, 16, 116 screws put in, and the accuracy with freehand technique was 93.5%, and with robot it was 98.7%. So there are a lot of things in the literature. You have already seen those, but one there for advantage of robotic systems: reduce exposure. First thing is accuracy and precision. Number two is radiation. When the O-arm is run, everybody runs out of the theater. Only radiographer, maybe anesthetist there. So of course, that's why less radiation to surgeon and the staff. Reduce mispositioning and reoperation rates, because you get the post-op immediate intraoperative results there and there itself. You don't have to go back, oh, a screw is not there, you take the patient back into the theater again. That may not happen. Decreased and all other advantage of minimal spine surgery. Disadvantages: reliable lacking of tactile feedback when you do the thing. You do everything best on the images, and then you get a feeling you are going through the bone, but it's not really good feedback. So
Kulkarni, you have finished your time, but you can take a couple of minutes. Want to show the video, you have to come in the end.
Okay, we'll come back to the end if time permits. Otherwise,
you have to finish in 1 minute.
Yeah.
1 minute for
disorder. But the biggest issue, high initial cost, is the one for these robotic things. Obviously, as time permits and a lot of people buy them and the companies decrease their price, that's happened with like any other gadget. Of course, you need training and education for doing this kind of surgeries. Case studies and clinical outcomes. There are papers which are already described there. There's ones by Hansman and Benix et al. To improve accuracy and precision of these screws. There are multi-center trials already there, and also comparative studies showing the better results with surgery. So accuracy is more, then you can avoid violation of the superior facet joint violation. That will prevent adjacent segment problems. That can be done. And also CBT screws, which we talked about, can help to improve the session. So other future developments will be that more integration with the AI, tele-robotics, that people can be operated in remote areas with the help of robots, virtual reality modules for training of the surgeons, and biomechanical modeling, advanced stimulation for better surgical planning. Will a robot replace a spinal surgeon? Well, we don't know. That's we're going to see here. But thank you for listening. And I think
thank you, Kulkarni. Any comments?
And this video, I think there's a link given on the video, which is on the YouTube. So I don't want to spend any time.
We'll have it in the end. We will.
No problem.
Okay. Any comments from please?
Any comments?
Not comments. Make it short because we have already overshot.
Real time or virtual, you get accurately whether you get with this present available robots or not.
Did that? Yeah. When we put the screws, there is a real time. As we go put the screws, we can see that on the image as well. The screw is going in. The picture is real time, but you don't have a tactile feedback of that. That is what we see. But there are some haptic systems that probably will help in future.
I think you answered my question, but my comment was, we have a circ. The difficulty is the lack of tactile feel. You know, when you're going in pedicle, you feel, which makes you feel a little bit nervous if the pedicle is very small. So I was just going to ask you how you overcome that fear, a surgeon's fear that, am I in the right place?
I think at the moment, just looking at the experience only, where we're doing more and more cases, and then you are sure what you're doing is right. Like that is what are we going to learn with this, unless the system develops in future and develops on this haptic system and get real feedback when we are doing this process.
Thank you, Kulkarni. Can I invite the next speaker?
Thank you.
Thank you. Next speaker is Brigadier Manish Sharma from Command Hospital, Pune, and he is going to talk to us on neuro-navigated spinal instrumentation using flat panel 3D fluoroscopy. Manish, stage is yours.
Morning, ladies and gentlemen. At the outset, I'd like to thank the organizers and the chairpersons for giving us an opportunity to present our humble data. Indeed, a matter of honor. I have no disclosures. The product has been supplied by the Government of India, and I'm just here to present the experience. And for the audience, they can make their own judgment depending on the images projected and the workflow as per their liking or disliking. Intraoperative imaging from its humble beginnings from traditional radiography, CM fluoroscopy has now progressed where we have intraop MRI, 3D fluoroscopy comes somewhere in between. We have neuronavigation, multiple platforms are available. Some of them are Stealth Station, 7D surgical system, Stryker has one of its own. And imaging platforms like OARM, Intraop CT, and Zyme has just come into India recently. As with advancing minimally invasive spinal surgery technology, the imaging modalities have also improved, and both of them have worked in collusion to provide better patient care. I have worked in Army Hospital R&R with OARM initially, and now having been posted to Command Hospital Pune, FMC Pune, I'm using Zyme Vision 3D RFT. Both of them are integrated with Stealth Station 8 and require an attachment with them. OARM belonging to the same manufacturer comes inbuilt, and if we have Zyme equipment, an additional radio reflectors have to be attached to the gantry so that they are recognized by the Stealth 8 machine. It's not too difficult. It got done over a period of 1 month. It is integrated with the neuronavigation through a communication channel so that it can communicate freely with it. And there are definite advantages of neuronavigation, although people who are experienced who are performing spinal surgery as the only things for them, it's all right. They already are accurate with their freehand techniques. But for the people who probably are doing head injury one day and shifting to spinal surgery the next day and moving on to another one the next day, it definitely gives them calmer heartbeat to know that their accuracy is better and the pedicle cannulation can be done under vision. It kind of gives a real-time orientation, although it is based on preoperative image which has been taken a few minutes before. It definitely brings down the radiation exposure because the number of exposures come down. You just have to take one 3D shot in the beginning and one probably at the end to confirm the location of your the screw placement. It definitely saves time and reduces the radiation. This is the image which has been provided. It comes with certain inherent technologies which are superior to the image intensifiers. It has better picture resolution and it comes with 25 kilowatt power. Initially, they came with 2.5 kilowatt, but they have now increased it to 25, which enhances the image quality and interpretation. Certain formalities which are required, I'll just mention them for the people who are uninitiated. A radiolucent OT table is required around which the whole gantry can move. It has to avoid any collisions which may occur. Imaging equipment is placed on the left side of the patient conventionally, but it is as per the surgeon's preference. Neuronavigation equipment is placed at the head end, but the camera can be placed either at the head end or at the foot end, depending on the requirement of the case. Patient is positioned as we see it in this image. The two images, the one on the left side is to show the patient positioning, and the right side we can see slightly more clearly where the 3D RFD is placed and the neuronavigation is placed. The tracker has to be, the drawback is that the tracker has to be put. Even if we are doing minimally invasive surgery without a percutaneous screw placement is being done, the tracker requires to be fixed. And tracker, for that, you have to expose the spinous process. It is fixed, directed either towards the head end or the foot end. One picture shows it directed to the head end, the other one to the foot end, as per the requirement of the case. Now, it is proposed, it is being promoted that the image has a variable isocenter. So that is the reason why only a 165-degree rotation accompanied by a linear 7.5 degree rotation in the beginning and end helps the 3D RFD to take a complete 360-degree picture. And this kind of helps because the number of collisions which can occur comes down. Subsequent to that, another requirement is the availability of navigated screw placements. Now, the instruments come pre-fitted with the navigated reflectors. But in addition, even if we do not have navigated screws, They can be fitted on any instrument and it can be customized to the requirement of the case. This is one image which is showing the location of the tracker as well as one instrument which you're using. This is the reflector which is used, and it has been fitted on an instrument which is not customized to using Medtronic's equipment alone. A small video to show how we do. We're using pack needle here to mark the site of entry. The site of entry having been marked first, we move on to the subsequent equipment, the awl which is used to penetrate the cortex. Once we penetrate the cortex, I have this video so that the audience can make a judgment of their own as to what is the clarity, how is it as compared to O-arm. The O-arm is what we use routinely, and we were very happy with it. But we found that even this equipment is not really all that bad. We actually get fairly good images, although the image quality is not as good as O-arm, but it is good enough to see where we are headed and where we are directed. I'll just run forward, and this is at the end. After having placed the percutaneous screws, we get a 3D rotational image, see and confirm it in the real time. Because when you're putting the screws at that time, the image is probably, there is a possibility that this screws could have moved or the bones could have moved. But in the end, you can just confirm it, and there is no need of shifting the patient to the CT gantry as highlighted by the previous speaker, and then coming back to the OT if there's a misplaced screw. This is another screw. The previous one was in the dorsal spine. Sorry, that is in the dorsal spine. And now we move on to the one where a lumbar pedicle screw is being placed. Equally easy. There's not much difficulty in this. There is no difficulty in visualizing the pedicle or the body of the vertebra. I'll quickly go on to the last bit where we do a 3D rotational image in the end to confirm the accurate placement of the pedicle screw. Moving further, we had this equipment about 4-5 months back. Unfortunately, after installation, after very first case, there was a glitch in the machine and it had to undergo major repairs. Took us about a month and a half to have it repaired. That is a problem of image intensifiers as compared to flat panel. Most of these equipment, there's no servicing available in India, and people have to come from abroad to have it. Whatever parts have to be brought from abroad to have it repaired. So we've done about 36 pedicle screws which have been placed, predominantly lumbar, a few dorsal spine, sacrum. We had a challenge in the cervical spine. We are still trying to get a table in which the gantry can move around collision free. So in absence of that, we have, despite attempting in a couple of cases where we wanted to put pedicle screws in the cervical spine, we could not succeed. And once we overcome this challenge of getting a translucent head end, we'll be able to do that further. We have done it in trauma, malignancies, infective and degenerative disc diseases. Cervical spine we couldn't do, which was initially planned. I wanted to highlight this because we need a specialized table to do cervical spine cases. This is little theoretical material. It has neuronavigation and image-guided surgery has benefits in cervical applications. Basically, because of the proximity to vertebral artery, proximity to neural elements, and the scope is anything can be done from anterior approach to posterior approach. There were initially some hiccups about the posterior approach, but anterior approach, but that has been overcome by putting reflectors, gluons on the head ring. It has equally good application in the thoracic spine. Kyphoplasty can be done. Pedicle screw placements I've already shown. The whole spectrum of degenerative, infective, and oncology were previously being done. Now the scope has been expanded even to trauma. One significant advantage which is being discussed is the exposure to the radiation. There have been randomized trials which have shown that there is a significant reduction in radiation exposure as the number of exposures come down significantly. In lumbosacral spine, also there is a role of this in pedicle screw placement. Deformity correction, it is being used more and more, especially in the elderly, where the scope of making any mistakes is far little. And there are some limitations. If the real-time imaging is not used, the pre-op imaging is used, it leads to inaccuracies between radiographic anatomy and surgical anatomy. There can be positional differences. If you are using 3D fluoroscopy, then the patient is grossly obese or there is osteopenia, there will be difficulties. And of course, the segments has always been an issue. How many segments can you do? It generally covers cervical 6 vertebrae and dorsal spine about 5 to 6 vertebrae in the lumbar spine. With that, I come to an end. This is the hospital in which we have been doing this, and that's my small team with which we perform our surgery.
Thanks, Manish. Finishing in time. Any comments? Okay, no comments. Thanks, Manish. Abhay, please, Abhay.
you attach the C arm itself, you attach that reflectors.
Yes.
Have you noticed any difference registering that part? When we used to do 2D fluoroscopy with navigation, we used to have a lot of difficulty registering that part. The stealth navigation thing also has to identify this as well. Did you find any difference?
None at all,
That-
sir. We've never had any difficulty with that. So in fact, that is one-time registration that is done at the beginning. And that time, it of course took us 3-4 days when the engineer was there and he fixed it. But thereafter, subsequent to that, we have not had, and we have had only about 8 to 10 cases, but we haven't had any difficulty of any kind with that reflex.
Thank you.
Thank you. Now we call upon the next speaker, Dr. Mohan Rao, for intraoperative neurophysiology monitoring in spine surgery, enhancing safety and surgical outcomes.
Good morning to the respected chairpersons. And first of all, I thank Dr. Manas and Dr. Sastry for giving me this opportunity. This is a small 28-bedded hospital having all the gadgets, in, even including the biplane cath lab. So even this is a small 28-bedded hospital having a biplane cath lab. We do all subspecialties here. So the role of intraoperative neuromonitoring, basically what, when, where, why, who, how, who. So if we see, I mean, if any person like sees through this image, there is no problem. But if you see this image, we are seeing the like only one way is the better than the other two ways. So how we can identify this? So the problem here is the surgeon itself. Like surgeon does the problem, so iatrogenic injury is the major problem here. So how can this occur? Like what are the problems? So either maybe surgical problems like distraction, compression, or blunt injury, or anesthetic problems, maybe hypotension, ischemia, or temperature, or like hypothermia, or cervical extension during the positioning, or direct compression, or blood supply, or all these are the problems. So what happens? Like so we are creating a problem. What was the with and without? Like generally without this, I'll only quote the intramedullary resection. Generally with IONM it is around 5% and without is like around 23.8%. This is quoted. And so basically we do this to improve the quality of life. I mean, surgeon is the first person and all these are the gadgets. Whatever my previous speakers showed the anatomically how we do that. And here what I am showing is like a physiological way how to do that. So as the surgery is improving and even for the like the medical facilities are improving, the life expectancy is also improving, but the quality of life is not if we don't use all the gadgets. So why I avoid iatrogenic injury? Just to reduce the cost first thing and to improve the quality of the life. So how we can avoid timely detection of the changes so that I mean even before we damage, if we identify that, that will be good. So as I said, previous my two speakers they told about the anatomically how they can do, but here I am showing the functional way. So the functional assessment is through the intraoperative neuromonitoring, and how we do that. So both the non-provocative and the provocative tests. So commonly we use MEPs, SSEPs, and a triggered EMG, especially in the intraoperative setup. So the positive predictive value and negative predictive value are very good in this. And how effective is the IONM? As this is almost good, around 93% is effective. So is it when it is appropriate, even before ongoing monitoring or time specific assessment or ongoing and monitoring during the surgery? It's almost every time it will be useful. So you can done in the preoperatively and during the intraop. And So the neurophysiologist is a must. And can we do the monitoring in less than 2 years? Yes, we can do. But most of them, they'll say that because of the myelination, there will be a problem. But even, I mean, I use like almost all these cases, especially the lumbosacral and all these, the voltage will go high. Like nearly MEPs, we will get at 300 and 350 in a regular patient, but here it is around like 600 and 670. And is it much reliable? Like some false positives will be there, but it is still reliable. And this is how we will place on every patient. I used to place all these 10 muscles on the one side and 10 muscles on the other side, and MEPs, SSCPs. This is my routine practice. I do for every case. Every case means like spine, I do for every case, and intraoperative like cranium depends on my choice. So, sorry. So like this, we do on the muscles, hand muscles, and then the foot. Then even in the previous, I showed the even putting it in the, I mean, in the anal sphincter and bulbocavernous reflex. So, so what is this? Like dorsal columns, we will check the SSCPs, and this is the upper limb one, and corticospinal tract. We do the MEPs basically, and so spinal cord, the blood supply is totally different. So dorsal columns doesn't give much importance, and only like the MEPs are much more better than these. So this is the triggered EMG. Generally, we will put in a rotor out 0.1 or 0.2 to a 1, and then we will check it. And generally, if nothing is there, then we will feel very happy that nothing. I mean, we are doing safely. And SSCPs, as I said, this is the upper limb trace, and this is the lower limb trace. This is MEPs. So spontaneous EMG we always check, and along with that, the triggered EMG also we will check. I check for every pedicle screw, and we check. I mean, like around like a 30 milliamperes or so. I'll check. I'll start with that, and I'll come down up to 4 to 6. And like if anything is less than 7, I feel that there is a breach, and definitely I have to remove that screw and need to place it. So you are seeing that the dorsal rami branch is doing, but in the triggered EMG, the down, whatever you are seeing here, this is the triggered EMG, and it doesn't make it. Sorry. So this is a case. I want to show you like before positioning and after positioning. Like this is the OPLL with the severe cord compression. So severe cord compression. So the TOF is one of the most important, one of the important thing for the anesthesia checkup. And then we will position the patient. I mean, first we will do on the supine position, and then we'll go on to the prone position, and once again we will check it. And based on the MEP recordings and based on those the changes, we will adjust the position. That's one of the most important thing here. And once we are done, then we will see the post positioning. Everything is same. Then upper limb SCCPs and lower limb SCCPs, and this is the lateral mass screws. Even the lateral mass screws also, if anything is less than 7, you should change it. Here I don't have much time to show, so I'm skipping this case. The rest of the things are the same. So even transcarticular screws are this. This is the post-operative outcome. And another case is this is for the lumbar. The same. It's everything is the same. So we'll place the retractor, and then we do the surgery. Minimally invasive surgery, MEPs will be checked. For everything like 15 to 30 milliamperes, we will check. Here, if you see, I did the over the top decompression in these two levels, and the patient is that's so introphysiology always, and another one is the spinal cord surgeries. Generally, spinal tumor surgeries. are the most important thing. So this is the placement of the D-wave monitoring. D-wave monitoring and MEPs are concurrent. I mean, if they are both concurrent, and you will not feel anything bad. Like most of the times we will have a lot of fear, but once we do the surgery and both are present, then you can say like happily what's happening. Yeah, you can say very happily that nothing is happening there. Everything is good. And you can say even before the patient moves the limbs, you can say yes. So if MEPs are gone down and D-wave is present, still the patient will recover in 3 to 6 weeks. And if MEPs are gone and D-wave is gone, I never had that occurrence, but in the literature they'll say remove the total tumor because already function has gone. So this is another tumor. I think my time is over. Thank you. Thank you very much.
Thank you so much, doctor. A quick comment or question from the audience. I have one quick question. Any of the previous two speakers, are they using intraop monitoring? Because the more minimal invasive and more robotic you go, do you feel the need for monitoring or no need for monitoring?
Yes, in selected cases, you should still use monitoring. There is a severe cord compression, dorsal cord compression, like one in thoracic spine, which I showed you. We did monitoring. Another, just a comment for this. I mean, um, we use head caps for all the operations. We found head cap was not used. So whether that is a common practice or
No, no, no.
what
I'm always bald.
Thank you. I think we can go on to the next speaker. Thank you.
Thank you, sir. Thank you very much.
Yeah. The next talk is going to be online. You can have the video up, please. 8 years experience of intraoperative 3D imaging coupled with navigation by Dr. Frank Hertel from Switzerland. Okay, he could not come because he couldn't get the visa last minute. I believe. Recorded one is there today. Video present.
Dear Dr. Panikrai, dear organizers, dear colleagues, thank you very much for the possibility to present our experience with intraoperative 3D imaging devices over 8 years at your wonderful conference. Unfortunately, it is not possible for me to present personally because of a technical problem, the e-visa. For this talk, I have nothing there. My working place is in Luxembourg, which is a very small country in between Germany, France, and Belgium, in the center of Europe. Our department serves as a national reference center. We are mainly treating patients from Luxembourg, but also from Belgium, Germany, and France, in an area of about 1 million people. For intraoperative navigation, you can either use preoperative imaging as CT scan, MRI, or fluoroscopy, or you can use real intraoperative 3D imaging devices. For this type of imaging, in principle, 3 different types of devices are available. Number 1 is the fluoroscopy with a 3D option. Number 2 is CBCT, the cone beam CT, I will speak about in the next couple of minutes. And number 3 is the so-called fan beam CT, which resembles more to a classical CT scanner. With this kind of devices, you can do intraoperative 3D planning as well as a 2D or 3D control of the position of your implants and the final control before the end of surgery. In our institution, we have 2 intraoperative CBCT devices available. Number 1 is the OARM2, which runs with the Medtronic or the BrainLab software. Number 2 is the LoopX device, which runs only BrainLab software. If you use the OARM2 together with the BrainLab software, then you have to make a co-registration of the images by using the universal tracker simultaneously to an additional tracker which you could place on the skin of the patient. But in this way of co-registration, the accuracy is almost as good as if you use the device together with the Medtronic navigation system. In means of the applied irradiation dose, the cone beam CTs give much less dose as compared to a fan beam CT or an ordinary CT. Within the cone beam CTs, the dose which is applied by the LoopX is much less than the dose which is applied by the OR. This slide shows again the low dose as applied by the LoopX. In this slide, you can see 3, in my opinion, important technical characteristics of the LoopX. One is the relatively low weight of about 500 kilograms. The second is the robotic junction, and the third is the relatively large field of view. Both latter characteristics I will show later on during my talk. One difference between the 2 systems is that the O-arm can be opened. Therefore, you can use for the positioning of the patient, for instance, a so-called Jackson table, which is not possible by the LoopX, which is a closed system, circular system. A second important difference between the 2 systems is the opening of the inner burr. So the LoopX is much wider internally as compared to the OARM2. Here you can see a typical intraoperative situation with a spinal percutaneous stabilization procedure by using the OARM2. The system has a sterile draping, but you can also see the space is relatively narrow. In this slide, you can see the LoopX. The system can be operated via a wireless tablet and driven automatically without somebody has push this. Here you can see a typical setting for cranial procedure with the LoopX on the left side, which shows a sterile draping, which is available for this system, but very expensive. Therefore, as you can see on the right side here for spinal procedure, we use it in a different way with our own draping. In Luxembourg, a radio technician is obligatory for the intraoperative operation of CBC. Here you see again a typical setting with a relatively wide space for spinal procedure with LoopX system. Additionally, you can see here the exoscope in place for percutaneous stabilization procedure. We have an increasing activity of the intraoperative 3D imaging since its installation. Since 2022, we have a second system operating, which is fixed. Actually, we are performing more interventions fixed as compared to OR. That far, we have performed almost 900 stabilization procedures with the implantation of over 5,000 screws in different regions of the adult and pediatric spine. Among those, we had less than 1% revision surgeries for screw correction. Average, we had 2.9 intraoperative 3D scans. Patients that had to be revised were because of pure image quality, because of a BMI, or because of physiological unstable situations. In cervical spinal procedures, even in anatomically difficult situations, as is shown here, you can reach with intraoperative CBCT sufficient images to place your implants in a safe manner. For this kind of interventions, we use a combination of carbon Mayfield clamp together with a universal tracker, which is placed at the clamp. In our series of about 150 cervical spine procedures, we have only 3 revision surgeries. Operative quality. With the CBCT, you can also match your preoperative MRI scans on the intraoperative 3D image. This helps especially for tumor surgery and is enabled via nonlinear co-registration. This is possible with both devices. We found that for the implantation of cages or also for tumor surgery where you need intraoperative microscopic view additionally, that the replace of the microscope by an exoscope together with LoopX is a very helpful combination because you can see here the exoscope which you could leave in place during the procedure together with the intraoperative scanning device, which is not possible. This is showing the whole setting, so this can be used for TLIF, OLIF case. You could use also the device for intravertebral tumor biopsy. This could be done under general or under local anesthesia and gives reduced dose as compared to classical. Percutaneous tumor ablation procedures. The device is also very helpful, especially if you do multi-level interventions. You save a lot of time and reduce the dose for the patient, but also for the staff significantly. The same is for percutaneous balloon kyphoplasty procedures. We use arthroplasty, as you can see here, especially if you use it in multi-level procedures, then you can save time and dose for the patient. Intraoperative CBCT can also be used together with navigation to plan the approach for endoscopic transforaminal disc operations, especially in L5S1. The planning of the approach with the navigation is helpful. Here you don't need to have a second incision to place the universal tracker. We are just suturing it on the patient's skin. So here you can also reduce the OR time significantly in this procedure. Last slides, I would just like to show very quickly, according to CBCT stereotactic surgery, use it now on a routine base for deep brain stimulation procedures. You can do the planning by using the intraoperative 3D scan Can also use it for the postoperative final control of the electrode and carefully evaluate the electrode position. This video, in means of time, I have to skip. To conclude, we have a reduced revision rate and risk for spinal screw placement. We have reduced dose versus intraoperative real CT and also versus percutaneous intraoperative X-ray. We have a zero irradiation dose for the staff. Scanning and verification is possible with the device. Postoperative often not necessary. We have reduced OR times for endoscopic disc operations as well as for percutaneous tumor ablation and balloon kyphoplasty or hybrid treatments. The matching with nonlinear co-registration for tumor resection we have.
I think this is not a talk, so may I invite the next speaker, who is none other than one of my best ever residents at National Institute, Komal Prasad, lead neurosurgeon at Narayana Hridayalaya, going to talk to us on optimizing spinal surgeries with technology, accelerating. Mic there, no? Yeah. Okay. So Komal Prasad is the lead neurosurgeon at Narayana Hridayalaya. He was trained by S.H. Sri Chitratirunal Institute of Medical Sciences, one of my best ever residents ever.
So thank you very much, sir. Thank you. Thanks for that. So good morning, everybody. I once again thank Manas, Savitra, and team for organizing this beautiful event. So my talk is the theme of the conference, that is optimizing spinal surgery and what is our part in accelerating innovation. We just missed Dr. Kulkarni's video, so I have a short video on the robot which we recently acquired, again the MeasureX. I'll just run it quickly. That's the robotic arm. The registration using WOARM. Planning and safeguarding the interdural structures. Then we can plan the trajectory. Then the arm takes us there. And it will be sort of real time because even the image acquisition is on table. So it's a WOARM image. So the roadmap will be there and the screw as it passes real time we'll be seeing. So that's a short video of MeasureX, and we are getting bombarded with technology. And much before we realize, when we are busy in OT, many things are happening. Even when the flyover comes in the city, we'll be knowing it 3 to 5 years ahead. But when new technology comes, it will catch us unawares. So what is our role, and do we have any say? Should we passive users, passively utilizing the technology which is bestowed on us, or should we have a say in how the technology and what's the technology which reaches us? That is the theme of this talk. So it boils down to innovation. So what is the innovation? Where does it come from? And what's the structure of innovation? Is there a structure, or is it always serendipitous? So scientifically, if you go, actually there is a structure, a process in which innovation happens in all the great places. So we'll come to that, and this is something which was initially started by the design school of Stanford. So what is that design thinking is something which I'm going to touch upon today. So we are in a changing healthcare scenario in which technology gatekeeping has moved from physician to patients to insurance and government agencies. We are following a different hierarchy when it comes to technology gatekeeping. Until recently, the other thing what has happened is, whatever may be the cost, anything new was acquired and with open arms. Not anymore. Technical wizardry alone is no longer enough in healthcare, because people ask small incremental benefits with huge costs or a strict no. So innovators have begun to respond accordingly. And yesterday we again saw this hype cycle, so where there will be initial enthusiasm. And whenever any new technology comes, we have to remember this graph where we will be in the upward curve, we'll reach a stage where it gets a maximum publicity value, but then slowly that interest weans off, and then it reaches a plateau, but always much higher than the initial level. So that's the curve, Gartner curve, which is a life cycle of technology. So coming to innovation, innovation is not just new invention, it's invention plus adoption. So there should be human values, there should be human need and desirability to use it, and it should be technically possible. Like yesterday we saw AI. With AI, many things are technically possible, but not everything is, there is a need for it. There is no desire for it. But what is doable, possibility is immense. So in that intersection of human values and technology, as well as some business viability. Otherwise it won't stay, it just stays in our minds or in our limited sphere of influence or in the few papers what we publish. So an element of business viability is also required for a technology to succeed. So coming to design thinking, it's a human-centered approach. It starts not in the minds of the inventor, but what he observes and sees as a need in his place of interest. A human-centered approach to innovation. A creative problem solving. Most of the big industries, most of the world's leading companies, whether it's World Bank, Google, Apple, have embraced this new process to innovate. And as usual, healthcare is slowly getting there. So we have that skepticism as with any other technology, any other method. But it's high time we get into there. High time to utilize design thinking in healthcare innovation. There's a huge potential for adoption of this process for innovation in neurosurgery and spinal surgery. We have a responsibility too. As Cushing once said, I would like to see the day when somebody would be appointed a surgeon somewhere who had no hands. To stress on the fact that the operative part is the least part of our work. We have bigger responsibilities also. To our team, to our community of surgeons as well as the society in general. I'll give an example of one Dr. Senthil Kumar, a radiation physicist in Madurai. From Tamil Nadu, you would have heard the recent news, where he was bogged down by the fact that these lead aprons are heavy. So he created a mixture of chemicals using bismuth, barium sulfate, and antimony, which is lightweight, which is more elastic, it won't break easily, but it is radio resistant, in place of lead that can be used. So he identified an important product which is of regular use, understood its limitations. He defined what's the challenge. It has to be lightweight. It should not wear and tear and should not be there. And brought in a new technological innovation and brought a delight to the end user. So this in brief is with an example what I mean by design thinking, which is possible in each one of our workplaces. We need not have technology to begin with. It's the way we think about the problem. So this is the standardized methodology by Stanford University design school, which says the first part will be to empathize, be in the shoes of the end user, then define the problem, ideate, brainstorm, and then create a prototype quickly. With this 3D printing technology, for example, we can prototype quite easily and then test it and then see if it is viable. The underlying thought what I'm telling is when we have this kind of thought process with every case and with every day, when we have hundreds and thousands of ideas, some of them will click. It's not that each one of the idea will materialize into something new, innovative, which will have an impact around the world. So I find out what the world needs, then I proceed to invent it. Or if you want to have good ideas, you must have many ideas. So these are something, the quotes which I want to give. And more interesting is Ford's quote, which says, if I had asked my customers what they wanted those days, they would have said, we want better horses, faster horses, or more arms in my robot, or now arm and what next. So, but because we have limitations in our thinking, so we have to observe and see how we can provide a car when people are only used to horses. How to do that? This new innovation happens at the junction between your specialty and the next, whether it's head and neck, whether it's radiotherapy, whether it is oncology, urology. So these are the examples. And they are no strangers for us. Talk to strangers, meaning the out of your comfort zone. Jump into the deep end of the pool, which you're not used to. Let your mind wander. And we are used to playing with sharp instruments, literally. This is coming to some examples what I gave. So it's not technology intensive. It's our frame of mind to think that way. So this we have used 3D printing, having like personalized implants, using exoskeleton. So these are some, it's a Bangalore startup which has created an exoskeleton with a little bit information from the clinical side from us. Observe. So observe like this nurse who has used a balloon inflated with air and kept there as a device to keep those tubes separate. Simple technique. There we are seeing an extreme user where there's a need, a lightweight thing which can be used. So these are something, this observation, quiet observation is very important to innovate. This group, BHS from Germany, observed that microscope usage of 3 hours or more per week was associated with cervical and thoracic pain. What they did, they dissociated the eyepiece of the microscope from the microscope to the surgeon's eyes directly. When you see there's no contact, neck is free. So this is innovation by observation. Rapid prototyping, it need not work like this thermocol prototype which was made for hand grip weak patients to see whether an iPad with bigger fonts is useful. Again, this rapid prototyping to level our lumbar drain, our external ventricular drain. So these are the various stages. I am giving examples from each stages of how the process of design thinking happens. And one practical example which all of you can use is how we use the Surgiflow kind of things. We started using gel foam with a little bit of blood and mash it up like this and use it for venous bleeding. It works wonderfully.
Normally, you have to
Yes,
conclude.
yes, sir. So we need to have a mindset of innovation, and that's how we get into truly disruptive technology. And it should be a viable business model to make it available all around the world. And 1 in 100 might click, 1 in 1,000 might click. But every day, if you go with that mindset, someday, someplace, we'll be innovating things quicker, faster, right around us. And we'll have those, we will know when the flyover is getting started, and we won't be taken aback by surprise when technology hits us. So start innovating. We, as neurosurgeons, spinal surgeons, we have to involve in the process of innovation. It's our responsibility. We have to take a leadership role. Thank you very much.
Thanks, Komal. Thanks, Komal. Very innovative talk. We have overshot time. May I call the next speaker, Umesh Sriganda from Bangalore. State of the art, single position, lateral fusion, intersection of spinal surgical technologies. Umesh. Umesh is here.
Yeah, I'm here.
Yeah.
I'm here. Hi. Yeah. Good morning, everyone. Once again, thank you, organizing committee, for giving me this opportunity and honor. Respected chairperson, teachers, senior colleagues, dear friends. So, my topic today is single stage lateral position OLIF. Now, among the wide repertoire of interbody fusion techniques that are available, the TLIF, the posterior approach, the TLIF and its younger and better counterpart of MIS TLIF, still are considered a gold standard in approaching the spine and doing an interbody fusion. But how much have we really benefited by converting from an open TLIF to an MIS TLIF? If you see the amount of invasiveness that we cause to the area of pathology, that is the dura, the nerve roots, is almost similar. The amount of decompression, fascectomy, interbody work, everything is similar. So the only thing that we have reduced is the amount of paraspinal muscle damage. And that is where the lateral approaches come into the picture, where the nerve root handling is not there, the peridural approach is not there, there is no epidural adhesion, post-op radiculitis, dysesthesias, all these complications are taken away because the spine or the disc is approached from a completely virgin area, from the lateral area, from the retroperitoneal approach. And that is why there is no paraspinal injury, along with all the other advantages that I just mentioned. What are the additional advantages? Now, lateral approaches or OLIF is the only interbody fusion technique, apart from the recently introduced KLIF, of course, which preserves all the ligaments of the spine, the posterior tension band, the posterior tension band, the facet joints, the ALL, the PLL, all of these are preserved, and it is just a spinal remodeling rather than kind of any kind of a direct decompression. We call this an indirect decompression. And so how does it help? In the presence of a listhesis, by distracting the disc space by ligamentotaxis, the deformity or the listhesis is reduced. In a canal stenosis, because of distraction, the bulging disc as well as the buccal ligamentum flavum are stretched and the canal opens up. And in a degenerative deformity, where the primary pathology itself is an asymmetric disc space collapse, by causing an uniform interbody distraction, the OLIF can achieve an excellent coronal as well as a sagittal correction in these particular cases. Now, apart from all these advantages, obviously there are limitations to this technique. It cannot be used in facet arthrosis, osteophytes, capsular calcification, and because the primary objective is disc space distraction, anything that is going to limit us from doing that, or any pathology that is not going to get corrected by just distracting the disc space, is not a good case for an OLIF in this case. But what many people, even in suitable cases, consider as a disadvantage, it's a two-stage surgery. The patient has to be in a lateral position, you do the OLIF from the left side, and then you flip the patient again to put in your percutaneous screw, which is again required. So I'm going to tell today about our experience in a single-stage lateral position OLIF, where we can do both the percutaneous pedicle screw fixation as well as the retroperitoneal approach in the lateral position itself. The positioning similar for an OLIF. The patient has to be at the edge of the head, the back has to be at the edge of the bed to facilitate the right side screw trajectory, which is going to come from below to up direction. It has to be neutral, because if the spine is curved in the lateral position, again, we may end up fixing the spine in the curvature position. Adequate strapping has to be done to facilitate a little bit of tilting to facilitate when we are putting the screw from downwards on the right side. The approach is similar. The incision is 5 to 8 centimeters anterior to the midline. You go through the abdominal muscle layers. You sweep the retroperitoneal contents and the retroperitoneal fat anteriorly. Go to the psoas, identify the anterior border of the psoas, identify the psoas, and identify the gap between the anterior border of the psoas and the vasculature, and enter the disc through that area. Now, we have to understand that this is the trajectory that we are coming in. And if we try to put in our cage directly through that trajectory, it goes into the contralateral foramen. And that is not a good thing that is going to happen. So we have to change our trajectory, which is called an orthogonal maneuver, in order to facilitate putting the cage in the longest axis of the disc. And that is what is being done here. So we go in oblique, and then we straighten up as we are going into the disc space, so which is called an orthogonal maneuver. And this orthogonal maneuver has to be done at every step, during the disc space preparation, during using a COBS, during using a disc forceps, during trialing, during final cage insertion, during all these things. So this is again a video, again simple case, type 1A listhesis that I told like yesterday, with canal stenosis and instability. Patient is in lateral position. We do an O-arm. So the O-arm is brought in. We put a percutaneous perc pin into the posterior superior iliac spine in the lateral position. At the same time, we aspirate some marrow blood, which we are going to use for the cage. This is the lateral position pedicle cannulation, which we are doing under O-arm guidance. So initially we put the guide wires in, because once we distract the disc space, the relationship between the vertebral body changes, and it may cause an error. The advantage of this technique again is both two surgeons can work simultaneously, one from the back and one from the front, where we can start the anterior retroperitoneal exposure while the pedicle cannulation is happening on the other side. So this is splitting of the abdominal muscles, internal oblique, the transversalis, and then you go into the retroperitoneal fat, sweep the retroperitoneal contents anteriorly. You may visualize retroperitoneal structures, which can be swept anteriorly. Identify the anterior border of the psoas. Sometimes the genitofemoral nerve or the ascending lumbar vein can be encountered, which can be tackled accordingly. So that is the disc space. So we can use navigation to identify our trajectory, what is the direction in which we are going, what is the depth in which we are going. It determines the extent of disc space preparation, the direction of disc end plate preparation. But the adequacy of end plate preparation is again, as done in a posterior approach also, is with a tactile feedback, the end plates being removed. And once that is done, so we can use an appropriate size trial, identify what is the correct size for that particular case, fill it with a allograft that we get from a cadaver bone bank, and I told that we mix it with the patient's marrow blood, because we don't have any bone here. We don't remove any bone. We have to use an allograft, an external source for the graft, and the cage insertion can be done. So most of this procedure can happen under navigation guidance. Only few times we'll need to take around 2 to 3 shots of the C-arm just to confirm that we are in the right position. And after that, once the anterior interbody cage is placed, we can put a percutaneous screws from posteriorly. And this is the end result. So you can see that the listhesis is reduced, the canal has opened up, and all this without removing any of the structures. It is completely canal remodeling. So this is the intraoperative image where you can see the screws are there from behind. By the time one side, one level OLIF is done, the posterior percutaneous screws have already been placed. OLIF helps in achieving a very good disc space distraction as well as lordosis. And even in tough cases, usually in these cases where there is bone on bone, we do a full extension lateral view where we can identify whether the disc space is distractible or not, and OLIF can be done in these cases. OLIF is actually a boon for degenerative deformities. Multi-level deformities can be easily corrected. It's not at all difficult. Unlike we do it from a posterior approach, it is all minimally invasive, hardly 200 to 300 ml blood loss, and posterior percutaneous pedicle screws can be done in the same approach. Even in complex deformities where apparently there is a thoracic hyperkyphosis, just restoring lumbar lordosis is enough in actually recreating the curvatures in the upper spine. But what about L5-S1? So we know that even in L5-S1 this can be done, and this is a new approach that has been becoming widely popular nowadays from an anterior approach. This is called a lateral ALIF, which is the cage is still put in an ALIF position, but it is in the lateral position. Again, a short video. So this is the incision is slightly more inferior. So that is the retroperitoneal approach. Again, so we sweep the retroperitoneal contents anteriorly, identify the iliac vessels. Those are the iliac vessels that we are seeing there. Dissect in front of the iliac vessels to reach the L5-S1 disc space. We have to be very careful to avoid any injury to the common iliac or an internal iliac vein that is going to come there. Minimize the use of any kind of a coagulation to reduce the injury to the hypogastric plexus that is there, and then identify identify the disc space, remove the disc contents, and then put in a appropriate size trial and cage. So once we do that, again in a multi-level approach, it is very easy to actually go superior. So we just jump across the vessels, and then we can go to the upper level, that is L4-5, as we can see there. So these are some intraoperative images that are there. We have also done some endoscopic approaches in the lateral position where there was an acute disc prolapse at another level and a listhesis at one level, as we are seeing in this particular case. And this also can be done. We can do an endoscope through an anterior approach as well. Because of shortage of time, I'm going to push through. I'm going to run through these slides where we can use an endoscope from the front to remove any intradiscal pathology, which was considered a major disadvantage for OLIF because you can't approach any pathology that is inside the canal. So you can use an endoscope and then put in your cage like we do it. So this is one of the case example, operated twice. This is a acute disc prolapse, and the disc can be removed from the front itself. So this is our experience. We have done 75 cases in this single stage lateral position, 92 levels. We are in the process of publishing that. There's no clinical data here as of now. So this is the take home message. Outside the OLIF is an outside the canal, outside the muzzle approach, preserving all natural structures. Superior coronal correction can be achieved better than any other LF technique. It achieves good lordosis preservation. It's faster, safer, and less blood loss, especially when we are doing a multi-level disease. Thank you so much.
Thanks, Umesh, for that excellent presentation. Any comments, please?
Excellent presentation.
Thank you.
Is there a long-term study to know the fusion of the OLIF and the compared to MIS TLIF? Because as you know, the bone graft what you use in MIS TLIF, significant bone, we use all the facet, whole facet is taken off. If you do a bilateral facet, a good amount of bone is there. We fill the whole disc space with the bone and then put the cage as well. But here you're just filling the cage with the cadaveric bone graft.
So-
This thing. Is there a long-term?
So the basic principle, obviously, there are studies, and the studies have also shown that the OLIF achieves fusion. The nearly 80% of the patients had fused by 6 months, whereas only 60% of patients had fused by 6 months in an MIS-TLIF. But at the end of 9 months, the fusion rates were similar between OLIF and MIS-TLIF. So the fusion rates are not inferior, but in OLIF, the fusion rate happened earlier. There are several reasons that have been described for this. Number one, because we are just talking about the surface area. The fusion happens so when the graft is in contact with a larger surface area of the end plate. And here, even though we are saying that the graft is inside the cage, the surface area is quite big as compared to a TLIF cage where the graft is very small. And that is why we emphasize that in MIS TLIF, we have to put more graft outside the cage in order to increase the fusion
sometimes two
surface
graft
area.
as well, yeah.
Here, the fusion surface area is more within the cage itself. And that is why the fusion rates are not inferior as compared to an MIS TLIF. But studies have already shown that fusion happens much more earlier in OLIF as compared to MIS TLIF.
Thank you.
Thank you, Umesh.
When would you consider not doing an OLIF in an osteoporotic patient? At what T-score?
So if the T-score is very, very low and there is a degenerative deformity, obviously, we don't try to correct that immediately. So usually now studies have shown that even 1 month of teriparatide preoperatively makes a significant difference in the intraoperative or postoperative outcome and intraoperative bone screw purchase. So at least 1 month of teriparatide is given, but ideally at least 3 months if the patient can wait. Ideally 3 months of teriparatide in an osteoporosis where there is a deformity that needs to be corrected. But in the case of a reducible listhesis, in the case of a patient where the amount of screw-based work or deformity correction is not significant, we do go ahead. And as I already shown in one example, we use augmented fixation from the posterior single-stage lateral position itself. We can put cement through the screws and improve the screw purchase and prevent any kind of a post-operative complication.
We'll move on to the next talk.
Thank you.
Thanks, Umesh. Dr. Prakash Moda to speak on use of ultrasound in spine surgery.
Good morning, Chairperson, and my dear friends, Manas and Savita, to give me the opportunity to present this simple paper, but useful in our day-to-day life. I'm Dr. Prakash Moda. I'm from Rajkot, and this simple paper about the ultrasound, it was a Christian Doppler who is from Austria. He developed the Doppler effect. He was born in 1803 and died at the age of 49 years. So, the consequence of the Doppler effect on the relative emitted frequency of an ambulance siren as it drives by. Frequency of the approaching ambulance siren appears higher. Compared to the frequency of the siren as the ambulance passes by, which appears lower. These are the machine we are using. This is the PK500. The machine we use frequently for our spine surgery, and the stand nearby the machine is a Mesonic scusa and bone scalpel. So these are the commonly used machines in our operation theater. This is our operating team using the ultrasound. Now I want to tell you something more about the probes we use in the ultrasound. The number one, this probe is for deep penetration, enabling the overview of lesion and anatomy and helping in to precisely remove the lesion. The next probe is a very useful and commonly used to guide burhole procedure with precision, including shunt placement and taking biopsy from the deep-seated lesion. This is very important probe, which is a flexible probe, and it can be used in the cranial resection as well as in the spine, and it has a tip which is flex 0, 30 degrees, 60 degrees and 90 degrees. And the last smallest probe is for the endonasal skull base and spinal procedure. Now I'll show you few cases. This is the patient with a L5S1 disc migrated upwards, and this is the ultrasound images where there is a tone of the annulus fibrosis, and you can see that after the removal, the annular fibrosis unites and cord become straightened. This is the another good instrument called bone scalpel, where we can mark precise incision for the microlumbar discectomy. You can see the incision in the lower lamina, and this is the medial facetal incision. Very precise cut, you can do it. This is another case I am showing for the laminoplasty. After surgery, this is very interesting case, that there is a pathological fractures of L2 burst fractures, and the burst fragment is into the spinal canal. So the ultrasound shows that there is a bulging of the fragments into the spinal canal, and once you remove it, the spinal cord get decompressed, and the patient recovers very well. Similar thing for the OPLL in cervical region. You can see that there is a gross compression of the spinal cord. Here also you can see, and after surgery of laminotomy, we get good decompression and good recovery for the patient. This is intramedullary spinal cord tumor of the cervical region, where sonography shows this type of lesion, and after surgery, you can see that we have removed the tumor practically completely. And very important thing for our country, for the children with Chiari malformation. This is the paper from Brazil, my friend, and Roger Brock and Mario Augusto. They have published from the University of Sao Paulo, saying that patients underwent decompressive surgery with or without opening of the dura mater. After intraoperative USG measuring flow rate, they come to conclusion that a value of 3 centimeter per second CSF flow rate was considered to be a cutoff. So they wanted to study that they should open the dura or they should not open the dura. So if the CSF flow more than 3 centimeter, then they need not open the dura. So this is very important paper and very well described. Another important use of the ultrasound is, this is the CT showing psoas abscess. This is the psoas muscle, and you can see that pus in the psoas. We can drain it by using the ultrasound. This is another ultrasound of a median nerve where there was a tubercular abscess, and we remove the abscess, we plant the sural nerve graft, and patient recover well. Another common use is in the intrauterine life. We say spina bifida occulta, meningocele or meningomyelocele can be diagnosed with the help of ultrasound. In conclusion, sonic ultrasound is very useful tool in spine surgery, It is good for soft spinal cord tumor, OPLL, prolapse intravertebral disc, peripheral nerve tumor, peripheral nerve abscesses, and meningomyelocele. The most advantage of this thing is the real-time images and very easily available and can be accommodated in the operation theater. There is a short learning curve for the interpretation. It is reasonably cost effective. If you consider intraoperative MRI, intraoperative CT, and you consider intraoperative ultrasound. So ultrasound is the cheapest mode and which is can be used in periphery or small towns, small cities also. So it is cost effective and most important, there is no radiation. So this is the thing which ultrasound makes the difference in our life. Thank you very much. And herewith, I will invite you all for the Nasikon Rajkot 2025 on 28th of February, 1st March, 2nd March 2025. Please do come, enjoy our hospitality and enjoy the conference. Thank you very much.
We will be there, Modaji.
Please do come.
Thank you for finishing in time. Any comments? Please. Make it simple, fast, quick.
Sure. Excellent. It's really very, very useful. Our pain colleagues use the ultrasound guided injection. I had the patient was pregnant for about 13, 14 weeks with cauda equina. The first time we used the ultrasound to define the L4-5 level, and it was accurate. So even you can define the spinal level without radiation in such conditions.
Yeah, correct. Absolutely correct.
If they, please. Any comment, please? Varnan, please, quick.
Permission. You need a PCP and DT license.
You have to
Neurosurgeons cannot use this ultrasound in OT until they have this license. Otherwise, one can get arrested. So please note that because they will come directly and arrest if you are doing it without the license. So please get the license first. Use the radiologist, get the license, and then use it in the OT.
Yeah, we are using the same thing with a license. But you see, when there is a one ultrasound in the hospital, so they don't give usually permission to take it to the operation theater. So we have to buy separate ultrasound. Yeah, correct.
Okay, thanks, Varnan. Thanks, Modaji. We go to the next talk, the last talk of the session. May I invite my dear friend, the one and only Atul Goyal, formerly head at the prestigious KEM, presently working in Leelavati Hospital, Cooper Hospital, and Somaya Hospital. He's going to talk to us on his favorite topic, vertical instability, central endoaxial. Atul Goyal, stage is yours. Finish 5 minutes before 10 o'clock.
Thank you very much. It is indeed my big pleasure, great honor to be a guest of Manas and Savitra, and of course, my chairman, sirs, sitting here. I am going to present to you a revolution again. Central or axial, believe me, I have no hesitation to say it is a great move in craniovertebral junction surgery. Understanding this issue, understanding the concept that compression is not the issue in spine surgery, in the entire spine surgery. Of course, I don't have too much time to elaborate on this. And decompression, what a statement to make, is never the treatment. So this is the concept of vertical spinal instability, the concept of telescoping of the spine, and the concept of central or axial atlantoaxial instability. This is a great move in expanding the horizons of craniovertebral junction surgery, and it has implications in a lot of issues like Chiari for syrinx and for various other issues. I have talked about this quite a number of times. Whenever you talk of instability in craniovertebral junction, you talk of odontoid process, you talk of compression. So we had introduced in 1999 the facetal instability. And then we said that instability is the issue, stabilization is the treatment. There is no need for decompression, which was done commonly at that time, transoral decompression. The other move that happened was, even when there is no atlantodental interval disturbance, the facetal instability can be seen by analyzing the facet on lateral profile imaging, lateral neutral profile imaging, and stabilization is the treatment. This kind of basilar invagination is still treated by decompression. Even when there is no facetal malalignment, no atlantodental interval treatment, instability is the issue and stabilization is the treatment. Compression, when there is no compression, these two entities are called central or axial atlantoaxial instability. So chronicity is the issue. Chronic atlantoaxial instability leads to various secondary manifestations which are not pathological, which are protective, which are reversible, which are indicators of atlantoaxial instability. So basilar invagination, syringomyelia, Chiari malformation are all secondary issues to atlantoaxial instability, and stabilization is the treatment. And as you know, when I made this statement about 10 or 15 years ago, there was a lot of discussion in Journal of Neurosurgery, in World Neurosurgery, several letters to editor that many of you must have read. And over the years, my things have become more stronger for me, and I have written several articles on this subject. Like basilar invagination of all kinds, instability is the issue, and stabilization is the treatment, whether it is group A or group B. There is no role for decompression. When you see Chiari malformation and syringomyelia, there is absolutely, if you have confusion, don't keep that nonsense confusion in your mind. Instability is the issue. Whether there is facetal instability or not, whether there is compression or not, stabilization is the treatment, and absolute magic is the clinical result. This is my experience about 4 or 5 years ago. Now it is close to 600 cases. When I talk with experience of 600 cases, you better listen. If you cannot listen, come to my place and I will show. Don't do decompression. And I have no hesitation to say it is a negative form of treatment. So Chiari is secondary to chronic instability. It is protective. Cervical fusions are protective. No compression, but it needs stabilization. Bifid is secondary, it is protective. There is bifid here, there is no compression, but it needs stabilization. Syringomyelia is secondary, it is protective. There is no compression here, it is secondary to chronic instability. Stabilization is the treatment. Short neck, torticollis, kyphos, a whole lot of problems. Instability at the atlantoaxial joint is the issue. Short head, short neck, these are all secondary issues. You try to learn C1, C2 fixation, and you have the potential to create magic. Even issues like kyphoscoliosis, central atlantoaxial instability is a very frequent cause. Stabilization of C1, C2 is the treatment, and that is a magical form of treatment. Now, today I want to introduce another beautiful thing. The role of dynamic imaging. See, when I used to do for Chiari, people used to object how you demonstrate C1, C2, how you can do C1, C2 fixation without demonstration of instability. Now I introduce to you another brand new concept. Dynamic imaging. You do imaging on rotation of the head. And I have got several articles which have been published, and several are already in pipeline. And I want to discuss this issue today. Carefully look at the title of this paper, Post-traumatic central atlantoaxial instability with atypical symptoms like brain fogging, trigeminal neuronoma, trigeminal neuralgia, vertigo, hemifacial spasm, visual problem, eye movement disturbances, and of course, limb weakness and things like that. Now, here is the patient, son of a minister from Canada. No compression, no problem in the atlantodental interval, no problem in the facet, and this is the patient. You see how he is walking on crutches, and he has been seeing all the neurosurgeons of the world. Many of you must have seen him. And this is the gait, and then he comes. You see this in a difficult situation. No facetal problem, inflection, extension. Then I do rotation. And you see the facetal malalignment. Here is one facet, here is one complete unstable, complete. So this is the role of dynamic imaging. And I do C1, C2 fixation. And this was the patient. And here is the post-operative. You see, in the after 6 or 7 days of surgery, I have not even removed the stitches. And here he comes to me. You see how he's jumping. And now you will see how he's running. And backward running. How many of us can do backward running like this? And I gave him a new life. And recently he sent me a picture where he did a boar hunting, and my wife got very angry. He said that he got a new life, but he has killed many of these donkeys and monkeys. So whether I have done a good thing or not. Another patient, you see this young girl having no compression, no facetal malalignment. See how she's walking. And also notice how the husband is taking care. You see how she is walking? And the husband is ready to catch her. You see, like in slips, you play and in the slips, the person is waiting to catch.
Okay, go back.
See what a difficult situation. This girl also visited several people all over the place. Nobody said, and various, all these patients of mine were on psychiatric drugs for several years. They were having painkillers morning, evening, and difficult situation. And then you see, I do rotation images. You see the facetal malalignment, and this is post-operative in the ward before she was discharged. And you see how she's running in few. This is a magic. This is a new life without any doubt. Little bit. Now you see this guy having no compression here, no compression, various symptoms, and advocate by profession. Let us see what he has to say.
क्या तकलीफ है आपको?
No compression anywhere, okay?
हाथों से चीजें छूट जाती है क्या?
हाँ, हाथों से चीजें छूट जाती है।
आपका राइटिंग चेंज हो गया है?
हाँ, राइटिंग भी चेंज हो गया।
So he has several problems. And I do, you see the image, complete facetal on rotation, and I have done various other images. And you see this guy now in the immediate post-operative period. This patient I did in my workshop, which I recently conducted.
हाँ, हाथ और पैर में बिल्कुल भी numbness नहीं है। हम work कर रहा है।
I gave him a new life, believe me.
Yes, sir.
You see how he's he's smiling and all. He was an advocate. He had lost his profession. He was being treated by psychiatry for various treatment issues like he was seeing brain fogging and all this nonsense. Another patient, you see no compression. You see the facetal malalignment on rotation images, and you see the fixation. And this is the patient. You see how he's walking, of course, my dear. And I will show you. This is the fixation I did. And here he is swimming in a very rapid pace. I cannot show you the video now because Suresh Nair is sitting here. But this is another patient. You see no compression, no problem. This is the patient after surgery, and you see the magic. Okay, now. Immediate after surgery. So compression. Don't think of, there are other issues which can create symptoms and massive symptoms. This is immediate after operation, and this is after about 2 or 3 months after operation. She's completely new life. Her husband had divorced her, and she was having a miserable kind of situation. And her brother hit her actually. This is another patient. You see, this is no compression, no problem. And I did dynamic motion x-rays and things like that. This is another issue which I had published long time ago. No compression, but presence of bifid, presence of serines is indicator of unstable C1, C2, do fixation, create a new life. And this is another patient. This is a patient, and she was an Olympian. She participated in ski Olympics. And during Olympics, she had an injury. And after that, for 10 years, she was just moving from with various symptoms like vertigo, urine problem, stool problem, pain here, pain there, pain everywhere in the body. And you see, in the immediate postoperative period, she is having both the hands up. See this hand here? And this is the shoulder, how it is drooping, and this shoulder. Now, to tell you, this lady is back in Olympics. Initially, she was a Canadian participant. Now she is participating as a coach in Finland. And this is the thing that she sent me recently. In short, decompression, decompression, decompression. Remove it from your mind. Compression, compression, compression. Remove it from your mind. Understand the situation, and I will worry about that.
Thanks, Atul, for that wonderful lecture. I am sure many of you will have some comments or questions. Yeah, at least Muthu Kumar has the courage. Yeah.
Muthu has been liking my presentations for a long time, although he has never referred any article of mine in his hundreds of presentations he has given in his life. So let us see what he has to say.
So you have discussed a large spectrum of anomalies, Atul. My comment pertains only to the atlantoaxial instability causing anterior and posterior spina bifida, right?
No, say that again. What? Atlantoaxial?
Atlantoaxial instability as the cause for bifid anterior and posterior arch.
Yeah.
Right? Now, I'm just putting this thought process out there. Can odontoid hypoplasia be the consequence of atlantoaxial instability?
I will say chronic atlantoaxial instability changes the body. You see, instability for 10 days or 15 days, I'm talking of instability for 20 years or 30 years. During that time, there are several secondary manifestations which are all protective, like Chiari, syrinx, bifid, os odontoideum. Os odontoideum is not an embryological issue or degenesis during fetal life. It is a secondary natural protection. It indicates unstable spine. You do fixation, that is the treatment. Similarly, odontoid hypoplasia in a selected situation is a result of chronic atlantoaxial instability. Stabilization is the treatment. Any kind of decompression, in my view, is nonsense.
I fully agree with you because there is one publication recently. I don't know whether it applies to all types of odontoid hypoplasia. Because of my interest in skeletal dysplasia and CV junction, I came across a publication where in children with mucopolysaccharidosis, the children are usually born as you must have seen hundreds of them. So they have odontoid hypoplasia, and the instability and compression are attributed to the hypoplasia. But this publication has shown within 1 year, out of the 15 patients, 12 patients had born without an odontoid, had regrowth of the odontoid. Irrespective of whether C1, C2 fixation was done or OC fixation was done. And 80% of them had regrowth of the odontoid within 6 months, which means one concept we have to probably rethink. All along we have been taught that odontoid hypoplasia is the cause for the instability. Maybe it is the consequence of the instability.
Thank you for referring this article, and thank you for agreeing me. In any case, you know what? Whether you have questions or not, whether you think I am talking a little bit lateral, better try to understand this, because this is the future. If you have doubt, if you want to do fixation, if you want to decompression for Chiari malformation, better learn C1, C2 fixation. And don't make a mockery with your patient, okay? Problem is, you know what? Problem is to do C1, C2 fixation in cases of Chiari is not easy. It's difficult. They are venous, they can be, you can overload in that area. Presence of syringomyelia, difficult to do operation in the lateral gutter. Presence of basilar invagination, presence of assimilation of atlas. They make the situation of exposure of lateral mass difficult. And that is why when it is difficult, we choose a easier path. Okay, let's decompress. World agrees. What, money same. Problem is reimbursement is the same. Whether you do C1, C2 or whether you do, that is of course.
Thanks, Atul, because Kulkarni want to show video quickly. 2.5 minutes for you. To finish a session where Atul is talking in time itself is a
Sorry,
great
this small
achievement
part
for
of
the young people. Yeah, please.
small part of my talk, which is a video of on the robots. I'm just showing, which is educational, and all of you are here. It's just going to robotic surgery will be there in future. I think robotic surgery is not very complex. It's simple. It's like we have done stereotactic surgery. It's exactly same thing. You follow the steps and you are there. All your stress is taken by the robot, so you don't have to worry much about it.
Can you show the video, please?
Video.
Finish,
Please start. Video will tell you everything.
Mazur X Delta Edition. The only robotic guidance platform that combines 15 years of Mazur robotic and planning technology, 25 years of self-navigation, and a comprehensive spinal implant portfolio to help deliver high-quality care and support your commitment to predictable surgical procedures. The workstation includes a large touchscreen control panel, system hardware component, and storage for the robotic guidance. The guidance system is made up of the following components: a table-mounted robotic arm ensuring a small OR footprint, a surgeon control panel, a sterile area, a navigation camera with a full suite of navigated instruments. Surgical planning is the foundation to a robotic guided solution, going beyond individual pedicles to enable the benefits of an entire construct design. Planning may take place prior to the surgery using the patient's pre-op CT scan, or during the surgery using O-arm scan plan. After selecting a region of interest in the CT image, each vertebra is segmented using an anatomical landmark recognition algorithm. From here, the planning interface displays the ideal orientation for each vertebra, where implants can be added and optimized to the ideal size and trajectory.
You can see the facet joints, and violation of the facet joints can be avoided.
Sagittal and coronal views, with the ability to fine-tune trajectories by scrolling slice by slice in all three planes. For ease of use, implants added at adjacent levels will populate with the same angle to midline as the previous level. Manipulate each implant for easy rod passage and a mechanically sound construct. The resulting plan is ready to be transferred to the operating room and can be shared with the staff to anticipate instrument and implant needs. To execute this optimized plan, surgeons need the precision of robotic guidance, supported by a platform of integrated technologies, instruments, and implants. Robotic precision is achieved through critical setup steps, rigid bed and patient fixation that maintains the stability necessary for robotic precision. A 3D camera that maps the surface of the operating field, providing topographical data for collision-free and efficient arm movements during instrumentation. Patient registration is accomplished with the O-arm, or CT to fluoro, as shown here, using two fluoroscopic images, AP and lateral, utilizing the 3D marker. Each vertebral body is then registered independently using Mazur's proprietary segmental merge, matching each segmented 3D vertebrae model, captured in the CT, to its actual position on the table, as detected in the fluoro image. Navigation uses an integrated camera with spatial tracking. For improved line of sight, the patient reference frame can be fixated on top of the arm. The snapshot tracker registration is the simple step that adds navigation capabilities to the robotic platform. The robotic arm moves with precision into the pre-planned trajectory, allowing instrumentation to be used through the arm, while self-navigation allows for real-time visualization of instruments and implants. Mazor X Stealth Edition, a comprehensive solution providing predictability, precision, and visibility.
Thank you.
Thanks, Kulkarni.
Thank you very much.
And let me thank all the speakers of this session with my co-chair Anand. Once I asked one of the speakers sitting here, do you use all these gadgets? He said this gadget is Professor Atul Goyal. Thank you once again for the great morning session.
Thank you, chairpersons, for running the session on time. And thank you all the speakers. Now we are moving on to the next session, that is on complication session 2. I would call upon Dr. P.D. Kulkarni, Dr. S.S. Khale, Dr. H.S. Batao for chairing the sessions.
Good morning, everybody. We're starting with another session here, which is regarding complications. And first speaker is Dr. Vernon Velo, talking on hemostasis in complicated spine surgery.
Thank you, Chairpersons. I'd like to congratulate Manas and Savit for a job well done. And normally we make our residents dance in the OT, dance in the ward, and dance in the OPD. He's managed to make them dance on stage also. So big hand to him. Yeah. My topic for today is hemostasis in complex spine surgeries. We have heard a lot about robots. We have heard a lot about technology. But when it comes to hemostasis, it is only the human hand and the human brain which can do this. Till now, no robot can do hemostasis. This is the place where I work. And of course, bleeding complications are very problematic in spine surgery, especially when you're doing complex spine surgeries. They make your life difficult. They cause a lot of problems. Hemodynamic instability, seromas, deep vein thrombosis, hypovolemia, and you might require transfusion. And overall, it increases the hospital stay, it increases the cost, and sometimes the patient might require a resurgery. So one has to be very obsessive compulsive when you are doing hemostasis in spine surgery. So coming to the preoperative period, today what we are seeing is people are not taking proper history, especially the residents. And many times patients are going into the OT and the anesthetist asks, have you been on some blood thinners? And they say, yes, I've been on blood thinners since the last 5 years. So we have to be very, very careful and take the history. And not only the juniors, the seniors should be also doing it. And because today, I think out of 5, 3 are on blood thinners, especially aspirin and clopidogrel. And these are the main ways which we do hemostasis, and that has not changed in our perspective. But there are newer agents which have come. We worked with gel foam, we worked with Surgicel, and now we are working with flowable hemostats, which are very good when there is a clotting and bleeding abnormality. Like fibrin glue helps when there is heparin, if the patient has been put on heparin before. And also the new flowable gelatins which act when warfarin is also being used in a patient, especially if you're operating on a patient who's already on warfarin. So my aim is to just highlight those. So there are different types of bleeding which can happen during spine surgery. It can start with a mild ooze and land up with an arterial high flow bleeding, and one has to be ready for managing all these types of bleeding. So the methods of hemostasis, they don't change. It starts with mechanical, going to pharmacological also agents are available now, like tranexamic acid, then you have prothrombin factor, and then going to blood transfusions and other adjunctive typical hemostasis. So there's no strict protocol. One has to mix and match and use whatever you have in your armamentarium. Just to show you some examples how bleeding occurs, this is a classical AAD, and we do it the Goel way. So this is how we dissect. So start your dissection microsurgically to avoid any blood and any blood loss. And every step you have to be conscious about hemostasis. Even putting the screw, one has to be conscious about. And see this, once the screws are put, some bleeding going on in the epidural area, we use flow seal. It stops for some time, then starts again. So it keeps, and the more you coagulate here, the more the bleeding which will happen. So here we are trying gel foam. So it stops for some time, then again it starts. And we have already done the instrumentation, so it sort of gets to you. So the last thing what we did is we used this fibrin patch, and then it stopped finally after using the fibrin patch. That's the patient, that's the post-op scan. So this is a slightly complicated case, carry with basilar invagination. And this guy's vertebral arteries were right in our face. They were across the lateral mass. So do this dissection under the microscope, and then you will have, when you're going lateral to the lateral mass, there will be a venous plexus. Here, see, more you coagulate, the worse the bleeding. So that's the place where flowable gelatin works. And I think flowable gelatin is a product which has thrombin. As to what Komal said, if you mix blood, here we are identifying the vertebral artery on the left side, skeletonizing it, and then covering it with silicone to keep it away from the screw. Otherwise, it can pulsate and produce pseudoaneurysms. So on the right side, this patient has an assimilated joint, and there is a high riding vertebral artery again on the right side. So here we are using a different trajectory. We are going from top down into the pedicle, so which is a different approach. And you see the lie of the screw on that side. So that's the post-op. That is the post-op, and that is a correction of the lateral rotation. So this is a foramen magnum meningioma. Again, these are difficult cases. So here what we are doing is we are lateralizing the vertebral artery, and we are keeping it for control. Always have it under control before you enter into the tumor. And we are going more far laterally. So here when you're doing this, you might have bleeding. That's the venous plexus which bleeds. And the flow seal works like magic. You try to coagulate here, it worsens the bleeding. With the flow seal which is there, it works like magic. Gelatin with blood forms a clot, so it does not flow through the syringe. So that's why the flow seal is better. Here what we are doing is, we are doing a laminotomy, opening the arachnoid over the meningioma, and then do the technique of devascularization first at the base of the dura. You might take down these dorsal nerve roots to allow access to the tumor, otherwise you have to push and pull. So the aim is use low bipolar coagulation and gently disconnect the tumor first, followed by delivering of the tumor, and always have control of the vertebral artery initially. If some problem occurs, you can, here we are shaving off the dura, and then one can close it and use fat enhancement. That's the patient, that's the post-op scan. So this is a recurrent cervicomedullary hemangioblastoma. Initially, only a laminectomy was done. So we went in and extended this laminectomy, used neuromonitoring. The hemangioblastomas are almost like AVMs. What we do is we use fluorescein angiography to identify the feeding vessels, and you got to be coagulating the right thing. So here the hemostasis is basically low bipolar coagulation. It's very low, keep it at 5, 6. Use the neuromonitoring and remove the hemangioblastoma in toto, and then you can use flow seal on the bed. The beauty about this flow seal is you can wash it off. You don't need to keep it there, and that's the patient. So he had a gradual improvement. He had a deficit pre-op initially. This is an endoscopic corpectomy which we have done for a cervical myelopathy. So you see here the end-on bleeding, which can be taken off very easily with this flowable gelatin. So here we are using the endoscope like the exoscope. So it's a fully endoscopic procedure, and the bleeding points can be taken care of. There's something called a Cervicel powder which is available, and the beauty is you need not keep this there. Once the hemostasis occurs, you wash it off. Unlike gel foam, Cervicel, you end up keeping it there, and sometimes it can produce a mass effect. So this is a patient who exactly had the same problem. When we were doing the ACDF, there was some bleeding epidural, and what happened is the patient, moment the patient came out, he had a monoplasia. So we had to go in again And then we found that this was because of the overzealous packing of gel foam and Surgicel, which had gone into the nerve root. See here, there's a lot of gel foam Surgicel, which we are removing. So do not overpack. So you can create a deficit. And that's where the flow seal, the flowable gelatin helps. So this just takes care of the bleeding and you wash everything off and get back to your job. This is a C2 schwannoma. This is more extradural, but there's an intradural component, and these tend to bleed, especially from the epidural veins when you're working into the foramen. So here we are doing a delivery of the tumor, and there's a big dural defect. And see the bleeding here? One can coagulate it, and we can repair the defect with a Duragen. And Duragen also helps. It's a collagen patch which helps in hemostasis, and it also helps in sealing the dura to prevent a CSF leak. That's the patient. So limited. So minimal access is good to prevent a lot of bleeding. We can just do the job, just limited bone removal. This is a large cervical schwannoma dumbbell, which is going into the neck. So one has to be careful. And when this is being done, you have to be ready for vascular anastomosis. That's the vertebral artery, which got cut. So no need to panic. Put temporary clips and do the anastomosis. So you have to be ready with everything. And then we go for the removal of the tumor, which is going into the cervical body. And the hemostasis of flow seal is ideal for this. So here, after removal, one can seal with fibrin glue and use the implant and place it. Here we are wrapping the anastomosis with a little bit of gel foam and put fibrin glue over top just to enhance the anastomosis. That's the patient. So I think, so this is a last video, an intraspinal AVM. The technique is the same. So hemostasis all the way. So I think I'm done. This is my last video, which I will show. So, but the technique remains the same. We use the ultrasound and very low bipolar coagulation. That is the most important. So the microsurgical techniques do not change, and no robot can do this. So it is your skill and your training which helps. So here we are localizing with the ultrasound and identification of the AVM. This patient had come with a pre-op weakness. He was wheelchair bound. So the important thing is to identify the draining veins and then get around the AVM. Very low bipolar coagulation. Check the feeding arteries and the draining veins. The draining veins are excised last. So we're taking pial stitches to keep the spinal cord away. And that's the excision. So very low bipolar. And the feeding arteries taken initially, followed by the vein last, which is draining into the dura. So that's it, AVM coming out. This patient took time to recover, so they are not going to recover immediately. A lot of physiotherapy, that's the post-op DSA. So I shall conclude. There are a lot of cases like this. So where hemostasis is important, and do not underestimate bleeding. And this is a consensus which we had done because there is no set guidelines. Which had, actually, Dr. Rishikesh had written this paper. And so hemostasis is important in spine surgery. The surgery starts with hemostasis and ends with hemostasis in order to achieve the best result. We'd like to invite you for the neurotrauma happening in Goa next year. Thank you.
Thank you, Dr. Vardhan. Whether it is a simple surgery or a complicated surgery, bleeding can be a problem. I know I must say that this FlowSeal or SurgiFlow is a invention in last 10 years. I think it has helped all of us during surgery. And bleeding is not that a big problem most of the time. Some people don't use even bipolar during surgery. I like to know the opinion of Professor Goyal. I heard about this. What is your thought about this bleeding during surgery? I heard you don't use bipolar even.
You know what? Tell you the truth, my dear one. I don't know what is flow seal. I don't know what is fibrin. Tell you the truth. This is what he's asked me. I'm answering that question. I don't know what is fibrin glue. I don't know what is this flow seal business and this Dura, whatever you're talking about. I've never used it. Maybe it is very good. Maybe it is necessary, but I have not used it. I don't know what it is.
Thank you.
So I don't know what the robots are. I don't know what the. So what Suresh said. I use whatever I have to use.
Brain navigation. Thank you very much. Thanks. We're short of time. We go to the next speaker. Thank you, Dr. Varnan.
So now it's Dr. Selvan will be talking to us. The twin facets of spine surgery, motion versus fusion. Always debatable. And of course, it's a never ending debate, motion versus fusion. I think it need not be motion versus fusion. It could be motion and fusion, both together. Selvan, please.
Yeah. There is Good morning, everybody. This is just a highlighting of what is happening in spine surgery in recent years. We are gradually switching over. There is a great evolution happening in spine surgery. So just to highlight what is happening and what should be our focus in future. Basically, the spinal fusion is a procedure in which two vertebrae were fused, and our aim is to see to that there is no individual mobility in that segment. And we have a beautiful success rate, but in spite of that, there is a chance of pseudoarthrosis 5 to 35% and much talked about complication, adjacent segment disease. So these are all the conditions, especially the late stages of the degenerative diseases, vertebral malalignment due to deformity, fracture, tumors, etc. The only way to fuse it. And we have applied our mind to various biological factors, graft factors, biomechanical factors to achieve the exact fusion. And spinal instability is the one condition where we don't have any other option. Professor Goyal used to say whether it is lumbar listhesis or cervical listhesis, we have to fuse. An unstable spine can no longer hold support of ligaments, muscles, disc, and bones. Micro instability, of course, the clinical symptoms are not visible, but macro instability can cause neural damage and deformity. And problems regarding most of the fusion surgeries, we have seen 95% of radiological fusion, but considering the clinical outcome, it is only 60 to 80%. So this has given us a motivation to look for alternative means. And this 15% chance of adjacent segment disease moves us further. Of course, it's not to degrade the fusion, but conditions like this with extensive osteophyte formation, which causes overload on the end plates, the ligaments being strained, and disc height is lost very much. We have no other option other than a beautiful fusion like this. And no second thought in spinal deformities due to fractures, fusion with autologous bone graft. And we have adapted a lot of techniques like laminectomy, laminotomy, foraminotomy, a combination with instrumentation, without instrumentation in achieving a good fusion. But what is meant for? The spine is not a single bone made up of 33 parts with 23 cushions. And it's a beautiful bowl-like structure. It's not a straight one. So what is it meant for? It is for the fusion, for the motion. And we can see various levels and various ranges of motion. Flexion, there is extension, lateral flexion, rotation, and even at single joint level, there is mobility. Even in CO and C1 also, we have 5-degree flexion and 10-degree extension. So these are all meant for maintaining the mobility of the spine. So these are all the extreme flexibility of the spine, which the future spine surgeons should keep in mind to to adapt themselves to maintain a beautiful vertebral column, which is already given by God with 120 muscles, 220 ligaments, 100 joints. So we have to admire the anatomy given by God and go ahead with that. As you all know, we have motion segment at each level. And see the beautiful movement at the level of facet joint when there is a flexion and extension, and also the migration of the nucleus. So each vertebra, as we all know, they have weight bearing component, the vertebral body, the neural arch which protects the neural elements, and the body processes which are the sites of attachment of various muscles and ligaments. These are all aimed at these curvatures, multiple segmentation, multiple attachments, and motion segment at each level. So these give us a clear concept that motion has to be. So fusion procedures, they have certain side effects also. There is a, as we already discussed, adjacent segment disease. There is a abnormal sagittal alignment, superior segments have facet joint violation, and there may be a persisting pain from the harvesting area. Motion preservation, when it is considered, it can be applied to almost all the degenerative conditions of the brain, spine, and fewer indications, fewer contraindications also are becoming indications nowadays, except a few contraindications. Rest of the things in an expert hand with available gadgets and available navigation oriented guidance, etc., it can be done. So already we have started adapting laminoplasty for a long time, cervical artificial disc for a long time, and the newer one with the advantages of preservation of motion, and the recovery process is being advanced and quality of life being improved. The motion preservation techniques, we can include the non-operative techniques also in this, because ultimatum is motion and ultimatum is relief of pain. So we can include these nerve blocks in various levels, and even kyphoplasty in early fracture cases due to osteoporosis. So common procedures now available, we have total disc replacement techniques, nucleus replacement, and dynamic posterior stabilization or interspinal spacers, and pedicle screw based stabilization devices, facet joint replacement. Newer methods to have a combination of stabilization and motion at the fused part. So this gives maybe a minimal restriction of movement at a limited segment level. Spinal motion preservation surgery is undergoing various advancements. There are a lot of changing indications and contraindications. As I already told, the contraindications can be minimized with an expert hand who is doing it in an expert way. And the aim is limiting the motion and not eliminating the motion. A lot of technical advancement is available. We have MIS, 3D navigation, laser guided surgery, fusionless surgery for spinal deformity, full endoscopy, MIS and all. So applying all these things with the available knowledge sources, we can maintain a motion at that level of disease, even in extreme degree of cases. The apophyseal joints orientation gives us a clue what we should not do. So this much of variable orientation of the joints itself gives us a drive to do some motion preservation surgery. And what we have to do, we have to master the technique. We have to become an expert by long learning curves or multiple learning curves. Of course, we need special equipments. And the last but not the least, of course, the gadget, our own gadget, the brain, in selection of the cases. This is much more important. We'll highlight in the last slide. So minimally invasive spinal surgery, we know what is the advantage of it, and injection therapies at various levels. And radiofrequency rhizotomy still holds good in relieving the pain. And minimally invasive kyphoplasty or vertebroplasty, even percutaneous vertebroplasty can be attempted. Balloon kyphoplasty is there. These are all the various methodology, simpler methodology, which we can apply to relieve the disease, relieve the symptoms of the disease and maintain the motion. And this is the other one which I want to highlight. The injectable hydrogel and non-hydrogel nucleus or replaceable nuclear material, which are all hydrophilic, and the various indications and the differentiation between the nucleus and the total disc replacement. In case of total disc replacement, the aim is to relieve the pain and restore the joint function. And we have cervical arthroplasty materials, lumbar arthroplasty materials, but the aim is to provide proper range of movement and relief of the symptoms. The various companies are coming out with various this thing. This is the one which I want to say, the contraindication side, except the last 4 or 5, rest of the contraindications are now being converted because of the expertized treatment and availability of gadgets and the minimally invasive surgeries. The contraindication, the top portion has come to the indication side in cervical arthroplasty also. So in dynamic stabilization, posterior stabilization, we have beautiful devices like dynamic pedicle screws, interspinous devices, and facet joint replacement device.
Please conclude.
So the aim is, of course, we have certain contraindications in minimally invasive spine surgeries also, but the new technology brings the possibility of new modes of failure also. That should also be taken into consideration. Mechanical failure of gadgets, dissociation, migration, subsidence, and there is a new entity which has started evolving, same level degeneration. We know the subsidence is 3 to 9% and dislocation 2 to 9%, but we are much worried about the same level degeneration when there is an attempt to do a motion preservation surgery. The idea is fusion is good always, but motion is better and to be attempted. And the one thing which forces us is the demand by the patient. Patient expects this status, but here is the place where we have to apply our mind, select the case, and select the availability of the resources and proceed with the surgery. Thank you.
Thank you, Dr. Selvan. So, one question or comment, please. No, very much.
Thank you, sir.
Now I call founder member of SSA and inspiration to all of us, Dr. P.S. Ramani, going to talk on safe spinal surgery.
This is the topic of my lecture today, surgeons, spiritualism, and safety in spinal surgery. Next slide, please. Within 2 months, I will complete 86 years and enter 87th year. I still work actively doing major surgeries. Spiritualism, I am not trying to tell you about our ancient scriptures like Vedas or Upanishad. Spiritualism means liberation of mind. It is the necessity of today. Abstract thinking is an element of human brain. It improves human personality, but it has also introduced negative thought like stress, anxiety, anger, irritability, etc. Surgeons plight today, they are brooding too much about the past and worrying about the future. They lose valuable present time because the mind is full of bizarre thoughts. They cannot think independently or critically evaluate the situation. Meditation was in fact evolved to streamline the thoughts, help thinking independently, maintain a healthy balance, and enjoy day-to-day experiences today. Evidence-based medicine, microlumbar discectomy, as established by me is established on evidence base, has stood the test of time, long-term results are available, and most problems can be handled by this approach. This is microlumbar discectomy. Next, please. Spiritualisms refers to the values of truth, peace, love, and righteousness. These are human values for vibrant, healthy, and viable work career. You might be interested that CERN is a quantum physics lab established by scientists all over the world to find out the origin of Earth and know more about the black holes in universe. It is in Geneva, by the way. The front facade of this building carries a carving of Nataraja for Lord Shiva doing Tandav Nritya. Its various poses indicate creation, preservation, and destruction. Shiva is also seen trampling on the demon of spiritual ignorance. And this was again the same picture seen in the Bharat Mandapam in New Delhi for G20 meeting. So that much is the value for spiritualism all over the world, appreciated by the scientists. WFNS Spine Committee, on behalf of this committee, I have established several guidelines on lumbar spine, cervical spine, and more recently on osteoporosis, with the help of experts from all over the world. And they are published in PubMed reviewed Neurospine journal. Pattern of guidelines, methodology of review. All over the world, guidelines are established by reviewing literature of past 10 years or more. The articles reviewed are not without flaws. Conducting prospective randomized controlled trials are very expensive and time consuming. Not possible to apply for spinal surgery, with most problems having an element of urgency. This is neurosurgery. Quality of literature search is published in leading neurosurgical journals. The review of the reviews. There is mounting evidence that the search strategies upon which systematic reviews are based frequently contains errors. The study demonstrates that the search strategies used in neurosurgical system requires improvement. So, evidence-based medicine or wisdom, which one you should use in spinal surgery? Conceptual approach, that is evidence-based, consciousness, explicit, judicious, and reasonable use of modern evidence in making decisions about the care of individual patient. Is evidence-based medicine an optimal treatment, or it is a cost containment tool? Dilemma. Which is more important? A successfully treated patient or a religiously followed picot, How prudent is the surgeon if the guidelines are not adherent to, and what if the surgeon can produce better results working away from the established guidelines? Wisdom, spiritual ailments, spinal ailments are often semi-emergency in nature. We cannot afford RCT. How do we get the evidence then? Is it ethical, valid to form a control group in spinal surgical ailments? Which is more important? Clinical and surgical wisdom or following the guidelines? You all know Sir William Osler. He said that a physician treats the disease. A wise physician treats the patient who has the disease. Medicine is a science of uncertainty and art of probability. Greater the ignorance, greater the dogmatism. And this is Viktor Frankl. You might have heard of him. Spinal surgery should be practiced without falling prey to outside liver. This is Sternberg's theory of human intelligence, evidence-based wisdom, ability to achieve success in life according to one's personal standards within one's socio-cultural concept includes analytical, practical, and creative abilities of the person. Personal standards include IQ and education. He need not be a genius with 190 IQ. By the way, Steve Jobs' IQ was 160. He can be average, 100, varying between 85 to 114. But he must be analytical, creative, and practical. Try always to learn more. Another genius, Richard Feynman, average at school but passionate about physics, became famous physicist and was awarded Nobel Prize for his work on quantum electrodynamics in 1965. In 1986, American Space Shuttle Challenger exploded in the sky. Feynman's tenacious inquiring mind exposed the engineer's flaws, which caused the space shuttle to explode. What were the flaws? Overconfidence, inflated ego, and dogmatism, where the sources of flaws is known as intellectual trap, which made them overlook the mistake. Curiosity is the key of wisdom. Curiosity is common with high achievers, even with average intelligence. Curiosity activates neurotransmitter dopamine in the prefrontal cortex. It also transmits the information to hippocampus, causing long-term storage of memory. So, general intelligence, which includes education, curiosity, and consciousness, that is ethics, are the pillars of academic success. Next slide, please. Lessons to the spinal surgeons. Seek new information in new situations. Look out for new things or experiences. Embrace difficult and complicated events. Explore your own problems. Explore different perspectives. Imagine alternative outcomes. Identify erroneous arguments. Lesson to spinal surgeons. Intellectual humility can make us see in the bias blind spot. Very, very important. Form more rational opinions, avoid misinformation, learn effectively, and work more productively. Next slide, please. Weaknesses. World healthcare system has progressed significantly with technological boom, but World Economic Forum has identified two things which are detrimental. Increased polarization of people and spread of misinformation in digital wildfire. Doctors' responsibility, spare few moments to listen to the patients intently. Most of the times it conveys the correct impression of diagnosis, pathology, and expected management. Examine the patient. Examine the patient carefully and make a working diagnosis. I have always insisted in my life that everyone should first make the working diagnosis. With dedicated doctor, it almost proves to be correct. Do not do only those investigations which are necessary. Don't say, you got pain in the neck, have you brought MRI? Don't say that. Next slide. Always speak with hope, optimism, and empathy. Never say, I cannot help you, your disease is permanent, you will remain disabled throughout. Today, Genes are decoding several diseases. Spiritualism, he should be conversant, observant, and non-contradicting to the patient. Rational thinking, rational medicine, analyze misconception. Evidence-based medicine or wisdom. Evidence-based medicine, this is published in Neurosurgery May 20. It has been observed that research strategies used in neurosurgical system review requires improvement. Evidence-based wisdom, again published in Neurosurgery 1994 and 2018. It is a giant within you. Remember, it is a giant within you. Next slide, please. Today's necessity, practice surgery, combining evidence-based medicine with evidence-based wisdom. Next slide, please. Value of meditation. Surgeons with knife in the hand should forget everything that is bothering his mind and concentrate with calm mentality to do the surgery. This was told by Supreme Court Justice B.N. Next slide, please. Apple was spiritualism. It is not an apple a day that keeps doctors away. It is the meditation combined with yoga that keeps away several lifestyle ailments, just as I'm enjoying good health at the age of 86 years. Next slide, please. Conclusion. Spinal surgery is a profession that challenges the doctors to do the best. We never seem to reach an end of our career while treating patients and start living with them. The wisdom we gain teaches us the meaning of the life. Selfless is the best work. Do your work with dedication, love, and passion without any expectation. That is called Karma Yoga, which I have been advocating to everyone. This is in Lord Krishna in Bhagavad Gita. Join us in NSSA, Neurospinal Surgeons Association. Thank you very much. Thank you. Thank you.
Thank you very much, sir. Thank you for your advice. You already taught us safe spine surgery. We are learning spiritualism from you as well. Thank you very much.
Yeah, it's every talk of Professor Ramani, it kind of reignites, it makes us sit back, rethink, and reignites the minds. Thank you very much, sir, for all these years and years of wisdom passed on periodically. Thank you very much, sir. Cervicodorsal deformity, state of the art, and complication avoidance. More important is the last part, complication avoidance. Dr. Satish Rudrappa.
Good morning, everyone. First of all, I should thank NSSA Hyderabad for inviting me here. Thanks to Manas and his team. Today, I'll be talking on the cervicodorsal deformity. After the great lecture on spiritualism and the Shiva doing the Tandav Nritya, you can see the spinal balance is so important when we do whatever the activity, so that against the gravity, we'll have a less load on every part of the human body. So especially the spine and the muscle. So the cervicodorsal junction is a unique junction which extends from C7 to T4, and it has an anatomical transition. It has biomechanical challenges and it has radiological challenges. Anatomically, there is an increase in the vertebral size from the cervical region to the thoracic region. There is a change, the beautiful lordosis which is given to human being at the cervical becomes a kyphotic at the cervicothoracic junction. And the spinal canal diameter, which is wider in the cervical region, becomes narrower where the cord slumps into closed net within its space, with all the organs in front of it from heart to the mediastinal structures, which is completely tightened and kept inside the thoracic cage. And biomechanically, the highly mobile cervical spine suddenly becomes in a rigid thoracic spine. And the The challenging in this approach is the vital structure. You cannot approach it completely anterior. Whenever you want to do 360, unlike in the upper cervical and the lumbar region, in the cervicothoracic junction, you cannot move the trachea, esophagus, heart, aorta. It creates a complication to the patients. And most diseases in this region, especially related to the balance, always progress, and it is prone to progression because of the mobility below and above, and it's static in the center. And definitely difficult in imaging as well as instrumentation in these patients. The cervicothoracic deformity usually happens most commonly in the congenital one. Many of these children are born with the deformity, and as they grow taller, it becomes worsening to them. So you will see many of these patients will have hemivertebrae, block vertebrae, etc. It can also happen commonly, in dish pathology and ankylosing and in trauma, but rarely in tumors. So the indications for surgery in this region is usually related to the neurological compromise. Many of them will have pressure at the T1 and T2 level. It can cause myelopathy or a simple radiculopathy in these patients, which will have progressive hand weakness and wasting. And in addition, if there is a progression in the kyphoscoliosis, you need to do surgery in these patients. More so in patients who have a failure to thrive. Many of these children are brought by the parents saying that they're not growing taller, they're not gaining the weight, their self-confidence is poor, and they will have bullying in the school, and which is purely related to poor lung function, which indirectly leaves them with a lesser tissue growth. And many patients, the ankylosing and everything you must have seen, they have a chin on chest deformity where they look down completely. Even to look up, they have to strain themselves, which is very common in dish pathology and ankylosing spondylosis. And many of these children, when they have a congenital anomaly, will have a social and psychological issues, which is related to their cosmetic in addition to their neurological problems. I'll give you a few examples of these patients. Here is a 14-year-old girl brought to me with progressive hand weakness, wasting of the hand, especially the right hand in her, which was happening for last 4 years. And she was developing a small amount of the twitching and the wasting even in the upper part of the right hand, which is extending to the left hand progressively. Look at her, this structure. She had a Cobb angle up to 69 degrees at the cervicothoracic junction, and C5 to T2 kyphosis is almost about 58 to 60 degree kyphosis. And when you see the CT in these patients, you will see complete the changes in the vertebrae, complete hemivertebrae, block vertebrae. Some of the vertebrae are missing, and they will have an acute kyphosis happening at the cervicothoracic junction, leading into toggling of the cord, which over a period of years, they will have a rubbing of the cord against the kyphotic part, and they develop the neurological deficit. And this patient was developing because unilaterally she was toggling on the spinal cord. Luckily, she was in the early myelopathy, but not complete myelopathy. When you do 3D CT, it is sometimes very devastating to see how you have to approach these patients. So the challenges in these kind of patients is pediatric patients are very, very, many of them are in pediatric age group. Poor bony ankles you will have. You will have inadequate bone grafts and stability in these patients. And more so, they're poorly nourished. So when they're poorly nourished, the anchoring becomes difficult. So you have to stage the surgery. First, improve their nutrition. The nutrition, many of them are caloric, deficient rather than protein deficient. You have to give high calories. It is very well known that if you give the McDonald's and the burgers, they gain more weight than, you just give egg and milk in these patients. So you have to give them more calories rather than the protein in this patient. And then stage the surgery with a great planning and analytical ability, which, Dr. just told us in the previous lecture. So in this patient, the first I did T1, T2 posterior facetectomy. I released most of the posterior elements. I did costotransectomy from T2 to T4, and I put the screws from C2 to T10 screws wherever it is available. Most of these things are very flimsy, and you have to use the neuronavigation, and you had to use your hand touch skill, the tactile sensation when you are putting the screw in these patients, rather than literally poking like what we do in adults. And followed the stage is same day, I did C5 to C7 anterior carpectomy. So overnight, after the posterior and anterior release, I put the patient on traction up to 12 kg weight. You can clearly see, which is kyphotic before, started opening up in the middle of the night. The next day, when I opened it, I could clearly see the posteriorly. Anteriorly, I took a large graft of the iliac graft of the patient. Even the iliac graft in this patient will have a lot of cartilages, and you have to take the extensive one and put it in that way, so that it'll be extension is created. And then go back posteriorly, fuse from C2 to T10. Believe me, even after this stabilization, because the proximal anchoring is very loose in these patients, and you cannot hold the whole long segment, you had to have additional support in these patients. This is how she was pre-op. The next you can see post-op patients. But after doing this, on the third day, I realized that my proximal anchor is not good. The lower segment is longer than the proximal segment. Then I resorted to put the halo for this patient so that she will not have a failure. Failure in this patient, redoing is much more cumbersome in this patient. So I put her on halo for 3 months. At the end of the 3 months, there is a complete reunion of the cervical region. There is a significant correction of the kyphosis and thoracic curvature. You can see preoperatively how the neck is tilted against the shoulder and her poor nutritional status. Now she's almost about a year. She's gained in confidence. She has come first in mathematics in the school. She's participating in activity, and her body size is also increased. She's become more taller. So this is a pre-op and a post-op. There is significant change both in the kyphosis and the scoliosis in these patients. So a 360-degree release is most important in these patients. Remove the hemivertebrae, give the stable fixation, and whenever there is a cervical involvement in the cervicothoracic region, add a halo vest in addition to your implant, so that the results in the longer run is much more better. I'll show you a second case in the similar way. In this patient is also the Cobb angle is 46 degrees and kyphosis is almost about 41 degrees. And in this patient, once again, I did a 360-degree release. This patient came with a myelopathy to me because of the complete toggling. You can see angular kyphosis happening at T2, T3 junction in this patient. And once again, 3D images will give you a complete block vertebrae on the one side, and the other side is completely deficient. So you had to plan it very well in these patients. Once again, I did the complete release. And at the end, when I do the 360, you can most of these patients can be corrected significantly. And once again, this patient, she was weighing 23 kg, she became 30 kgs, and her Cobb angle was completely corrected in these patients. So in this patient, I did the substernal approach in the anterior part, and hemivertebrae excision was done from the substernal approach from the anterior, so without cutting even the manubrium. So similarly, you can do, but this is yet another patient. You can see here severe kyphosis along with the lower thoracic also. He was getting scoliosis in these patients. They progress, and this is after 3 years. You can see here he's become straight, and recently he came to me after 8 years. He's completely corrected. He's become a great adult, and he's going to get married. So in these patients, this is the fourth case. This is a patient with ankyspon, chin on chest, which I was telling you. Once again, I did posterior pedicles and pedicle subtraction in osteotomy and anterior correction in this patient. And this patient was corrected, and we had to give up to the occipital region the stabilization in this patient. And he became almost the perfect walking. The take-home message in these cases are the cervicothoracic complexity is very rare, but very complex in dealing with it. Understand the anatomy. Your 3D anatomy is key in this patient. And approach, you had to plan it well and sit and write down what exactly you would do it. And the pediatric patients should always require adjuvant immobilization. And with experience, you gain more and more confidence in this patient. And being a neurosurgeon, when we can do intramedullary tumors and excise the AVMs, you can do even the deformity surgery if you plan it very well. Thank you very much.
Thank you, Dr. Satish. I think it's a challenging situation here, and obviously more challenging when it is failure of the instrumentation or infection. Do you have come across any problems with?
The problem is preoperative. Preoperative, how you feel the pedicle, because any pedicle, you have to see where exactly you have to do the UIV, that is the upper instrumented vertebrae, your LIV at the lower level, and what is your apex. At the apex, upper and lower, you have to have the great stability. So first, always do at the apex, go to the lower one, and the upper one, spend more time. Use the neuronavigation, and especially in the pediatrics, some of them will not have the cancerous bone in the pedicle. So you have to have a different technique where you slowly, you'll have a blend probe, slowly hit it and feel that the cortical bone expands and allows the screw to go in. And the navigation is key in these patients.
Satish, great talk. Do you do monitoring in all these cases?
Yeah, of course, yes, of course. I do the IONM in every patient. Both you had to do the long tracts and also nerve tracts. Also, you had to do it.
What did you find, like during the difficulty, correcting this? Do they have problems? Do you stop doing it?
That is advantage. This is one of the problem in cervicothoracic region. In cervicothoracic region, unlike in the thoracic kyphosis, which you do in adult, where you can derotate the rod, where you literally use the force, you cannot use the force in these patients. That's why your mobilization of destabilizing the spine, mobile spine, then you put it in situ almost, where you have to correct it based on the posture and the head frames you do it, rather than the derotation. Never do it, otherwise rip off the pedicle, you will never have a stability.
And especially the subtraction,
Yes, pedicle subtraction osteotomies or the hemivertebral removal is the key in these patients, not like other things.
You do costotransversectomy on one side.
Costotransversectomy, you had to do one side because if you look at the anatomy, the costotransverse junction is the one which holds it very tight.
But
You had to remove.
What about the block itself?
You had to remove the block.
You have to.
You had to remove
To
it.
section it.
You use the same bone grafts. You rib head you remove, then the joint you have to remove, go anteriorly, drill off that part, and it becomes very mobile. Thank you. Thank you very much.
Now we have the problem which I think we'll be seeing more and more in the years to come, especially as the spine surgeons add to their experience, that is surgery of the aging spine. We're going to see more and more senior citizens coming for spine surgery. And Dr. Marcus Wagner from Brazil, he's going to talk to us on aging spine. Over to you, sir.
Thank you. It's a great pleasure for me to come in the name of Professor Manas Pranigani and Professor Hamani. It's a great pleasure for me to come from Brazil. So I'm going to talk to you about the effects of the aging process in the cervical spine cervical myelopathy. I live in Campina Grande, Paraíba. It's a city here in the south region of Brazil, northeast region of Brazil here. Okay, it's really far away from us, but okay. And why to study the aging process? So there is a changing in the populational pyramid along the years. Okay, you see here in Germany there is already much more aging people than youngers. Brazil is towards this situation also. Maybe in 2050 we are in the peak of it. And you can imagine a country like you with 1.5 billion inhabitants, how many problems you're going to have, many patients in these aging fields. As we are listening to Professor Hamani, the importance of movement, importance of taking care of your muscles for having a better health while you're in the ages period. And the muscle nowadays is more than a muscle per se. It is an organ which is much important in terms of endocrinology, control of glycemia, and so on. And we need to take care of our patients. I know we are good to see how the screw is going, the trajectory, but if the patient doesn't have a good life, a good spiritualism, we're going to lose all of the high-end techniques that we are using to provide his care. So since 50s, in the literature from London, they refer to us about the process of cervical myelopathy. We can go further and see until from the ancient Egypt, there is reference about these changings. And you know, all of these chronic process damage the vasculature, damage the spinal cord, giving to us all of the symptoms that we have. The spinal column in some species are important and magnificent. It's an important organ of the human body. And day by day here we discovered new etiologies of the disease, like Professor Goel told us today in this historical event. There are many other situations that we still need to know, and I will bring to Brazil, Professor, your new theory about rotational anomalies in the cervical spine. Maybe you can save many lives in this kind. Anatomy of the cervical spine is so difficult also to explain. It's a unique organ. And here is all the process that all of us know, the heredation, height loss, cracks, joint degenerations, impact of stability and mobility, every process here. And you see in this figure, all of this process here, the degenerative process from this degeneration until sequestration. Another lateral view showing the osteophytes damaging the nerves. Here are some videos also. And Professor Pilates tells us that you are only as old as your spine. So you have to take care of our spine also. Here's the osteophyte process, how it works and how it changes along the ages. It's a never-ending process since we were born. If you don't take care nowadays with the use of cell phones, all of these processes are being increased. Okay. So all of this process damage the spine. We need to work combined with endocrinologists, tell our patients to do movement, to do strength exercises to maintain everything in the right way. So cervical spine myelopathy has a unique series of pathobiological mechanisms related to chronic progressive spinal cord compression and distinguish this condition from traumatic spinal cord injury. So it's a chronic inflammations and factors as tabagism, it can increase all of this process. The epidemiology is high, it's 2.2 to 7.9 per 100,000 patients. The incidence is from 50 to 70 years old, and it's commonly underdiagnosed. Some jobs, some occupations tells you what you're gonna find in terms of lesions. Here in tennis, how many times these professionals has to move their neck. And clinical evaluation is important. All of the exams, X-rays, magnetic resonance images, computerized tomography, everything we know is important for the evaluation. So X-ray is important to see the curve. We have to see all of the spine of the patient, to have a whole view of the skeleton, to have rational philosophy. CT scan showed us the ossifications of the anterior ligament. In Brazil is not so common as we have here in Asia. MRI has come to highlight all of other in soft tissues abnormalities and showing us the CSF flux. Here is important alterations that we see in this diagram here. See the process of osteophytes damaging the nerve. You see here the myelopathy. How important is these studies? There are some clinical implications, the balance, the alignments of the occipital orientation also. And we must be aware of differential diagnosis for us not to treat diseases like amyotrophic lateral sclerosis that we can worsen the patient's symptoms, syringomyelia, spinal cord tumors, plastic, inflammatory, autoimmune disease. So we always have to think more than we want to give a better care. There is also nowadays connections from cognitive dysfunctions of those patients related to cervical myelopathy. So we are treating the cervical spine, but the problem is in the brain or opposite. We don't know who begins first. Here's the classification, renal heart classification. Has to talk the same language from Asia to Brazil. It's important us to grade how our patient is damaged. This algorithm is important. It's a great summary for our rationale about this disease. So the patient history, static risk factor or dynamic factors go you through these streets. And at the end, you can go to surgical intervention versus structured rehabilitation, education, clinical follow-up is really important for our patients because these processes are continuously. If he continues with all of the etiology of his disease, we don't solve his problem at all. There is the article, it's an algorithm strategy for selecting a surgical approach in cervical deformity correction. So prevention, as Professor Hamani stressed here before, everything is important, even the mind, the soul, everything. And physical therapy medication in our culture, yoga is not so popular, but nowadays it's increasing there in Brazil. I think it's one of the most important things for preventing to have a better life and almost not expensive. So indications, all of us know about, depends on the gravity of the patient. We can go anterior or posterior, depends on what we want to do, what we have to do. So this is the incision we use sometimes, vertical or transversional. We can use some cages, we can use some bones. Everything we have to do for decompression is important. Okay. Here we have multi-level decompressions, use some peak cages. Plus we can use some weights. We have some advanced devices here, as we can see here with a screw in each level. We can have a elegant fusion. Disc space, our experience left side approach. As upper you go, more right you make the incisions. Lower you can go to the left to spare the nerve and avoid to use monopolar in this region. Bipolar or non, any coagulation is better. Some recurrent laryngeal nerve palsies in some cases. So what we do to optimize the anterior surgery? To reduce dysphagia, topical or IV steroids, improve operative technique, as I told you, not to use the monopolar in this region. To avoid pseudoarthrosis, you can use implant materials improvement, autobiologics that we have here in the market. For reduce adjacent segment disease, motion preservation device, hybrid procedures, and to avoid surgical invasiveness. But the invasiveness of the surgeon doesn't depend on the kind of the skin, is what you have to do it. Posteriorly, you can go, we use sometimes nasal fibroscopy to spare movements in those patients who has the spinal medulla in dangerous situation. So here many approaches, you know more than us, and we use open door laminoplasty for motion preservation in some cases. In some cases we fuse. Okay. Here I went to the Mecca of neurosurgery and have some lessons from both Professor Goel and Professor Hamani. Sometimes I'm rebel and make the decompression, but sometimes we keep it. It depends on the case. Some examples here is good result in terms of aesthetic. Some complications also we have, but we treat and face the problem and there's a better end. Factor related to post-op outcomes is symptom severity. So as soon as we diagnose this case, good result we have. That's why we beginning in Brazil to create an awareness campaign about Chiari, because all of these lesions, if you treat them earlier, the patient got really good situation. Optimizations of posterior surgery is C5 palsy. It's one of the major problems there. So you have to do foraminotomy, maybe intraoperative monitoring, or neurological worsening, monitoring, surgical techniques, steroids, avoid wound complications, supportive post-op pain, areas protocols, multimodal postoperative regimes, motion preservations, laminoplasty, laminectomy, in medical complications is to see better patients before the operating. So here is my historical moments that I passed here in those days. It was really impressive. I'm really support you, India, and all my friends now, Professor Hamani, all of other friends from China. There is 2 events that I can here promote you. There is an event which I'm the president in next month. I know it's too late for you, but all of you are welcome to come to Brazil. And there is on July in 2025 in Amazonia, one congress from our Brazilian Academy inside of the Amazonia. So thank you. I'm available for questions. And Brazil and India are friends. I come to here with 2 luggages, but now I have another one from Korea. We can make some exchange program among us. Thank you.
Thank you, Dr. Wagner. Thank you for elaborating problems with the elderly people and operating on them. And thanks for talking about this. But there's the older people who are supposed cord compression. They got already associated morbidities, and they are not fit for operation. But you are helpless. You want to do something, but you cannot do it. So what do you do for these people?
I think we can make some work with the physiotherapy, physical strength, because it's a multi-professional area. Surgery, I think, is the last thing. If you have physical training, strength, lung, respiratory support, the patient can do that. But the great problem is the falls. Patient falls and then get a subdural hematoma. Challenging for us. So if we work on prevention since we were born, I think all of these problems can be reduced in the further generations.
Okay, thank you. Any questions, any comments? Thank you very much.
Thank you.
So calling the next person, Dr. Aprajay Golash from UK regarding training in spine surgery. Now, as we climbing on the ladder of training, we come across many problems. We are working very hard, training, education, examinations, relationships, and all those of things. And they vary from country to country. Obviously, training is different from India, training different in UK. Dr. Aprajay Golash is consultant neurosurgeon from Preston, and he's a BAS president. BAS is British Association of Spine Surgeons, and we got a BAS here, which is a Brass and Spine Society, and almost logos are more or less similar as well. So I invite Dr. Golash to talk on training.
Thank you. Good morning, and thank you, Manas and his team, to invite me and such a wonderful hospitality. What a wonderful morning it has been. We have heard about innovation, different concepts, spirituality, and such a complex surgery. And that begs the question, how do we learn and teach these things? How the new generation becomes the master they are. And the setting today is amazing. You have got trainees, I've got their trainers, trainers of the trainers, and even their trainers. So in this huge spectrum, for me to talk about training is slightly awkward, but let me try to raise some thoughts in your mind. So what is Sodoto? Anybody thinking of what is Sodoto? This is our classical way of learning so far. that we used to say. See one, do one, teach one. And it's like a cycle. You just go around. This is the typical surgical training way that we have been trained. Not just see one, you see few. This is the typical apprentice type training that has worked for us. We all been trained on that. But now the times have changed. There are working regulations, so your trainees can't work more than certain hours. There is a different public perception. You cannot train on the patient. You have to have something else before you actually put your hands on the patient. So all these begs for a different type of model. A lot in literature, the recent publication about surgical training, a review, and many others like this advocate a structured training. And what is a structured training? It could be in anything, whether it is surgery or pilot or anybody. It's a time defined with a specific goals, learning objectives. That's what you need to get. It requires a training program. You need to assess the trainees formally. And not only trainees, the trainers, how they're training. The training unit, it's not one trainer, it's the whole unit that needs to train. We saw yesterday the KIMS, the whole team was there. It was very impressive. So you need to have the team, the units, and they need to continuously improve the training methods. So how do we train in spine surgery? And the rather odd thing is spine surgery is still not a separate specialty in majority of the countries. You come from orthopedics, you come from neurosurgery, they have different training structures, very different experience. And when you come out, as we see in your own publication, you actually have not done a lot. You're basic competent, but the all advanced training is not there. And that's why I think you have got here the FNB, your NAS and other organization is providing some training. So you have to have some structure. I'll just explain how we do. I do chair the National Training Program in Spine Surgery in UK via the Joint Committee of the Surgical Trainees. So we design Spine Training Interface Fellowship where you have orthopedics and neurosurgical trainees to come together. And the aim is to provide spinal surgeons, so general spine surgeons who can manage all range of, not necessarily operate, but manage. So they know where to send, what to do next, what is the emergency. Don't let the people linger. And how we do it, there's a national selection process. There's a well-defined curriculum. Units need to apply to become an approved training unit. So they have to have the proper details. They need to provide what they can give, what the numbers, what the clinics, what the specialty. Some may have pediatrics, some may have scoliosis, some may have intradural work. So they have to have what they're doing, and they get reviewed by this. So same things we can look into. Each unit have their own specialism. So if somebody wants to be an expert in CV junction, they go to certain units. Somebody wants to be a cervicothoracic surgeon, they can go to the other units. So you have to have that modularity, because nowadays the days are gone where you can say, I'm the spine surgeon, I will do everything that's possible. You need to specialize if you really want to make a good name and want to do a good service. There is no harm asking for opinion from the others. So we need certain defined structure, and what we call it is the generic professional capabilities and capabilities in practice. What it means is just being a very gifted technical surgeon is not enough. You need to have the ability to interact the team, the patient, the other professionals together. And there are these 5 settings for the clinical capabilities. As you can see, there's nothing special. There's just a structure given to what you do normal day to day. It just has been defined. And then the levels of expertise defined. So you know what is level 1, level 2 to level 5. So there is a structure to them. So you can just prove where you are expanding. And there are 9 domains. I don't want you to read all this, but it's just to give an impression that you have to be not only have the professional skills, practical skills, but you have to have health promotion. We heard about how you prevent doing yoga exercise or rest of it. So you have to have health prevention, safety, innovation, research, all that sort of things need to build into this training. And then there is a critical progression points that you need to see.
So that's the structure where you put all the syllabus, you put everything, and you formally assess. And then you put into the training program, which has certain themes. So effective is giving a very structured, so you can evaluate how one is moving and how you're going along. But after putting in the structure, you need to do formal assessments. And these are the certain tools we use, which are work-based assessment, case-based discussions, multiple consultant reporting, and all rest of it. So there is a very formal structure to it. And this is how it goes. In the beginning, you have an agreement. You assess the progression in the middle so that you're not caught unaware in the end that you have not progressed. So it's very important that you have regular reviews as you're going along. And then you have the training units. So you put all this in place, but you still need to provide the training and how you do it. So you provide the technical skills and non-technical skills. All these needs to be provided. And that takes me to simulation. So you need to provide certain things. Nowadays, the simulation is becoming more and more important in various ways, whether it's high tech or a low tech. And then you need to assess whether simulation is helping or not helping. Just not to have a gadget, and there are various ways to assess that. Like you can use an eye tracking, these type of things where you can say, okay, you're using simulation. Were you engaged? Have you improved? So let me give you some examples like what we do. So this is a device, a haptic device, which trains by putting needles into the pedicle screws to give you that feedback, give you even the X-ray image on the side. So this is something that you can use. This is what we developed ourselves using HoloLens. And this is, let me see if I can play. I've speed it up. So there is a holographic image of the spine comes in. You're wearing a HoloLens. And then you just stare at your eyes. The center point is your eye. With your eyes, you just read, this is what you'll be studying. Then you go on. So having something like this allows you to practice in your own time. And we find this is very useful for even this training staff, the theater staff. A new staff has come. You put the HoloLens up in your time, and you can go to anatomy. And we use it for the pedicle screws, but we're devising it for various other things. Simple things like even doing a lumbar puncture for medical students. So something like this, I've speeded up 1.5 times just to speed it up, to show what it looks like. All can be done with simulation. I'll move on to the next. You might be wondering what we are doing here. And this is using the virtual and augmented reality. So you put this on, you may see we are just putting in the thin air our fingers, but actually there is a model there which we are looking at. And once you will see what this model does, so you can have a model in front of you, you can turn it around the way you want, and then you go inside it. You can walk inside the model, you can look around the structure, so you know when you will have the relationship of the other structures around when you're inside it. And then you bring it to the practice when you're actually doing the surgery. I'll just play this again. So this is then what you have simulated before, and then is the real surgery. It was a transfemoral approach to this chondrosarcoma. And I was able to look at where I will expect the carotid in relation to the tumor, and rest of it we have practiced before because I was able to walk inside the head and look medially. And so does my trainees. So these ways, it really helps to take it to the next level. So with that, I stop and ask for questions, but as it says here, the simulation didn't show the redness and haziness, if you can read. So sometimes you need to have the real experience. The thing can take you away from real experience. These are just add-ons. Thank you.
Thank you, Dr. Golas. Any question, comments?
It was a great talk. I just want to ask you a very, honest question. That how would you compare simulation as a training versus actually taking your resident through the surgery yourself on the patient? Because you see, I'm sorry to say this. Of course, we didn't grow up during our training with simulations. It's wonderful gadget for the younger generation or the residents to do it, to have the three-dimensional vision and all, but the feel of it and what you actually do, what you actually look at, and the sixth sense that you develop with experience, is that what our trainees need? So hand holding and actual training on patients to make sure that they don't do any damage, of course, is, to my understanding, is much more valuable than a lot of machinery. But they are all useful. I'm not saying they're not. It's a wonderful presentation.
No, to answer your question, if I can give you the analogy, suppose you're taking somebody on top of a hill. If you're taking them from the bottom to the top, it's a harder job. If they are only 100 meters below the peak, and then you're holding your hand from there to the top, it's an easier job. This is what this is doing. You know, there is no substitute to the hand holding. But it's just, yesterday we had a talk on the 3D printing. Amazing tool for training a complex thing. These are just, we have developed the ability to generate the 3D in the head here. You know, as Atul was saying, everything is here. This just facilitates that. They need to develop that sense, which it took 10 years to develop. We want them to develop in 5 years. That's what it is.
Good talk. Strictly speaking, in India, especially in neurosurgical community, we don't have a structurized spine surgery fellowship program. I think the need of our, because from the time we started 20 years ago to till today, in orthopedic, they have a better system than in neurosurgery. I think looking at the system, we all have our own fellowship program. Some of them are well structured, some of them not structured. And with the spine surgery evolving from minimally invasive to maximal surgery, and it has become such a common disease with the age increasing. I think, especially in India, organization like NSSA, we had to come out with a protocol and a systematic way how to select students, what to train, what is the level of training we have to go, and what is the exact exam we have. Otherwise, we are finding every neurosurgeon putting a spine surgeon, and many of us are doing redo surgeries more than the fresh surgeries which are not required to do in the beginning itself. I think it's a good talk. Hope we'll awaken ourselves and we will do the program much better. Thank you.
Thank you very much.
Thank you, Dr. Gulash. And now we move on to the last talk of this session. An old friend from Korea, Dr. Se-Hoon Kim, performing a better cervical disc arthroplasty.
Thank you very much, Mr. Chairperson. Good morning, ladies and gentlemen, and good morning, Professor Ramani and all distinguished members of NSSA. It is always a great pleasure for me to be a part of the NSSA annual meeting. The topic what I'd like to share with you is the cervical disc arthroplasty. I saw there were only small number of the papers regarding cervical arthroplasty, and I was very happy Dr. Selvan mentioned in his talk regarding the motion preservation techniques. So I'm not sure how many of you experienced the cervical arthroplasty so far. This is my disclosure. And I have one disclosure. You know, my last name, family name is Kim. This meeting was hosted by Kim's Hospital, but do you know what the Kim means in Korean as the last name, family name? Kim means, in Chinese character on your left, gold. So actually last year when I was informed regarding this meeting in Hyderabad by Kim's Hospital, I was so much surprised. Actually, I don't have any relationship.
Kims have gold.
Yeah, that's right. So anyway, I don't have any relationship with the Kim's Hospital. So again, so honorable to be at this meeting. You know, this picture was taken exactly 2 weeks before in Seoul. As you can see, we celebrated and we had the friendship meeting with NSSA India. And there you see many Indian friends, good friends, talk about the many topics. So again, it is so honorable keeping the international friendship stronger and stronger year by year. So coming to my talk, I'm going to briefly mention about the cervical disc arthroplasty or artificial disc replacement or total disc replacement, and the potential complications and the key surgical tips for successful cervical disc arthroplasty and conclusion. Now, talking about the cervical disc implant, these are most commonly used, the currently available implant in Korea during the last 2 decades. I've used most of them, but when you check at Google, you see so many, 40 main players at the spine market as the cervical arthroplasty implant. I've never heard some of the name. So which implant will survive or disappear in the future? We don't know, actually. So I can say no ideal arthroplasty implant can perfectly mimic the real disc so far. So this is timeline of the US IDE and FDA approval. Some implant obtained 2 levels indications, some only 1 indications. So when you do the ACDF, as you can see here, we can experience the screw fracture and cage subsidence and finally pseudomotion, pseudoarthrosis, and on your right, implant failure. And sometimes we see so-called the ASD at the adjacent levels of ACDF. So this is the reason why arthroplasty was introduced. This is some of my cases. I operated this patient 16 years before. And as you can see in the dynamic X-ray, the patient showed good mobilities on this flexion extension view. And what about this patient? Oh, I'm sorry. This patient, I did another arthroplasty implant, activity from the esculate. This patient also showed the good mobility after 12 years. So we were able to publish our result in terms of segmental motion in the single level ACDF versus single level TDR using the activity. So we concluded it was very promising, and the arthroplasty showed excellent motion preservation at the 2-year follow-up. So coming to the arthroplasty indications and contraindications, this is well-known indications. Remember, the indicated cases are radiculopathy, myelopathy, or myeloradicalopathy at the 1 or 2 levels only. 3 levels is not approved yet by the FDA. And it must be the refractory to the medical treatment or conservative treatment at least 6 weeks. So what about the contraindications of cervical arthroplasty? Severe osteoporosis, infection, and significant the instability of the operative level or severe the arthrosis, spondylosis. Those the conditions are contraindications. So I can summarize. This could be potential benefits of cervical disc arthroplasty: motion preservation, the adjacent disc degeneration, the risk is reduced, and the other ACDF-related complication can be reduced, and so on. And there are some potential complications in addition to the usual complication related to ACDF. Those will be improper malposition of the implant, heterotopic ossification, we call it HO, osteolysis, and so on. We can see a lot of the complications related with arthroplasty. It is notable that 12% of the patients may reveal mechanical or bone-related complications at postoperative 1 year, within 1 year. So due to the time limit, I'm going to briefly mention about these some 3 complications, unique complications related to the cervical arthroplasty. HO, osteolysis, also called anterior bone loss, and improper malposition of the implant. Regarding this HO, it is reported 7 to 70% occurs after arthroplasty. And according to a paper published by Korean groups, they mentioned the risk factors of the HO were older age and male sex. In cases of severe and progressed HO, it may defeat the original purpose of the arthroplasty in terms of motion preservation. So to reduce HO, it is recommended. Minimize unroofing the cancerous bone and end plate violation. And you need to use copious irrigation during the surgeries, and NSAID are usually required during the early postoperative periods. And the next is osteolysis. Actually, the mechanism is well not understood. Some mechanisms are proposed, the foreign body reaction, or wear debris effect, and so on. Initially, some doctors called this osteolysis as anterior bone loss because it was seen in the anterior edge of the superior vertebral body. But you can see even at the lower inferior vertebral body. So the osteolysis is the better terms, I think. So according to this paper, the risk factors actually they tried to find the risk factors of the ABL, but according to their report, they analyzed 4 kinds of the arthroplasty: Bryan, Discorso, Mobisi, and Bagherazzi. And they found this bone loss was common in all implant types. And the greater the number of levels operated, the higher rate of ABL occurred. So the osteolysis usually occurs within first post-op year. So when the osteolysis progresses, it may induce device subsidence and segmental kyphosis. So we need to check serially using the close radiologic follow-up. And what about the improper malposition of the arthroplasty? In cases of the malposition, this arthroplasty implant may cause in the future the unilateral neural foramen compression and the resultant radiculopathy. This is my own series. This patient underwent cervical disc arthroplasty 2 years before in other hospital. But as you can see here, this is off midline, shifted to the right. The patient presented with right shoulder and arm pain, so we have to convert to ACDF. So you can see many the kinds of complications related to arthroplasty. This is displaced implant. What about this very rare complication, sagittal split fracture in cases of keeled prosthesis? And what about this very rare complication? It is published by the Yonsei University group. They found Bryan device was missing after post-op 1 year. They didn't know where it gone. So finally, my main topic is regarding key surgical elements for the successful. We have to keep in mind properly position the patient, wide and bilateral, symmetric decompression is needed, and proper end plate preparation, and proper implant size, and so on. So as we do in cases of ACDF, we have to place the patient in the normal and slight lordotic position. And we have to apply the standard ACDF technique using the landmarks of the midline of vertebral body, and adequate symmetric decompression, including bilateral oncovertebral decompression is needed. Unless that may induce radiculopathy to the patient. And the proper end plate preparation, and the proper trial, and finally proper implant size, and the properly centered sagittally and coronal plane of the prosthesis. So
please conclude.
If unable to implant successfully, we are better to convert to ACDF without any hesitations. Actually, there are not so many the literature regarding the radiologic assessment after cervical arthroplasty, but I can say that the optimal position should be centrally placed both in sagittal and coronal planes. And you can find several algorithms proposed in cases of failed arthroplasty. This is my conclusion. To make successful arthroplasty, you have to stick with good, strict surgical indications and contraindications, as I showed. And actually, so far, no ideal cervical arthroplasty implant we can see. But I think in the future, I hope we can see more physiologic advanced implant and the appropriate patient selection and attention to the the precise and key surgical techniques that would make the successful cervical disc arthroplasty. This picture was also taken 2 weeks before in Seoul during the NSC meeting. We have our president, Professor Cho, coming there. He hosted very successfully our NSC meeting 2 weeks before. Thank you very much for attention.
Thank you, Dr. Kim.
Thank you.
And I'm sure you will find a lot of Kim around here. So thank you very much. And with this, are there any questions? Any points to be made for Professor Kim's? Yes, please.
In India, many times there are discharge cards saying that 3 stents are put, and then you find there's only 1 stent. I want to know what happened to that disappearing disc, artificial disc. Was it not put and fusion was done, or the body digested it?
Excuse me. Okay.
In India, many times people undergo coronary angioplasty. And there are 3 stents, 4 stents written in the discharge card, and sometimes on investigation you find there's only 1, but the patient was charged for 4.
Wow.
Soluble stent. So I want to know what happened to that disc which disappeared. How did the artificial disc disappear on the post-operative imaging?
Actually, yeah, they don't know. They didn't know where it's gone. At the paper as well. May passed out to the stool, but we don't know.
Oh, so you think it came out into the...
Yeah,
I
maybe.
thought they did
It was the explanation. Yeah.
Oh, I thought they just put bone graft and said that they have done the disc replacement.
Okay, thank you.
Yeah.
Thank you, Dr. Kim. And with this, we conclude the session. And I thank
Presidential oration soon.
it's over to Dr. Raghavendra.
Thank you so much, Chairpersons. This is pretty much the pièce de résistance of this conference. For the prestigious presidential oration, I would like to invite on stage the past president of NSSA, Dr. Kale, the president-elect of NSSA, Dr. Selvan, and the secretary NSSA, Patuk Tera, to chair this session. I have the honor and privilege of introducing the president of the NSSA and the organizing chairperson of this conference, Dr. Manas Panigrai. Can we have the presentation up, please? This task has been made both very easy and very difficult. One is Dr. Manas needs absolutely no introduction. And the part that's very difficult is to fit in everything that he has achieved in the 2.5 minutes or so that's been given to me. While they load the presentation, I have a couple of personal anecdotes with Dr. Manas. I grew up in the neurosurgery department in NIMHANS because my mother used to work there, and Dr. Manas was one of her students. And I would spend weekends in her lab, and I have a very, very clear memory of my mother pointing out to him working in the lab and said, "This is Dr. Manas. He is one of the first neurosurgeons to work with me. Say hello." And I said hello as any 12, 13-year-old boy would do, and completely didn't think much about it till perhaps 15 years later in 2010, I walked into my MCS neurosurgery exams and Dr. Manas was my examiner. So that was a fairly long association. And since then, he has been a mentor, a guide, and he's been extremely helpful in the last 10 years that I've been in Hyderabad and in the last 3 years that I've been associated with KIMS under his mentorship. But for a short presentation regarding Dr. Manas, these few slides do no justice to everything that he has achieved. in this short span of time. He is currently the head of neurosurgery at KIMS. He is a fellow of the Skull Base and Cerebrovascular Society at Wayne State University. He was previously a professor at the Nizam's Institute. He's the president-elect of the Neurological Society of India. He's the president of the Cerebrovascular Society of India and the Skull Base and was the president of the Skull Base Society. He is the president, was the president of the Neuroendoscopic Society of India and is a member of the WFNS committee and is, of course, the president of NSSA. Brief about his schooling and education. He finished his high school in Behrampur and went on to do his MBBS from the MKCG Medical College in Behrampur. And following that, he joined the National Institute of Mental Health and Neurosciences from 89 to 94. He was then assistant professor of the Department of Neurosurgery at NIMS, a clinical fellow of skull base and cerebral vascular surgery at Wayne State University, and then continued to become associate additional professor and finally professor at the Nizam's Institute from 2007 onwards. And from 2009, he has been associated with the Krishna Institute of Medical Sciences. We saw a lot of his contributions to the Department of Neurosurgery at KIMS and the amount of training that has been done yesterday. For those of you who weren't there, we had the KIMS alumni meet yesterday of all the neurosurgeons who had trained in KIMS. This is a busy slide, but it's probably not as busy as it could be. He has won the UC Mishra Memorial Gold Medal for securing the highest in biochemistry and physiology, and the CR Subudhi Medal for securing the highest in pharmacology, the Gold Medal for pathology, obstetrics and gynecology, surgery, ENT, and ophthalmology, the Pfizer Medallion in medicine for the best outgoing student, and the Professor G.P. Mohanty Prize for the best surgical graduate in the state. He's won the Andhra Pradesh Neuroscientist Gold Medal in 2005 and the AP NSI Gold Medal for participating in the Dr. Bala Parmeshwar Rao Symposium in Nellore in 2006. He's been awarded the Captain C. Venkaya Memorial Oration Medal in 2010 and another award for presenting the Bala Parmeshwar Symposium in 2015 and awarded a medal at the AP NSA in Nellore 2017. Apart from that, there's also achievements in the best essay by the Indian Academy of Pediatrics in 1987. He was, of course, the best outgoing student in his MBBS batch and the best outgoing student in his batch of neurosurgery. He's also been awarded the E. Merck Award at the 43rd Annual Congress of Neurological Surgeons in India for presenting the best NSI Allied Sciences paper in 1994 and the Dr. Saraswati Memorial Award in 2013 at MMC. He's been awarded an honorary FRCS in 2003 and a certificate of merit at the RSNA USA in 2016. The JSCN Award at Tokyo, the Pattabhi Memorial Medal in 2011, the Young Neurosurgery Award, and was a panel member at the symposium in Kyoto in Japan, and awarded a fellowship in skull-based and cerebral vascular surgery at Wayne State University, Detroit, an International Pediatric Neurosurgeon Award to attend and present a paper at Salt Lake City, another International Pediatric Surgery Award to attend and present a paper at Adelaide, and the Young Neurosurgeon Award by the European Pediatric Neurosurgery Association to attend a paper at Rome. He has more than 98 publication index journals, over 10 chapters, had a ResearchGate score of 36.45, and over 1,300 citations for his contribution to research. As we saw yesterday, between NIMS and KIMS, he has trained over 50 alumni just from KIMS in the last 10 years, and an equal number of neurosurgeons have trained under him from the Nizam's Institute. He's been a faculty in many international and national conferences. We've seen him and learned so much from him in the past few years. He has demonstrated both endoscopy and microneurosurgery in workshops both India and abroad, and has demonstrated functional neurosurgery in conferences both India and abroad. Short snippets of his life outside of the hospital with his wife and child and his family. And he has won multiple awards. He was the Legend Award in Neurosurgery and a huge number of firsts in Hyderabad with the use of AutoGuide to implant a lead. And he is also positive for us getting the first 3 Tesla MR guided focused ultrasound system and the latest Gamma knife to KIMS in Hyderabad. Can I have a round of applause and invite Dr. Manas Panigrahi to stage? to deliver the presidential oration of NSSA 2024.
Yeah, good morning, chairpersons and uh, teachers and friends in the dais, in the audience. I didn't know that I had to work as a president when I took the responsibility of organizing the meeting. So I'd like to thank Professor Ramani and the foundation for giving this opportunity to be a president. But then I don't think we have done as a president anything. But I am fortunate to get the liberty of getting so much time to speak and the liberty that nobody can ask me questions. So I can speak whatever is there in my mind. I thought I'll speak on odontorectomy. Where is Dr. Savitar? Savitar, thanks for giving an elaborate, probably could have shortened. But then I told you make it elaborate so that I can speak less because I want less time. And my talk is dedicated in memory of Professor B.S. Das. As he told, trained from Nimans, and Professor B.S. Das was known as a legend for transoral surgery. And when we were trained, people from all over India were referred to Nimans for transoral surgery and posterior fusion. In 1997, when there was a meeting by Professor Jain at Lucknow, and they brought out a book on the experiences of CV junction by different people all over India. There were half of the people who wrote chapters in this book were from Nimans. And so that is the legacy of Nimans of promoting surgery for CV junction. The standard protocol at that time was transoral odontectomy, followed by occipitocervical fusion. And in addition to Professor B.S. Das, Professor Chandramoli had taken over the to continue the same legacy at Nimans, and Professor Jain at Lucknow SGPGA. And the same legacy was carried at Andhra Pradesh by Professor S.V. Rangarao, as he was felicitated yesterday. And Professor B. Subbarao at Vizag, he was also felicitated yesterday for carrying on the same legacy of to treat CV junction at periphery centers. Because Professor Das believed that things should be available in periphery rather than people should be referred only to a tertiary center. And Professor Subbarao and Dr. Rangarao had worked with dental drills, means as a resident I have attended, and we have done work with dental drills with, when we started working at NIMS, we also did with dental drills. Many femoral odontoid screw fixations we have done, femoral neck lag screw, which is hardly 100 rupees, and all those with dental drill. Means I'll not include all those things of antique, now it will be antique, people will not be interested. But then what is important is to use, don't look at the disability, look at the ability of the place, find out instruments which is available and use it, and you can do wonders. In 1997, when we took out our data of post CV junction alumni what we were treating, we sent our paper. So we also started doing the dental drill, transoral decompression followed by posterior fusion. Now, Professor Jain, in his chapter, he wrote that 40% of them needed a transoral decompression. Until 15 years later, Professor Atul Goyal changed the concept. He said the odontodectomy is of historical importance. Nobody should do that. And he published that it can be done everything with posterior, do a distraction of the atlantoaxial joint. And 10 years later, all legacy of Niemann had to follow him. They said, but then they said that it's not distraction is enough, but you have to do joint manipulation also. So they published a paper, Dr. Sarat Chandar and Dr. Praveen, who was trained with Dr. Jain, and he said that one has to do a three-dimensional correction of the joint to get a proper alignment, and everything can be done with the posterior and no need of doing transoral surgery. And all three of them, they disputed Professor Das. So the legacy of Niemann was dying. That is why I selected the topic that it's not to revive the legacy, that odontoid excision still has a role, and when one has to do odontoid excision. So the legacy odontoid excision of historical importance was presented by all three of them in different conferences. But then you look at this paper in 2020, 10 years down the lane, when after Salunke and Sarat published in 2013 and 15, these complications come when all of us started following that only posterior approach. What happened? We had ulcers in the occipital region with the implants coming out, and this is published. It's not my observations. I also had similar cases, but Professor Goyal will get offended if I present my case. So I took from publication that these are the problems when you cut the ganglion and you have bilateral ganglionectomy, you have occipital hypoesthesia, patient lying on the occiput, they'll end up with this problem. It's not bad technical infection, because probably because of bilateral ganglion removal, C2 ganglion removal. We had observed this in our cases, though we are not very good in writing, so we are not published, but this we presented in 2011. This is a video of 2011, and we from 2011 started preserving C2 ganglion. This was presented by Dr. Fani Raj, who was working at KIMS. He's still working at KIMS. You can see here it's a 2000. So the date is there, 2011. So the ganglion, do a subperiosteal dissection of the epidural venous vectors and ganglion, sift, identify the lateral mass, and use the same entry point where what Dr. Goyal used, below the C1 arch in the lateral mass. But then using this technique, there is a problem that the screw will probably irritate the ganglion, and patients can have paresthesia or hypoesthesia in the occipital region. So to overcome that problem, we changed our technique to trans-arch C1 screw, which Manoranjita was working. She was there yesterday. She left now. We see presented in 2015 our work of other cases that we changed the point of entry. This is a video of 2015. So the same dissection technique of subperiosteal dissection of epidural vein, and then the vertebral venous plexus along with the vertebral artery from the groove of C1 and protect it by gel foam. And when I was presenting at that time, I think Dr. Muthukumar, Professor Goyal, they were not agreeing. No, this is not correct. They are not getting good alignment. But then we continue to do because we believe that this is better technique in our hand. So instead of entering between the arch and the lateral mass, we enter directly through the C1 arch. So if we went through C1 arch, the complications of the screw irritating the ganglion is less. So post-op paresthesia and occipital like neuralgia complications were less. And this I I is not very good at writing, but the cases which are done, I sent to Dr. Srivastav from Sanjay Gandhi, and they also had a large number of cases, and they were following also C2 preservation, and this was published in 21, and we had 88 cases, which a group of A, where the ganglion was sacrificed, which they were practicing earlier, and then 78 cases where ganglion was preserved. Out of that, half of the cases we had contributed. And what was the difference was that the incidence of neuropathic ulcer in the occiput was 0 when the ganglion was preserved, and in 3 cases when the ganglion was not preserved. And this is significant because we use implants. It's better not to have any pressure sore or neuropathic ulcer in that level. The second problem in what we encountered was the graft. This cage was popularized by known as Goel's cage, and then but using this cage, there was hardly any space for putting bone graft. And though we did not have pseudoarthrosis, but logically we thought that just putting a metal is not good enough for having a good bone fusion. Though that process initially started only bone chips, but later, because bone chips did not give distraction, he started using these cages. But then we thought these cages are not good enough for bone fusion. So initially we used, now this publication came in 21, and they have compared the Goel technique and Sarachandra technique. And one of the problem is when you have a graft, and if one does Dr. Chandra's technique or Dr. Salamkar technique with so much of bone drilling, the cortical bone is gone. And when you put a metal, there are chances of settling of the bone, and that can cause implant failure, and they can have delayed worsening. So we had thought logically that probably it is not correct, so we did not continue to do putting a metal cage. We thought of putting a bone graft, a structural bone graft. And this publication has come now in 24. And here they said whenever you use a bone graft, the fusion rate is 100%, but metal graft, the fusion rate is 60 to 70% according to this article. People, when you thought of bone graft, people use iliac crest graft, but all of us know that iliac crest graft, patients are not very happy with iliac crest graft. So instead of using iliac crest graft, we used C1 arch, posterior arch. The C1 posterior arch is a very hard bone, and so it works like a structural graft because it's hard. You can so we harvest the C1 arch, then we shape like the Dr. Goel's peg, the implant, divide into 2, and this is the bony one. So it has hard bone with a central cancellous bone. So it's like a structural graft. It will help in distraction as well as help in bony fusion. And we use this graft and impact it in the joint after drilling the joint. So the first we place the C1 screw, take out the arch, then impact the bone graft, and then place the C2 screw. Otherwise you will not have space to place the screw. This is a structural bone graft which has both cortical bone and cancellous bone. So there is no need of making an additional incision on the occiput in the prone position, and so patients feel happy, and the extra incision is less. So complications associated with iliac crest graft can be avoided by doing this technique. The third problem we encountered with only posterior fusion was delayed worsening. In the last 14 years, we had 4 cases in children. They came with delayed worsening after 2 to 3 years of surgery. Now, this was a 24-year-old male with no comorbidities and neck pain, and he had paresthesia, difficulty negotiating foot, had symptoms of quadriparesis, and this was the X-ray pre-operatively. He underwent occipital-cervical fusion with FMD. He was doing well, and came back after 9 months with worsening and difficulty in swallowing. And when he did a repeat scan, there was the invagination had aggravated. And this was the X-ray. No, we did not demonstrate instability, so we decided to go for a ventral decompression, a transoral odontodectomy. This is again another case. This is a young patient. We had done fusion, And she came with worsening after 2 years, and scans showed that there was a progressive invagination. This was the invagination, and then we thought of doing the odontoid excision. Now, I'll be discussing only the odontoid excision in CV junction, but then there are a lot of other indications of odontoid excision I'll not be discussing. Out of the 4 cases we had, we did 2 transoral and 2 transnasal. Initially, we did the 2 cases transoral, and later we realized that transnasal is probably better than a transoral. So this is what we presented. How do you decide that a particular case is good for a transoral or a endonasal approach? Whether you do endoscopic or microscopic is different, but then we were trained in transoral, but then we graduated to doing an endonasal, endoscopic or microscopic. So for any patient who comes, we can do a lateral X-ray or a CT scan and draw the nasopalatine line, the line between the nasal spine and the posterior border of the hard palate. And if any lesion above this can be done through the nose, any lesion below this, one has to do a transoral or high cervical extrapharyngeal approach. So this is the nasopalatine line one has to draw in every patient to decide what transnasal or transoral versus extrapharyngeal approach. That is how we decided to go for transnasal over transoral, and from transoral we have gradually changed to an endonasal approach, but then the concept is there is a need for odontoid excision and it is not of historical importance. The advantage of doing transnasal is the post-op swelling of the tongue is less, so patients are more comfortable. There is no need of many times tracheostomy, and but then endonasal approach takes longer time, but the post-op morbidity is less. But they can be extubated faster, and so that is how we changed from transoral to endonasal. But we believe the legacy of Professor Das that odontoidectomy is required. It is not of historical importance. We have done 11 cases of foramen magnum lesions ventrally, 3 extrapharyngeal, 4 transoral, and 4 transnasal. Now this is a case which we did transnasal because the compression was above the nasopalatine line. So as you see here, the pathology above the nasopalatine line, and then we did a transnasal approach. Now we did this with the microscope. After placing the retractor, there's a limited space in the through the nose. As you can see here, first use a laser to cut the to incise the nasopharynx. And then to insert the drill, we went through the mouth. So we made a perforation at the junction of the hard and soft palate, then inserted a needle through that. That gave us a wide space. The drill has come through the oral cavity, and we are working through the nasal cavity. So it's like a biportal approach, like endoscopic, uniportal, and biportal. And this gives us a lot of space and better visualization. The whole clivus can be drilled, the tip of the odontoid till the C2 body can be drilled or till the compression. No, so drill till the make it thin out or excelling of the odontoid. Then the transverse atlantic ligament can be excised. So what we learned as a resident from Professor Das, we still practice of excising the transverse atlantic ligament until we achieve the dura. Normally, epidural venous bleeding is you get at the end, you get epidural venous bleeding. And Surgiflow, Dr. Varnan was presenting, Surgiflow is it's faster. Means now we are using, earlier when it was not there, we used to have patients just wait and follow Dr. Goyal's technique. But now we use Surgiflow and it just achieves faster. So this is what keep on drilling till we have the adequate excision and final achieve. This is what we get the final decompression and achieve hemostasis by application of Surgiflow. And this is how Using a transnasal, patients can be discharged faster. There is no need of tracheostomy. We have a RICE tube kept for 2 years. Ask them to have a mouth gargling for 2 weeks. Do not have solid food, and then they are better. And the recovery also is faster. This patient was not able to walk pre-op, and then he's able to walk comfortably after 3-4 days of surgery. This is again another case of transnasal approach. We did through the similar approach to again transnasal, and the patient did well. The same people who said odontodectomy is of historical importance, Dr. Sarath, then came in 2020. Are there any indications of transoral odontodectomy? So people have then changed their way of thinking that odontodectomy is required. I'm sure tomorrow Professor Goyal also will come with a paper when odontodectomy is required. I've not taken the papers by Professor Sushil Patkar. I'm sure he'll be presenting next, so I have not included all those anterior approaches because my objective was to establish the legacy of Nimans. There are a lot of papers on reconsideration of the transoral odontectomy. This came from China. This came came in 21 again about transoral odontectomy in complex CV junction with irreducible anterior compression. Now, what is the outcome? All of us think only of celebrities like Professor Goyal. He never tells that he has any problem of after posterior decompression. But then what happens when people like us operate? Now, this paper came in 2021 from Satya Sai, Bangalore. And out of 94 cases, what they published was in 36% of them, they thought that reduction and realignment will be risky, and they decided to go do a transoral and posterior decompression. Now, there are some papers they have told that you do attempt a posterior alignment, and if you fail, then you fuse it and go for transoral. So there are a lot of cases what we operate. At least 20 to 30% of them cannot be done, at least in our hands, not in the expert or a celebrity hand. He or she can do it probably with nil complications, but common people like us, you and me, probably will need in 30% of the time a ventral decompression. So in an algorithm, it's a very good algorithm to follow, that whenever you have an irreducible AD, you have two options. Option one is to do only a posterior fixation, and FMD means only a posterior approach, but then that is in experienced hand. But if it's like you and me, probably one also should have 1/3 of the cases an option that you have to do a transoral or a transnasal decompression. Whether it is reducible or irreducible, one has to follow this algorithm. In both the algorithm, you can see here that transoral is coming back and is going to stay. In conclusion, to be happy, as Professor Ramani told, one has to be happy as a neurosurgeon, and the greatest thing to practice to be happy is dogmatism has to be avoided. And dogmatism is the greatest of mental obstacles to become happiness. This is what I didn't tell. This was told by Russell. So when you practice anything, don't be dogmatic. Take what is logical and what you feel correct. Many times residents listen to great lectures and come and tell that why don't you do this? I said, no, I don't feel it's logical, so I'll not practice this. Thank you for your attention.
Thank you, Dr. Manas, for this highly personal opinion about CV junction surgery. Good, it's good to lay it out. Now we go ahead with the second part of. So we go for the next oration. Okay. So I think now we go for the next oration.
Thank you so much, chairpersons. Can we have another round of applause for Dr. Manas, please? The Professor P.S. Ramani Lifetime Achievement Award Oration is a very prestigious part of every NSSA FineCon meeting. In order to introduce the award itself and the history of the Lifetime Oration, I'd like to invite on stage Dr. Shraddha Maheshwari.
Uh, yes, Ramani Lifetime Achievement Award Oration. Before I go to introduce the orator, let me first introduce a bit about the oration. Dr. Premanand Ramani, a name that has inspired many generations of neurosurgeons. From humble beginnings in Ponda, Goa, where he would walk 15 kilometers to reach his school, to becoming a world-renowned neurosurgeon. His journey, in fact, has inspired and will keep inspiring many. The dream of becoming a doctor from a very young age and then developing keen interest in spinal surgery took him to England, where he mastered the art of neurospinal surgery. But never did he think of settling in there. He had this dream, vision of giving it back to his motherland, his country. With that aim of propagating and spreading the knowledge about neurospinal surgery, he returned to India and, with his 4 very able students, laid the foundation of Neurospinal Surgeons Association. This association did not leave anything unturned to spread the knowledge. He collaborated with multiple world-renowned neurosurgeons across the globe to bring the knowledge to India and various other countries. Dr. Ramani conducted multiple cadaveric workshops where he would train the students in different techniques that he had founded, and soon they would be flocked with students. Live operative workshops, calling students from abroad and training them one-on-one, starting fellowships, training in microneurosurgery, and writing multiple books about the subject. He did not leave any stone unturned. With multiple honors in his name, an operating theatre in Indonesia, the Paul Busi Award, the first Indian to receive one, an auditorium in his name at the LTMG Sion Hospital, a road named after him in Vadi, Goa, a stamp in his honor in Hungary. The Neurospinal Surgeons Association started the Lifetime Achievement Award in his name and an oration which acts as a guiding light to many. Over the years, multiple national and international figures have received this award. The award is aimed at recognizing those who have dedicated their lives in spreading the knowledge of neurospinal surgery. Their journeys, like Professor P.S. Ramani, continue to inspire many. Like they say, what you leave as a legacy is not what is etched in stone monuments, but what is woven into the lives of others. The Dr. P.S. Ramani Lifetime Achievement Oration strives to achieve that year after year. With that introduction to the oration, can I please call the chairpersons for this oration? Professor P.S. Ramani, Dr. Pramodha, and Dr. JKBC Parthiban to chair the session. Before I introduce the orator for today, there are some very famous lines which come to my mind. Research is to research. You can't ride a horse by catching its tail. Necessity is the mother of all inventions. And last but not the least, from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than endurance of the same. Good Lord, deliver us. Yes, this of course was written by Sir Robert Hutchinson. But there's one person who constantly reminds us about all these things. He's none other than our this year's Dr. P.S. Ramani Lifetime Achievement Awardee, Dr. Sushil Vasant Patkar. When I write his name, I emphasize on his middle name, Vasant, his father, his first and foremost teacher. I remember him very dearly and always during the cadaver workshops telling me that his father would tell him, "What right do you have to operate upon the living if you haven't operated upon the dead?" With such great thoughts put into him, he was sure to make a great neurosurgeon. Ladies and gentlemen, Dr. Sushil Vasant Patkar, a renowned neurosurgeon, is the founding members of NSSA. He has always kept his teachers very close to him and ardently followed him, making his presence felt on world forums and stages, and one of the most sought after and looked upon speakers on the stage, setting the stage on fire with all his ideas. All you need to do is give him a bone model and he starts speaking neurosurgery. With multiple awards and papers to his in his kitty, he has again and again spread the knowledge of neurospinal surgery worldwide. He has been recognized for his anterior approach in the CV junction and has been called world over. Personally, a loving father, a doting husband, a loving father, and loved by his family and friends and friendly foes equally. Presenting to you the star of today's afternoon, Dr. Sushil Vasant Patkar.
Good afternoon, everybody. At the outset, I'm grateful to all of you, especially to Professor Ramani and to God, that I should be invited and be on the stage to deliver the oration of my teacher, father, mentor, everything. It is very, very rare that one gets this opportunity, that he's sitting as the chairperson and I'm giving an oration in his name. It is very rare, and I thank God and everybody for that. Thank you very much. Can the slide start, please? Yes. So I will be talking about my tryst with spinal surgery, especially with the craniovertebral junction. I have absolutely no disclosures except for Dr. Ramani and my life partner who began as my house surgeon, and we still continue now. She has become my boss. Life is like this, you know. When I started, suddenly I thought I knew everything. And then slowly you start realizing I'm somewhere stuck over here just now. And now that I'm getting the Lifetime Achievement Award, means I have to stop working. So probably I will not reach here. I'm somewhere here in between these two. Some time back, I had published a paper whether life is about destiny or about doership. And I'm now, towards the end, realizing that destiny is more important than doership. As you become older, you realize in the beginning it is, I did this, I did this, I did this. Slowly now I'm realizing that it was destiny which brought me over here. So this is where I began at the KM hospital, then some sanity, and then I was lucky to move on to Sion Hospital. My journey in neurosurgery actually began with this junkie whom I met, addicted to neurosurgery. He actually wanted a house surgeon. And what he told me, Patkar, everything else is bachcho ka khel, you have to do neurosurgery. And I was dragged into neurosurgery by him. And slowly I got introduced into neurosurgery and life went on. That was an era, many of you will not know, there was no CT scan. CT scan had yet to come. We used to rely on angiograms and ventriculograms till CT scan came and main yahan, tu kahan. And then, of course, the MRI came. This is for the youngsters, they don't know what kind of neurosurgery we went through. There was no neuro ICU. Neuro ICU was ICU. Usually all the wards had their side rooms in which 3 beds were kept. And that was neuro ICU. So I came, after surgery, you sat down next to the patient. So that was ICU. Till I met him. And he inculcated in me, he was way ahead of his time. He had the ideas of a superhuman, complete doctor and guru. So there are various kinds of teachers. You can get a teacher who can give you knowledge. Guru will give you philosophy of life. And that is where I met him, and I was lucky to meet Professor Ramani. He stressed on history, history, and history again. This was what we used to do that time, myelogram. We didn't have the luxury of MRIs. And most of the time, we did the myelograms ourselves. And then on the stage had arrived that time 2 people, Roy Camille and Manohar Punjabi, and the concept of instability was coming in. And many people thought that Dr. Ramani was a pseudo-neurosurgeon. He was talking about bones and fixing pedicle screws. And now over the period of time, like Manas said yesterday, it is becoming more important than brain surgery. That is the time he came up with this. He was in the world amongst these. This is Cloward, Steffi and Paul Lynn, where they have done more than 1,000 PLIF surgeries. And this was published in AANS proceedings, I think, way back in 1989 or something. And this is how it was done. It was a very meticulous operation to be done, where you have to retract. At that time, Foley had yet to describe transforaminal technique. It was a very, very kind of anatomical operation, but it changed the life for many patients. And the next thing was pedicle screws. Pedicle screws also were made popular by Dr. Ramani all over the country. It started spreading like wildfire. He used to do his workshops, traveling, and I was fortunate to be part of that journey with him. And then he brought about a revolution by describing, teaching many people about pedicle screws in India. And that time still the FDA had to give approval for pedicle screws. The other thing was, of course, transoral surgery. I was fortunate that time he was doing transoral surgery followed by the loop. And this was another doctor who was also from his colleague from Nair Hospital, Professor Arnold Menezes, whom we kept on liaising with him. He had come to Nair Hospital. And that time, this transoral surgery was in great vogue with the posterior loop fixation. I had the opportunity to go with him and with Dr. Menezes do a workshop in USA. For the first time, we did a workshop in a hotel with cadavers in Boston. Then, of course, all over the world, then I was inculcated by him into the World Federation way back in 2009. Then we went to Kenya, we went to many countries, Nepal, and then he had this unique capacity of making friends all over the world. You can see this with Professor Moon. I'm sure he was boss of Professor Kim. He was a teacher, right? So he was his teacher, and Dr. Ramani used to keep inviting people from all over the world so that the science progresses. And this was much younger me that time. My hair was, originally black, not like what I've done now. And this was with me where we had gone to Indonesia. We went to Indonesia many times. We frequently visited there, and he did demonstration surgeries, and there was an operation theater in his name. And then this pedicle screws, I shifted into private practice, and definitely then I moved on to doing pedicle screws. And this was the first time I'd made this kind of dual rod from Geon. They had made it for me. And then, of course, my friend Atul, he described this technique, which revolutionized C1, C2 surgery. And then this paper got published, which mentions that I was always fighting because they kept on calling it Harm's technique and not Goel's technique. And now suddenly they have changed. And this whole basis, see, even today, when Dr. Manas was showing us this work, if the whole focus was, working in that small area in that bleeding and where the screw is going to go through, this is what happens to neurosurgeons who wants to do CVJ surgery. He doesn't love me anymore, and he keeps on thinking that the vertebral artery is going to rupture tomorrow morning. So I went on to find out a new trajectory where you could avoid the vertebral artery. You went right under the facet, and that could avoid the vertebral artery. The bone was much stronger there. And this got published way back in 2016, but didn't receive much attention. Though it was even presented at the American Association of Neurosurgeons, and even they had kind of taken note of it. The technique was actually making use of the same principle of pedicle screws and manipulating the vertebra using pedicle screws. This concept I had shown in 2016. And then later on, it started getting attention. You can manipulate the C1, C2 by using these pedicle screws. Recently, in 2022, they compared this work, and this is where they published about the superiority of this technique and why this technique should be used and how it is important even in high-riding vertebral arteries. And then again here in India. And then it got published in JNS. And last week, somebody published about it without mentioning my name. So I wrote to that gentleman. And then he replied back apologizing and saying that the next time he'll publish my name. So this happens, like it happened with Dr. Goel. But then again, I shifted my attention anteriorly to find out where the weight transmission is. And way back in 2013, I published the largest series. Till then, most of the series were cadaveric series of approaching the atlantoaxial joints and fixing them from the front. This is the first description in English literature of fixing both the atlantoaxial joints extrapharyngally with plate and screws. So this was another area of interest for me, the odontoid fractures, where they ended up doing posterior C1, C2 surgery. And I went on to describe this technique of, but this was just another anterior cervical fusion. Common anterior cervical, you had to go just 1.5 centimeters above the C2-3 disc. I don't know why, because these surgeries for the C1, C2 were described originally by orthopedic surgeons, and these were posterior surgeries. And we just continued in that tradition. And they were non-microscopic surgeons. And we went on to, if we use the microscope, this is just a child's play to go, under the mandible and reach the fracture and fix the fracture directly. That is the basis of treating a fracture, that you have to fix the fracture under compression. I've been traveling all over the country. So this is passing a subfacet screw. The joint is just staring at you like a disc space, and you can put bone grafts in it. I remember Dr. Bal Murugan, and we had done a case way back in Chennai many years ago. And you could on the table check for stability, whether your job is complete or not, or you could check on the table. The head is not fixed in any Mayfield clamp or something. So you can, of course, this got published in, again, see when it was published in 2016. Then again at various places, this was the construct which I described. So you could treat any fracture of the odontoid. There was no point in doing transoral surgery, then turning the patient and then doing a posterior fixation. You could do everything with this technique of fixing the fracture in compression mode and fixing the atlantoaxial joints at the same sitting in 95% of the cases. Of course, then Jeon made for me these implants, and I used these implants. This technique then went on. I went on to use it for anterior facetal realignment. See, they talk about remodeling the joints and trying to put in the cage or bone grafts in that small restricted area between the vertebral artery. I think all that is not required when they've got a big joint staring at you. It is just a matter of starting and doing the case. After 2 cases, Manas, you will stop operating posteriorly. I promise you. So this was the concept that if you this grab Oakes line, realignment of the odontoid with respect to the grab Oakes line To correct instability, you have to create deformity, you have to create more instability, and that you can do only by cutting the anterior muscles. The patient has got a fixed flexion deformity not because of the posterior muscles, but because of the anterior muscles. Basic anatomy. So if you disconnect the anterior muscles, you have created instability. You can correct almost every deformity, and never say 100% like Dr. Goel, but say 98%. So this is an example you can see. And you can see how you can correct it from the front by putting large cages in the joint and fix. You've got a lot of bone to fix without any worry and without any fear of demystifying basal invasion surgery. Then this was published in Neurospine. Then it came up again in Journal of Neurosurgery, the JNS video section. But I was not happy because there were sometimes cases where the anatomy was not favorable and you couldn't do the fixation. Then the anterior, there is no way to do it. Still, none of the companies have got navigation for anterior cervical spine, especially the high anterior cervical spine. So you can make mistakes like this, and your screws can go out. They can, not go penetrate properly, and you can have complications. Like, for example, this one, there's an over distraction. It has not gone inside. And then I had this kind of case where there was an overriding. You can see the vertebral artery was coming dorsally. I know that Dr. Goel can easily do that. And there was overriding. But then I thought of doing something new. And this is when I went back to the drawing board and I found that it was very easy to pass screws directly into the lateral muscles and into the body. And then I went on to devise this plate. And you can see this is a very simple technique where you don't need any navigation. And you can, again, do this kind of operation where the plate can be fixed. And you see the screw is bicortical. And this is a large screw, 4.5 mm screw. Unlike the 3.5, you can put a 4.5 mm screw. And the entire, it is a single implant, unlike two separate implants. So definitely it is superior to two separate implants. And now you can see how you can put bone grafts into the joint. You can distract that same patient. You see how the odontoid process has come down. The bone graft has been put, and this got published, of course, later on. Then for patients where it was not possible to fix, this is another technique which I had described, which consists of transferring the weight of the skull onto the anterior cervical spine. Even this had got published in neurological research. Recently, my friend Dr. Kalia, I don't know, he likes me. It's the third time he called me to AIMS to demonstrate this technique. So create happiness where you cannot find it. Dr. Goel, this is for you. So there was a case of fixed atlantoaxial dislocation. So it involved refracturing it and then putting again by my technique the screws and grafts inside the joint. And then I learned from his juniors that the patient is doing well. So like Shraddha showed this slide, necessity is the mother of invention. Everything already exists. Search again. The truths are there. No knowledge is original. You have to just keep on churning in your brain and you'll find the answers. This is at AIMS last 2 weeks ago. There are certain unclassified fractures like this, where they didn't. D. Alonso did not describe these fractures, where, what to do. People ended up doing occipital cervical fixations for them. So I described this technique of, fixing the joints as well as correcting for hangman's fracture to treat the C23 instability. And then this techniques and case series was published with Journal of Neurosurgery in 2 years ago. I think 1.5 years ago. And then I was there at the SBNS and I was quite surprised, Dr. Gulash, why they gave me that prize. I had not asked for the prize. And I came back and they sent a letter to me that they found the technique which I showed at the SBNS very nice in our meeting, and I was happy. So look at this face, and look at this face. Is there similarity or no? And they always thought out of the box, And last week he sent me this. I was shocked. He sent me by post a gold medal for excellence in spine surgery and craniovertebral surgery. I remain indeed indebted to him. We have been doing these mock WWF fights all over the world, trying to show people that, we are enemies. But actually, at least I love him. I don't know about him. So in craniovertebral surgery and spine surgery, you have to remember one important thing, neurosurgeon we have to be very careful. Why this search for finding simpler operations? Because the moment you get We are programmed with primum non nocere, but it is not possible. Primum non nocere is not possible always. And if you see, neurosurgeon is the second victim. When there's a complication, what happens to us, nobody knows. How we suffer. Though we put on a brave face and we walk and try to show that nothing has happened. But I think we have to do serious thinking. You see, in literature, the prevalence of imposter syndrome is what doubts about one's abilities and fear of exposure as a fraud is a prevalent psychological condition, particularly among physicians. In neurosurgery, it is known for its competitiveness and demand. This is there even in senior neurosurgeons. They feel frightened. There's something, I'm not good enough. As we become older, we lose the capacity to get complications. We don't want complications. When you're younger, you get complications, you go to somebody senior. When you become older, there is nowhere to turn to. So we have to program ourselves by keeping on learning and keeping in touch with colleagues and. So we end up in guilt and self-blame. And this is more as the hairs become grayer and the hairs become sparser. It is very difficult to accept complications. So what you need a mentor, you need a bicycle, you need a helmet and willingness to get up after the fall. If you're worried about falling off the bike, you should never get on it. But then what is important is this mentor. I found in Professor Ramani was there to hold the bicycle for me till I developed my balance. You have to search for a mentor. They don't come easily. You have to be lucky to get a good mentor. And start with the old bicycles. You can't buy a brand new bicycle like this worth ₹1,00,000 and start learning. Buy an old bicycle. Balance is the key. No book can teach you balance. Balance you have to develop. Truth is more important than the facts. Search for the truth, not for the facts. Success is always only what you see, but you don't know what has transpired to reach there. Never be happy. Keep on asking yourself, is there a better way? Is there a better way? And then you will find a better way. Remember, neurosurgery, the art is long, opportunity is fleeting, and experience is treacherous. As I've reached somewhere, at around about 90, I still got to go. As you become older in the game of life, you see between 85 to 90, there are 3 snakes which are ready to bring you down. One is addictions. Keep away from addictions. Always keep away from addictions. Second is lust. So I carry my wife. Wherever I go, she's there with me. Don't fall trapped with it. Very easy. The moment you get a bigger car and you got a bigger house, this snake is waiting to bite you. And lastly, of course, is pride. He's there at 97. So keep away from these 3. And I'm sure the journey is going to be good. Someday, I was lucky that somebody wrote about me. He was my, like Goel had dragged me into neurosurgery. Professor Nadkarni, who heads KEM, was dragged by me into neurosurgery. At the end of life, what is very important is there should be somebody who's waiting for you. Otherwise, all the money, all the fame, all the name is of no use. Children will grow big and they'll go away. What is this? Us over the years, and still she's there. She never eats dinner without me, and I don't eat dinner without her. So there is intizar all throughout life. You need somebody with whom, who's waiting for you. And I will, before, yesterday there were many people who are coming and congratulating, got lifetime achievement award. So I thought that, I should put a relevant strip over here. Hey, what is happening? Why it is not coming on? Voice sound. Can you increase the sound, please? Hello. Thank you very much, my dear friends.
Thank you, Sushil. It was wonderful. And you really have done a great job for the award oration. And you have sent a lot of message to all the youngsters over here and also to your colleagues and also to the seniors. Thank you very much for honoring us. Thank you very much.
Well said.
It was one of the best oration that I've heard, give standing oration for you for that.
Arey, thank you.
Thank you.
Thank you so much, Dr. Patkar. Thank you so much, chairpersons. I would now like to invite on stage Dr. Raghavendra to give us a short intro about the Brain and Spine Society of Hyderabad and to felicitate some of the prominent neurosurgeons by the Brain and Spine Society.
Sir, it was a wonderful oration. I'm speaking here on the behalf of BAS Society. We felt that we don't get a better platform than these platforms to felicitate the great mentors of our both the Telugu states. So, before the start, I just want to give an introduction about the BAS. The Brain and Spine Society, it was almost established 9 years back. The Brain and Spine Society recognizes the great challenge of neurological disease also to the healthcare in India and encourages the need to meet the challenges. The BAS aims to promote academic and the scientific activity in the field of neurological sciences and provide forum for the exchange of ideas among the neurologists, neurosciences, research, aspiring student managers, and the policy makers. And I'm the member of BAS. Now like to invite the president of BAS Society, Shastri sir, and the organizing secretary of BAS Society, Manas Panigre sir, to on the dais. Please, I request Manas sir and Shastri sir, please come on the dais. Thank you, sir. And I like to and BAS has conducted many national and international conferences at Hyderabad, NSICon 2015, NICE Symposium in 2018, Indo-Japan Neurosurgical Meet in 2018, ACNS and WFNS Meet in 2019, Indian Academy of Neurology 2020, 7th Annual Meeting of Neuroendoscopy Society in India 2021, IFNA Intermeeting in 2022, Society of Image Guided in 2024, and ISPN CME 2024, and the beautiful 2 days NSSA in 2024. And we would like to share that we will be organizing NTSI in 2026. So now we will be feliciting our 4 mentors, and I'll be taking the most 4. We thought who will be better than their seniors, felicitating them. So Shastri sir will be felicitating TV Srinivas sir. So I just given brief introduction about the Shastri sir. Shastri sir actually doesn't need any introduction. Everybody knows about him. He's a guide and mentor to Manas sir. So, sir is an MBBS, MS General Surgery, and MS Neurosurgery. He has a neurosurgical training at the Nizam's Institute of Medical Science and Usmania Medical College in 1978. Along with the great two mentors like Balaparameshwar Rao sir and Raja Reddy sir, he worked in Nizam Institute of Medical Sciences and Usmania General Hospital, Hyderabad. He has been trained in England along with Sen Gupta sir in USA along with Robertson. And he worked as a professor and head of the department in Nizam's Institute of Medical, in the NIMANS, Bangalore for the 20 years. He was also a medical superintendent in 2006. After retiring in hospital, sir now also associated with the KIMS Hyderabad. He has areas of interest of Shastri such as vascular surgery, brain tumor, neurotrauma, and a lot of experimental research. To say about it, he has published more than 100 papers in both national and international papers, and he has trained more than 100 neurosurgeons in the MANS. His experience is more than 45 years. Recently, sir has been awarded with the Lifetime Achievement Award by NSI in 2019. So now I request Shastri sir to felicitate one of our mentor, TVS Srinivas sir. Please, I request TV Srinivas sir, please come on the dais. TV Srinivas sir. TV Srinivas sir is an MBBS, MS, MCH. He has worked as a professor in HOP Gandhi Medical College, Usmania Medical College, and SVS College, Tirupati. Sir has many publications and also he now works as a Chief Director, Consultant Neurosurgery at the Sai Krishna Super Speciality Hospital, Hyderabad. And he received the major awards in the Best Medical Officer in 1986 and Legends in Neurosurgery. He is a present Telangana Neuroscience Association President. So, please give him a clap. Now we will be felicitating Maleshwaram sir. So I request Professor Dinakar sir, please. Dinakar sir is an MBBS, MCH in 1968. He worked as an assistant professor of neurosurgery in AMC Vizag, professor of neurosurgery and neurosurgery at Andhra Medical College Vizag, and professor and head of the neurosurgery NIMS, and dean of the NIMS, and director in charge of NIMS, and director of NIMS from till 93 to 96. He has received more than 30 awards. He has more than 304 publications. I feel that you have to give a big popular man on 304 publications, and he has presented 125 conferences and more than 20 neurological topics he has written. There is not only interest in neurosurgery, he has a lot of interest in music. So now I request Maleshwara sir, please come on the dais. Maleshwaram sir works in the is an HOD of neurosurgery in Rangaraya Medical College, Kakinada. No, sir. Sir also worked in Narayana Medical College, Nellore, and Mamata Medical College, Khammam. He is an emeritus professor of Rangaraya Medical College, and he also has been a chief for DNB Neurosurgery Apollo Hospital, Kakinada, and he is the main important chairman ethics committee of Rangaraya Medical College, Kakinada. He has guided more than 15 years. He's been training the PG students, and he is a past president of Andhra Pradesh Neurosciences Association. Please give him a big applause of hands. Now I request Satyanarayana sir, please come on the dais to felicitate Purohit sir. Satyanarayana sir is one of the senior most neurosurgeons in the Twin Cities, obtaining MCH and from the CMC Vellore in 1973. He has become the head of the department of Usmania Medical College and also in the Gandhi Medical College. He worked as a superintendent of in the Usmania Medical Hospital. He also worked in the department of neurosurgery in Kakatiya Medical College, Warangal, and he worked as a director of medical education in the government of Andhra Pradesh. After retirement, sir has his own hospital, Vijay Healthcare, which is known for his a lot of patients load in the Secunderabad area, and he is presently the president of Geriatric Society of India. Now I request Satyanarayana sir to felicitate the Purohit sir. To speak about Purohit sir, I was searching an article. There was a published article in Neurology India by Suchanda madam saying that Professor Anirudh Purohit neurosurgery a neurosurgeon with the difference. Please, I request Purohit sir, please come on the stage. Purohit sir is an MBBS, MS, MCH. He has worked almost all his career through NIMS, Hyderabad. His current position is a senior consultant at Aster Prime Hospital, Hyderabad. And madam has written that he is the first to come to all the academic classes in that, and he is known for his cerebral palsy treatment. And in that, I took one line in that neurology publication saying that his family is considered God for him, God on the land. This is the word one of his patients has written on it. He frequently attends all the national and international conferences and gives lectures on spasticity. He is the first Indian Academy of Cerebral Palsy, and the annual conference was organized by Purohit sir at Hyderabad in 2006. He also established Indian Journal of Cerebral Palsy, which is there. Not only in that, sir is very much in the Hindi literature. He has written all the English, the scientific data in the Hindi also. Please give him a big applause of hand. Peter sir.
आज इस सभा में उपस्थित सभी गणमान्य व्यक्तियों से मैं आज यही कहना चाहूंगा कि पहला तो बड़ा कोइंसिडेंस है कि आज हिंदी पखवाड़े का मध्यकाल है, 21 सितंबर 14 से 28 सितंबर के मध्य में। और बड़ी अच्छी बात यही भी हुई थी कि यहां पर कोरिया से आए हुए हमारे गणमान्य ने हिंदी में आपको बहुत बहुत धन्यवाद लिखा हुआ भी पाया है। ये अवार्ड कोई मुझे नहीं मिला है। जब कभी भी कोई शिशु, द न्यू बॉर्न बेबी व्हेन इज बॉर्न इज नॉट अवार्ड, लेकिन उसकी पूजा की जाती है, उसकी मां की पूजा की जाती है, लेकिन उसे कोई अवार्ड नहीं दिया जाता। जीवन में वह जब आगे बढ़ता जाता है, स्कूल में, कॉलेज में और अपने अध्यवसाय में, अपने जॉब में, जब वह किसी अच्छे काम को करके दिखाता है, when he contributes something in his life because of the contribution by many other people in his life, he contributes to others, and that is what has happened in my life. My father gave me the left brain, संस्कृत के बहुत बड़े विद्वान थे। My mother gave me the right brain, दिल की वो बहुत करुणामयी थी, and all these two, right and left brain, got balanced through the corpus callosum in my life. And that is what we all have got, the right and left brain, masculine and the feminine. And as you proceed in your life, when I started doing my neurosurgery also, whenever I wrote something, cerebral palsy, pehla vijay kadam, any time when I go and write, my father is in front of me, लेकिन उसी समय मेरी माताश्री एकदम प्रकट हो जाती है, and something comes from my heart also. So brain and heart got balanced in any of my writing. And today I am very lucky that what is good in our life, एक होता है pleasure, दूसरा होता है happiness. लेकिन हिंदी में आनंद, और सबसे बड़ा आनंद होता है प्रेम आनंद। और आपके जीवन में यदि शांति है और आप एक शांति के अवतार बनकर यदि इस पृथ्वीलोक पर अपना भ्रमण कर रहे हैं, तो प्रेम के आनंद में राम, शांताराम यदि आपके साथ में है, और शायद आपको पता नहीं होगा कि पूरा नाम डॉक्टर रमानी का प्रेमानंद शांताराम है। उनके माताश्री पिताश्री ने शायद के पांव पालने में ही नजर आते हैं, और शायद यही हुआ होगा कि उन्होंने तभी इनकी प्रतिभाओं को देखा होगा और उन्हें प्रेमानंद शांताराम एक अवतार के रूप में आज हमारे सामने प्रस्तुत किया है। और शब्द रमाणी, यत्र नारिष्य पूज्यन्ते देवता तत्र रमन्ति, जहां जहां नारी की पूजा होती है वहीं पर देवता रमन करते हैं। और कल डॉक्टर भास्कर ने आपके नाम का संधि विच्छेद थोड़ा बहुत किसी भाषा में किया है कि रममणि। तो वह मणि, वो हीरा, वो डायमंड जो घूमता रहता है, रमता रहता है, रमंती। तो आज हमारे बीच में शांताराम, प्रेमानंद, रमानी साहब उपस्थित हैं, और जिन्होंने अपने जीवन में अपने परिवार का जो उन लोगों ने बचपन में देखा वह आज उन्होंने करके दिखा लिया है। उसके लिए मैं अपने हृदय की गहनतम गहराई से उनका अभिवादन करता हूं। और एक और अभिवादन यह करता हूं कि सर्जन्स को जैसे कहा जाता है कि ईगल्स आई, और मैं कहना चाहूंगा कि डॉक्टर मानस, आप यदि कभी डॉक्टर मानस से मिलेंगे तो एक बार आंख में आंख जरूर जाएगी, और आप देखेंगे इतना प्रेम प्यार उनकी आंखों से टपकता है। आई थिंक हिज ईगल्स आईज आर टू सी द फ्लावर्स, द लोटस इन अदर्स। Thank you very much, Dr. Manas, that you selected me, but actually it is the award of my whole journey of my school life, my parents, and then college, and then Nizam's Institute of Medical Sciences, all where whatever blessings I got and contributions could make it. It is the contribution to all those things, and I'm grateful to that you have recognized those services. एक अंत में और कहना चाहूंगा कि जो आपकी फिलोसॉफी रहेगी कि एक बच्चा अपनी माँ के पास गया जिसके 10 भाई बहन थे और बोला कि माँ मेरे को ये बताओ कि ये बच्चे आते कहां से। एज यूजुअल भारतीय माँ ने कहा कि बेटा बच्चे तो भगवान के यहां से आते हैं। वो दौड़कर मेरे जैसे साइंस स्कॉलर फादर के पास गया और बोला पापा मेरे को ये बताओ कि बच्चे आते कहां थे। तो साइंस स्कॉलर बाप ने डार्विन का सिद्धांत लगा के बोला बेटा हम तो बंदरों की औलाद है, आवर एंसेस्टर्स आर मंकीज। आप दौड़ के मां के पास गया, मां मैं तो बड़ा कंफ्यूज हो गया। आप कह रहे हैं कि बच्चे भगवान के यहां से आते हैं और पापा कह रहे हैं कि बच्चे हम बंदरों की औलाद हैं। मम्मी सच्ची बताओ कि बच्चे आते कहां से। तो मां बोली बेटा मैं अपने वंशजों की बात कर रही हूं, ये इनके वंशजों की बात कर रहे हैं। वह जैसा कि आतुर होना चाहिए, वो फिर अपने मां के पास गया कि अच्छा मां फिर ये बताओ कि हमारे बात में कौन भगवान को देगा। तो मां बोली उस अनंत का तो मुझे भी पता नहीं। फिर वो साइंस स्कूल फादर के पास गया और बोला कि पापा मेरे को ये बताओ कि यदि हम बंदरों की औलाद हैं तो बंदर किसकी औलाद है, वो किसकी औलाद है, वो किसकी औलाद है। साइंस स्कॉलर बाप ने कहा कि उस अनादि का तो मुझे भी पता नहीं। तो अनादि से अनंत, साइंस और स्पिरिचुअलिटी के बीच में आज हम सब उपस्थित हैं। ये जान लेना चाहिए कि हम आज जो हैं सही में यह सही है या नहीं है। उसको डॉगमेटिज्म, जो कि बहुत अच्छी तरह अभी प्रस्तुत किया गया था, स्वमताभिमान हम में नहीं होना चाहिए। जस्ट बैलेंस द राइट एंड लेफ्ट ब्रेन, प्रेम प्यार और उसके साथ में विज्ञान। इन्हीं सब के साथ में पुनः आज आप सभी का जिन्होंने इसको आज महत्व दिया है या अपनी उपस्थिति करके, उसके लिए मैं वापस से अपने हृदय की गहनतम गहराई से आपका आभार व्यक्त करता हूं। नमस्कार।
Please sit down, sir. Next year we are having meeting in Coimbatore, and morning in the EC meeting they were discussing we should get Sadhguru. And last year they could not get, the struggle. But then, as I told, we look at ability of Hyderabad, and we don't need Sadhguru. Professor Purohit has given a very good lecture, so he spoke well. Thank you, and I'd like to request Dr. Professor Srinivas to tell a few words.
Good afternoon to everybody. I am really honored and overwhelmed with joy. And from the bottom of my heart, I wholeheartedly thank Manas and his team for this honor to be given to me. And my association with Manas has been more than 3.5 decades, where I went for training in MANS, even though I am from Usmania Medical College and Hospital. At that time, because our hospital did not have infrastructure, I was sent to NIMANS for advanced training, where we were we had training, and at the time, Professor Shastri was there, who taught us the advanced at that time with microscopic training, etc. Thank you. Thank you all. Yes.
Thank you, Professor Srinivas. Nizam's, when I was working at Nizam's, Professor Srinivas and Professor Satyanan was HOD. We had a good, normally in any institute and medical college in any city, they are at loggerheads, but we had a very good relation. Professor Satyanan, he was the director of medical education. Rather, he called me many times. I had just come back from US doing skull-based fellowship. So he said he come and teach our residents. So it given me opportunity to go to the medical college, do some cases there, some cavernous sinus tumors exposure and all those. And that is the beauty of Hyderabad. And with this, I'll request Professor Malleshwar to say a few words.
Thank Surgical Society, Urological and Neurosurgery Spinal Society of India and Brain and Spine Society of India. I'm very much thankful to you all, and I'm very much indebted to Dr. Manas. Manas was student when I went to NIMHANS, but the younger generation, many residents I have seen here, has to emulate him. Daily he sees so many cases, 100 OP, 5 to 6, 7 operations, and yet he publishes papers. And yet he joins all deliberations, all conferences, all workshops. That's what I tell my residents to learn from him. Just because you are doing, some people operate, they're called real, not tigers, some are paper tigers. They go on publishing papers, but while asking to do surgery, they will not be able to do. Some are real tigers, like Manas. But the real tigers also will not produce papers. He is not only paper tiger and real tiger, both. That's what I advise the residents. I don't know how he does so many OP, so many operations, but yet he participates all over India and other AP and Telangana conferences. He is very active. So I thank Dr. Manas, Dr. Raghavendra, and one small thing I want to tell, because I'm getting bolder, the residents is, a surgery done by a neurosurgeon must be different from a surgery done by an orthopedician. That's where you have to score. That is my message to the residents. How you will do, how can learn it? By coming to such conferences, by learning tomorrow. Tomorrow workshops will see that you are better than an orthopedician. Thank you very much.
Thank you, sir.
MRC Naidu, sir, he couldn't make out due to his personal reasons. So on behalf of MRC Naidu, sir, I request Dr. Ravi, sir, please come on the dais. Ravi, sir.
Is he outside? Huh? Dr. Ravi. In the meantime, we call Professor Ramani. Meantime, I'll request Professor Ramani to come out to the dais. On behalf of organizing committee, we want to felicitate him.
We are going to break for lunch, but before that, I would request everybody to come up on stage so we can have a group photograph.
Hi. You are now working with Atul.
얘를 여기다 저녁 식사를 한다고 그래서 호텔을 조금 더 저기 어차피
그러니까 레이트 체크한.
But everybody who's taken part in the lucky draw, please submit your forms back in the registration counter. If you haven't yet taken part, please pick up your forms, get them filled, and submit them in the registration counter, please. Thank you.
अच्छा फोटो मैं स्माइल नहीं A very good afternoon. Welcome back. We are now heading on to the session 3, that is an endoscopy 1. May I request Dr. C. Koon Kim, Dr. Ajay Reddy, Dr. Anil Kumar for chairing the session, sir. So please come on to the stage. Dr. Ajay Reddy, Dr. Anil Kumar.
Hello, good afternoon, colleagues. Now, welcome to the afternoon first session. This session is MIS endoscopy. The order of the speakers changes. So the updated, the first speaker is Dr. Hrishikesh Karosekar from the Mumbai. His topic is endoscopic interlaminar approach for spinal tumors. Actually, he was supposed to talk at the session 4, but he needs to change. So, okay, Dr. Karosekar, please.
Yeah, thank you. I would appreciate the organizing committee for allowing me to speak early as I have to catch a flight. So I'll be starting with endoscopic approach, interlaminar approach for spinal tumors. I am Dr. Hrishikesh Karosekar. I'm working as an associate professor at Grad Medical College, Mumbai. So spinal surgery all over the world is undergoing a revolutionary change in terms of biomechanical concepts, motion preservation. More number of spine surgeons are now using endoscopic techniques for wide range of pathologies, mainly for disc prolapse and degenerative spine, but now to spinal tumors also. And this has made because of the progress in technology, more sophisticated devices, 4K HD camera, and now newer exoscope. So the different techniques for spinal endoscopy, these are mainly invented for prolapsed disc and degenerative spine. They can percutaneous transforaminal approach, uniportal, biportal, unilateral biportal, then which I do is Destandu technique, that is interlaminar approach, and then endoscopic assisted or exoscopic spine surgery. So why there is need of endoscopic spine surgery? Because it has the advantage of lesser incisions, lesser tissue dissection, motion segment preservation, less morbidity and early mobilization of patients. It gives the better cosmesis, the approach is target, and it maintains the biomechanical stability. What are the limitations? You cannot do it for multi-level pathologies, for infective lesions like tuberculomas, long segment tuberculomas, vascular lesions like spinal artery aneurysms, when the spine is grossly unstable, and for large tumors. The prerequisites for spinal endoscopy is you have to know the anatomy thoroughly, you have to know the biomechanics, understand the disease process, and you have to make right choice for right patients. Not every patient is for spinal endoscopy, and you have to be familiar with the operating technique and tool whichever you are doing. And definitely there is a learning curve for spinal endoscopy. So which technique I use in our institute is invented by Dr. Jean Destandu in 1993. It has a principle of triangulation between the scope and sections, which make a 0-degree scope as an angulated scope. These are the instruments for endospine system. So I would like to share our experience in spinal tumors. So we have done total number 22 cases, purely endoscopic interlaminar 10 and endoscopic assisted 12. So more of a male predominance. We had one nil CSF leak and one cord contusion while doing a meningioma. So most of them were meningiomas and neurofibromas. So this is the important part of any surgery is position of the patient, which we prefer is prone position, which was described was a knee chest, or what Dr. Rohidas does is modified knee chest position. This marking of the lesion, marking of the level is very important, especially in tumors like in disc. You just mark the disc level. For doing spinal tumors, you have to mark the upper disc level and the lower disc level. What an advantage of this system is you can do with unilateral incision, you can have a bilateral visualization by just going under the spinous process. So this is a neurofibroma. Exposing the lamina. All part of muscles have to be removed. Start the drilling at spinolaminar junction. Detach the ligamentum flavum from undersurface of the lamina. In the dura. Then the steps are same. Exposure is almost same. Only the incision is small. Gradually deliver the tumor in piecemeal pattern. Cannot completely in toto remove the tumor in endoscopy. We close the dura with inlay and outlay, tearing of dura patch. Case of meningioma. Again, the exposure is same. The tumor. Difficult part in this is the attachment of meningioma to the dura. The calcified part of attachment needs to be coagulated. Hemostasis can be achieved with coable gelatin, well closure with well patch. Intramedullary tumor, conus rhamoid. Bulging. As next day. Cervical arachnoid cyst. Referred with quadriplegia. Some other hospital he was tried to tap this arachnoid. Open and marsupialize the cyst. The capsule. endoscopic assisted technique. Advantage of endoscopic assisted is you can use both of your hands and it's fixed on the holder. You can also preserve the root from which the and even dura can be closed with endoscopic assisted technique. In a case of lumbar neurofibroma. So definitely there is a learning curve in mastering this endoscopic approaches safely and effectively. This can be achieved with class studies, cadaveric lab fellowship, working with an experienced endoscopic surgeon. However, careful patient workup and selection is also critical in providing effective, minimal invasive spine surgery care. Conclude, endoscopic spine surgery is evolving field. It represents a departure from the traditional spine surgeries in several ways. It has several advantages for patient as less morbidity, early mobilization. However, loss of tactile feedback, hand-eye dissociation, different operative angles, decreased operative view with narrow working challenge can make the things a learning curve steep. However, with proper attention, each of these variables can be mastered. Thank you.
Okay, thank you, Dr. Kurosaka. Nice work. We have the discussion comment. Let me ask you, you demonstrate a case of intramedullary tumors. What was the pathology?
Dermoid.
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 Ah, I see. So it was liquefied. Okay.
Yeah,
And
luckily.
what about any difficulties in case of intractable bleedings or
Yes.
the CSF leakages?
Yeah,
Is
most
there any
no.
tips to the audience?
No, luckily CSF leakage till now we have not encountered. Can be there because we are not closing the dura. I have not encountered. Maybe because the incision is small and the muscle comes over, covers it. Yeah, hemostasis is a trouble initially, especially in meningiomas. But we could manage it with flowable gelatin because coagulation is difficult.
Okay. Okay. Any more questions or comments? Okay, go ahead.
Yeah. Fibrin glue, yeah, with sealant.
Yeah, great work. It was the same question. How is the experience regarding the use of small staplers and the usage of hemopatch as has been propagated by the Baxter?
Hemopatch is good. It can be used. Staplers I have not used.
Okay.
Thank
Nice
you.
work. Thank you.
Thank you.
I'd like to call the next speaker, Dr. Ahmed Ansari from Aligarh. This is a talk on right side pathology, left side standing approach, UBE spine surgery.
Thank you all. At the outset, I want to thank the organizing committee of NSSA, Professor Manas, Dr. Savitra, and my good friend Dr. Sai Kalyan for inviting me in here. Apologies for the bad throat today. I was speaking on a very simple and easy topic: right side pathology of the spine with a left side standing approach for a right-handed surgeon, with incision given on the right side of the spinous process. So before beginning it out, a very brief history. So it was in 2013 when Jin Hwa and Dr. Son from Korea, they first started the SMIS, they first presented on stenosis decompression and the endoscopic decompression of lumbar stenosis using UBE. Further, in September of 2013, it was Dr. Son from Korea who had the first presentation for endoscopic fusion. It all started in the year 96-98 when Dr. Antoni, he had first published regarding translaminar lumbar epidural endoscopy in the Journal of Arthroscopy. Further, endoscopic lumbar discectomy, as was initially published in the year 2001 by Dr. Abdul Ghaffar, which was further published in the Korea-Japan Endoscopic Conference regarding the UB for lateral discectomy by Dr. Jung in 2003. Now, when we talk about the evolution of minimally invasive spine surgery, It had propagated from open surgery to tubular to further to endoscopic spine, or it may be whether it be a monoportal or a biportal scope. Regarding UV, very simple, same as the scope surgery regarding the usage of arthroscopy in joint surgery with fluid involvement. The difference against arthroscopy in joint surgery is regarding the working space which needs to be created in the endoscopic spine surgery. Why again UV in most of the surgeries? As most of the instruments can be used which are of the normal usage in our operation theaters, except for the presence of an endoscope, which we may also use as the one which we are using in the cranial endoscope, which is a 2.7 endoscope. All the other instruments can be are readily available in our OTs. Now, where we are exactly in open surgery, though we can deal with all cases, but it's pretty destructive. Microsurgery, again, the tubular approach, I would say less destructive, but still we are some way behind. Now, where we are right now, we can use either uniportal, which may be in the form of transforaminal and interlaminar. Early period, it was minimal invasive, but had limited indications. But recently, though minimally, but had a wide indication with the device developing. Biportal, it has no indication, no specific limited indication with MISS benefit. Regarding the difference with open surgery, of course, when we use the endoscopic with the fluid medium would be acting as a suction thing, I would say, because it removes all the blood and all the false cavities in there. It's again the art of water flow in UV. The inflow and the outflow needs to be very well coordinated. A very good incision over the fascia, in fact, a generous incision of the fascia would help in further movement of the fluid. Second thing is the triangulation, which we can say again an open or an open triangulation in which the instrument is not readily visualized, early triangulation in which the instruments fight with each other with no definite scope. So the next thing is the skin marking. Again, the mid portion of the spinous process with the upper end, with the upper part of the disc and the middle margin of the pedicle are taken into consideration with a 3 centimeter distance between both the scopes. Now, these all markings depends on the pathology we are dealing with. Supposedly, a right-handed surgeon, which most of us would be sitting in here, we are dealing with right-handed with a right side pathology. Now, in most of these pathologies, what most surgeons are either doing, they would be standing on the right side of the patient, or in other terms, they might be standing on the left side. But in that case, they might go for an over the top, meaning thereby they would be drilling a part of the lamina on the left side, and then down into the spinous process, they would be dealing with the pathology on the right side. Just I would be showing in here. Just like in this case, in which the left side has been opened up, and we can move slightly, we can move directly towards the right side to deal with the pathology which is on the other side, meaning the surgeon is a right-handed standing on the left side of the patient, and he can move to the opposite side to deal with the pathology. Second thing, again, is the skin marking might be different. In cases of foraminal stenosis, we can see in the lateral view, the scope is directly over the foramen directly, and the AP, it may be 1 centimeter lateral to the vertebral body. So again, scopic view, it all depends on the type of pathology we are dealing with. In here, we can see a total decompression of the foramen. We can see the nerve root clearly visualized. We can feel the nerve root totally decompressed. So again, the concept of working space in cases of UV, especially when a right-handed surgeon is taking up pathologies over the right side, is the initial working space, the potential space, which is between the lamina and the multifidus. So this one is the initial working space, and the true working space is after the removal of the lamina, and of course, a part of the ligament flavum. As it is removed, the true working space comes into view. Now the saline flow, the scopic portal, as it moves by, it creates a space between the lamina and the multifidus. Again, some pressure is again directed through the saline, through the portal space, in order to make space or a bulge into the multifidus. Note the outflow must be very properly directed. Now, usually when a surgeon is a right-handed and a left-sided pathology is dealt with, the scopic portal is caudal, is a cranial, and the working portal is caudal. For a right-side pathology, the scope portal goes downward, meaning the scope portal is caudal because the surgeon who is a right-handed is standing towards the right side of the patient. The best way to deal with the pathologies is for making the initial triangulation is to use two spinal leaders. With the help of two spinal leaders, we can mark very clearly the port of entry into the skin and the point of its hit over the lamina. Now, what we can see over here is a right-handed surgeon. He is standing on the right side and has dealt with complete decompression over the right side pathology. And from the right side, we can go directly in the same way as we go from left to right. We can get an over-the-top decompression. Same way, what we are seeing over here, it was a multiple level fixation, and the patient developed an adjacent segment disease at the upper level directly afterwards. So what we see in cases of a left-standing approach, what we are seeing is the initial view in which the lamina is very much clearly seen. Once the lamina is very clearly seen, this is the view that needs to be taken out. The caudal portion of the cranial lamina, which is easily visualized over here, it needs to be properly visualized, and the drilling starts coming into view. The caudal portion of the cranial lamina is drilled somewhat, as we can see in here. It is thinned out. Note the incision is towards the right of the spinous process. Further, the usage of punch, we can use again we can use the punch to again remove a portion of the caudal portion of the cranial lamina. We can again use the bipolar or the plasma to remove the to coagulate a portion of the ligament flavum over there. And as the further part of it is complete over there, I'll just take one more minute. We can just remove the portion of the ligament flavum. Complete removal is done over there, and we can see the removal of the disc in here. Complete portion of the disc can be removed, as we can see. So all in all, what we are seeing in here, once the final removal of the disc is done, we place the final drain over there, and once the scope is taken out, the whole of the musculature falls into place. So all in all, right side pathology can be dealt very beautifully by a right side standing on the left side by a right-handed surgeon by making an incision to the right of the spinous process and dealing with the pathology directly over the right side. Thank you.
It was a nice presentation. So, any questions? There are no questions. There's one question from my side. You're using the drill. So, do you use any guard for that, or you just use that?
At times we are using the guard, but if there's a ligamentum flavum downwards, if there is a free ligament flavum, mostly there is minimal chances of an injury over the dura.
Thank you.
Thank you. Now, may I call the next speaker, Dr. Jayant Gaud, Pune, the PSL for lumbar canal stenosis, steps their experience. Dr. Gaud, please.
Hello, good afternoon, everybody. Thank you for giving me this opportunity. So I am here today to discuss about percutaneous stenoscopic lumbar decompression. I would like to thank my teachers who taught me the concept of spine and spine surgery. So we know there are the surgery for spinal stenosis is a decompression, and as a evolution, the incision is becoming smaller, but the aim is to achieve the same decompression what we achieve by open surgery, and it has to be achieved with the endoscopic spine by only 8 millimeter of incision without minimal or with minimum collateral damage. So this is the AO spine nomenclature. We know the benefit of endoscopic spine surgery that our eye is within the canal, so to do maximum decompression with minimum collateral damage. So these are the different generation of endoscopies. First generation is transforaminal endoscopy, where the small scope is introduced from the transcambian route. The main indication from our side is annular fissure, non-migrated or small, very less migrated discitis patient. Very experienced surgeon can do highly migrated disc and stenosis cases also. So the second generation is interlaminar surgery, in which we can directly introduce the scope with wide canal like L5S1 or sometimes L4-5 canal, and we can do the discectomy from it. But the limitation for this interlaminar surgery is it's very high difficult to do bony work in cases of stenosis. So for that, the third generation scope has come, that is stenoscope, and we can do translaminar surgery with the help of stenoscope. So in 2017, Dr. Kangtek Lim introduced the scope. The scope is around 9 to 10 millimeter outer diameter with 5.5 to 7 millimeter working channel. 10 to 15 degree, different companies having different degrees of scopes. So what we can do with this stenoscope? We can do discectomy, we can do lateral recess stenosis, we can do cervical laminoforaminectomy, cervical laminectomy. Now we can do dorsal decompression. Even people are doing ACDF and OLF cases also. So what is this stenoscope? Stenoscope is a channel scope. It is having a working channel, optics. There is a irrigation channel, outflow channel, and a illumination. So the next important tool is a drill. So drill should be, it can be a high torque drill with lesser RPM, or high RPM drill with sufficient amount of torque. The next important tool is RF or plasma to achieve the coagulation and dissection of soft tissue. These are the different instruments we can use from the stenoscope. Most important things are Carrison punches, graspers, hook, dissector, and annular cutters. One of the most important, but few people keep it as optional, that is pressure pump to maintain the pressure between 30 to 70 millimeters of mercury. So this is the OT setup. I am presenting an index case for stenoscopic lumbar decompression. The most important thing that these are all high equipment based surgery, so all instruments should be checked beforehand. We prefer to have GA to control the BP and to have a clear field. Elevation stand is important to relax the arm. So this is a 60-year-old female diagnosed with L4-5, L5S1 lumbar canal stenosis. So this is the position we prefer to give erector spinae block before surgery. Our aim is to target spinolaminar junction first. So this is the incision with 11 number blade. Then we dilate the track with artery forceps. We put a dilator, and then a sleeve insertion is there. So our aim is to see spinolaminar junction once we put our scope. So 9 o'clock is the cranial end, 6 o'clock is the IAP, that is the lateral end, 12 o'clock is medial end. So this is the tip of IAP. The next step is drilling of cranial lamina and IAP. So we drill the cranial lamina till we see the detachment of the ligamentum flavum. And a small part of IAP we have to drill to do lateral recess decompression, ipsilaterally. We can use Carrison punches. The next important step is to identify caudal lamina. So to identify caudal lamina, it is important to remove the superficial layer of ligamentum flavum to see the caudal lamina. We can use curette to detach the ligamentum flavum from caudal lamina. To go contralaterally, we have to drill the base of the spinous process. It is very important to keep the ligamentum flavum intact, the deep layer of ligamentum flavum intact to to avoid the injury to the nervous tissue. So the next step is drilling the contralateral cranial lamina and IAP. So we can see the contralateral IAP and cranial lamina. The next important step is detachment of ligamentum flavum from contralateral caudal lamina. After that, we can do the ligamentum flavum removal. We can do ligamentum flavectomy piece by piece mill or en bloc. Anything doesn't matter. So now we can see the ipsilateral traversing route. The same thing we can do contralaterally. This is the contralateral traversing route. In disc pathologies, we can do discectomy. We always do annuloplasty, RF annuloplasty after the surgery. So this is the post-operative, this is the immediate post-operative incision. We always keep drain for 24 hours. This is the post-operative MRI. So there are few complications can be associated with the surgeries, that like incomplete decompression, dural injuries, hematoma. So it is important to maintain the BP less than 30 millimeters of mercury before removing the scope, remnant disc or pressure injuries. So we can do endoteleif with the in cases of disthesis. So till April 24, we have operated around 52 cases. Definitely, most of the cases were single level L4-5. Average time required was 1.5 hours. 3-level cases, it took almost 4 hours. So definitely, visual analog score and Osworth disability index is significantly reduced in immediately as well as after 6 months. And our results are comparable with the published studies. Thank you.
Okay, well done, Dr. Raut. So, any questions, comments from the floor? Okay.
Canal stenosis, we prefer only the exiting route, only the traversing route.
No, we can see by like if there is a foraminal stenosis, we can do contralateral exiting route decompression also.
What about the ipsilateral?
Ipsilateral, it takes very difficult to do it because of we have to sacrifice a lot of parts.
Basically, if you talk about the 4-quadrant decompression in spine endoscopy, be able to achieve it.
We can. Yeah.
4 quadrants or only the, because you have shown in the video,
Yeah.
you have decompressed only the traversing route,
Yeah.
not the exiting route. I think
In
most
this,
of the cases, the pathology lies in the exiting route, and that is the reason why a patient are not able to that benefit which open surgery they get.
in this patient particularly, there was no foraminal stenosis, and that's why we have done only traversing route decompression. Exiting route decompression, we always go till superior pedicle for contralateral side. Ipsilateral side, most of the time we avoid to
because we cannot do it with
monoportal thing.
Okay, Dr. Carlo, well done. Oh, yeah, make it quick, please.
Nice presentation, Jayant.
Thank you.
About the question which was asked, 4-quadrant decompression. Endoscopic surgery is a targeted surgery. It is not a blanket surgery. If you're not seeing any pathology on the exiting route, you did not do it. That is the most important thing. Jeopardizing the thickness of the pass is something that we are not going to see immediate effects. The effects are so going to be seen much later on. So it is better to avoid things and not to decompress it just for the heck of seeing the root. We just should decompress what is necessary. Thank you.
I think in canal stenosis, it is more important on the pathology lies on the lateral lysis, not on the central canal. So is a lateral lysis also includes the exiting route, or only the traversing route?
See, the stenosis is divided mainly. For endoscopic spine surgery, we divide it into 3 parts, like a central stenosis, lateral recess stenosis, and foraminal stenosis. So we have to see where the root is getting compressed. So every time there will not be traversing route, exiting route will be compressed. If their exiting route is getting compressed, we definitely go from opposite side and do contralateral decompression. But we'll not damage the pars for doing this for the
Is it possible to have a only central canal stenosis
no,
without lateral stenosis?
no. Most of the time we will be always having lateral recess stenosis. The main complaint is the lateral recess.
Lateral recess also includes.
The foraminal part and lateral recess we always find it like different. So to do the foraminal stenosis, we always go from the contralateral side.
Okay, Dr. Gaud, well done.
Thank you.
We'll invite next speaker.
So we are running late, so I'll like to call Dr. Vishwaksena Reddy. He's going to speak on functional outcomes following endoscopic decompression for a multi-level lumbar stenosis.
Yeah, very good afternoon, everyone. I'm Dr. Vishwaksena Reddy, a consultant neurosurgeon, Star Hospitals, Hyderabad. At the outset, I would like to thank the organizing committee for giving me an opportunity to present my work. This topic is about functional outcomes following endoscopic spine surgery, endoscopic over-the-top decompression whenever multiple levels of lumbar canal stenosis is there. And when I started off with doing endoscopy spine surgery way back in 2019, there were many techniques available. So there were in those times there were many techniques which were mainly fixed, but I preferred going for descendo because it was a mobile technique. It was a very versatile technique, I felt, and I could use it in cervical, dorsal, and lumbar, and multiple levels can be approached through same incision. So the conventionally, so what we have been practicing is a descendo technique where we go interlaminar and we do a ipsilateral decompression followed by over the top decompression of the opposite root. So in descendo technique, which was initially started by Professor Dr. Jean Descendo, who is a French neurosurgeon. So when I started, it was the cheapest of the instrumentation. And the anatomy was familiar and interlaminar approach was a more familiar anatomy. So I preferred going that. So this same system can be used for cases, especially in cervical, dorsal, lumbar, everywhere. And it can be used for cases where there is recurrence also in case of tumor. And the same system can be used for fixation also. And these are the conventional instruments of conventional instruments. So majority of the instruments are the operating tube with an working insert with an operating tube and the suction. This is the annulotome and this is the bipolar and these are the dissectors and a hook. And rest of the instruments, these are the same instruments we use for open technique also. So the working insert and the operating tube, they work at an angle of about 12 degrees, which will give us an angulation. So this will help us in avoiding clashing of the instruments. And the apertures which are there in the operating tube are one for the telescope, one for the suction, one for the surgical instruments to pass, and one is a root retractor, which is optional. Positioning, it would be the same, whatever is the bulk of the patient, whether the patient is bulky, thin milled, whatever is the bulk. So the conventional procedure is an E-chest position, but I generally use this the image on the left side. It's a conventional prone position with a break in the table. And we use a localizing device for the localization of the level. This is the localizing device. And once the CM is placed and marked, and the disc space is marked, we give an incision. The incision is about roughly 2 centimeters, about half to 1 centimeter away from the midline. The fascia is cut in the same incision and the muscle is dissected out from the spina and the lamina. And the tube sits about 50% on the lamina and 50% on the ligamentum. And even if multiple levels of compression is there, we can repeat the same procedure at each level. So this is a conventional single level and multiple level after localization. So the most common pathologies we see are between L4-5 and L5S1. So the same in one single incision, we can approach both the pathologies. And this is a mobile system. So just by tilting the scope, we can approach both the levels. That is the lamina where we have docked the instrument. So till date, we have operated about 271 patients using Descendo technique. Of these, there were 45 patients who had multi-segment lumbar canal stenosis. Whenever two levels or more were involved. The inclusion criteria were patients with typical neurogenic claudication with associated with or without radiculopathy, and there is a neurological imaging which is suggestive of multiple level compression, degenerative stenosis, and without any instability. And over the top decompression using Descendo technique was performed in all these cases. So the average age was between 40 to 85 years, and majority were male patients. L4-5, L5S1 was the predominant multi-segment involvement, followed by L3-4-4-5 and L3-4-4-5 and 5S1, only 2 patients. And one case we had operated for L2-3, 3-4 and 4-5 levels. So the average operating time was between 2 to 4 hours, and there was dural tear in 2 patients, which we could deal with intraoperatively. There were no post-operative complications, and the average hospital stay was 1 day. All patients were given a shot of antibiotic 1 hour prior to the incision and were continued for 3 days. Surgery was performed under general anesthesia. If patient is hemodynamically, if the general condition of patient is not good to tolerate a general anesthesia, we can go for epidural or regional anesthesia. All patients we had put a Foley's under general after the anesthesia was given and removed once the patient was mobilized. Majority of the patients were approximately mobilized between 3 to 6 hours, and mobilization was delayed in cases of patients where the surgery we had done the procedure later part of the day. And once the anesthesia effect was gone, we could start off with the diet of the patient. And analgesics were continued till the patient experienced pain with an average from 1 day to couple of weeks. And gabapentinoids were given to alleviate the neurogenic symptoms. And rest of the patients we gave symptomatic treatment. Physiotherapy was started immediately from the day of surgery and discharged within 24 hours. We formulated a follow-up, but majority of the patients visited on random basis. So we evaluated our results by using McNabb's criteria, ODI scores, and also VAS scores. So minimum follow-up was 1 month and maximum was up to 42 months. So according to McNabb's criteria, of our 45 patients, 36 patients had excellent results. What it means is patients were completely relieved of the pain with no restriction of mobility, and they could return back to their normal life. And 7 patients had good results. What we mean by that is they had on and off symptoms with mild numbness, and they could return back to their work, but probably with some change in their activity. We had 2 patients who had fair results. They had previously they had presented with some deficits, and they did not improve significantly, but there was some improvement in the functional capacity. We didn't have any patients who had poor results. So we also followed up with all these patients using ODI scores. So on an average, our scores improved from a range of 60 average the range of 63 to 14 in the immediate post-operative period. And the average VAS score improved from 8 to 2 over a period of 1 year. And on one year follow, most of the patients were pain-free and satisfied with the procedure. No patient had any deterioration in or any other post-operative complications, and no patient required instrumentation. The major issues I had to face were wrong localization in the localization, especially in the initial part of the times. Whenever I used to dock the instruments, though I had localized pre-operatively, I used to sometimes go put it on dock it on a wrong level. Other issue with Destendu is retraction of the muscle, but over a period of time we could overcome that. Dural puncture, it may happen as in any case, but it's very unlikely to happen. Bleeding is another issue which we face during operating using Destendu technique. This can be easily controlled using a bipolar or by simply Abgel and some by anyhow you have the suction, so you can keep the suction there. And another issue was operating time, because initially for single level I used to take 3-4 hours, but of late we are able to operate within half an hour, 45 minutes. And neural injury, of course, for any procedure, neural injury is a known thing to happen, but luckily we didn't have. This is my first case which I had done. The typical case of an elderly gentleman, my junior's father, who was a very active man. He used to go to Tirumala for various sevas. He came to we came with the complaints of, I am not able to go to the temple, I am not able to climb up the stairs, and the typical neurogenic claudication. He was very hesitant because initially, as anybody would worry about the complications, but his disability went to the extent that he was unable to walk to the washroom. So luckily I was able to counsel him fine, and he was satisfied with my method of approach. And this was my first case which I had done. So what we are doing there is starting off with the spinal lamellar junction. We cut out the laminotomy and go do an over the top decompression, followed by that is a ligamentum flame. The left is and to guard the thecal sac, I put in a cottonide. Then I complete the dissection. So immediately the post-operative delay, immediately within 3 hours, I was able to make the patient sit and walk.
ఎట్లా ఉంది మీకు ముందున్న ప్రాబ్లం తగ్గిందా
So what he's saying is, I was unable to walk to the washroom, very satisfied. Now I am able to walk. That's what he's saying in Telugu.
Yeah, good.
So the smile on his face.
Hello, sir. How are you, sir?
So this is 4th month problem.
మీ పేరు చెప్
So this man gave me the motivation to take up this procedure, and seeing the results, I took up. So in this case, if you see the multi-segment, there is a severe lumbar canal stenosis at L3-4 with associated 2-3 and 4-5 compression. So what I did was, if we go by the conventional way, probably we'll have to cut out everything, cut the muscle, retract them, put in screws, do a lot of laminectomy, facetectomy, and whatnot. And this will add to the disability. And especially we see these type of cases in elderly people. And this big surgeries will add to the morbidity of the patient, and they become bedridden. So instead of that, and of course, patients will be osteoporotic. We will have to put in screws, fenestrated screws. We'll have to put in cement and stabilize the spine. So instead of all those things, we can use Descendo technique. In this case, we have used Descendo technique and localized L2-3, 3-4, and 4-5. And then once the over-the-top decompression is done, this is the L4-5 level. And this is the main pathology, L3-4.
Inside root. The opposite root.
So using the same incision, we could deal with L3-4 and 4-5. Then I'm coming out and I'm trying to show, this is the after the procedure. This is, I finished the procedure. I'm just trying to demonstrate the, this is the 2-3. So instead of those big incisions, we can deal with by giving 2 small incisions and immediate post-operative period. The patient, this is an 85-year-old gentleman. He was absolutely fine and very satisfied with the procedure. So concluding, Descendo technique we can use for multiple level pathologies. At each level, we can definitely approach as in like a single level. And how many other levels? Probably if it is 4-5, even if it is 3-4 levels, we can use the same technique. Thank you.
Thank you, Dr. Vishwak. It was a nice talk. Any questions from the floor? I think if there are no questions, we'll move on to the next speaker.
Thank you.
Thank you, Dr. Reddy. So next speaker canceled his speech. We'll move to the next. May I call Dr. Praveen KS from Bangalore? His topic, difficulties in learning curve in spinal endoscopy. Right?
Good afternoon, everyone. I know it's a postprandial period and difficult to be awake, but just bear with me for a few minutes. I think we should have spoken about this at the beginning of this session. People have already presented some advanced procedures during endoscopy. My interest with spinal endoscopy, it's been going on in my mind for a really long time, but physically I think it's just been 1.5 years now. And then primarily I'll be speaking about the interlaminar technique, which is so popular amongst the neurosurgeons. Being a neurosurgeon, of course, I think it's also a familiar territory and then much easier to progress with. So let me just deal with my experiences with difficulties and learning curve in spinal endoscopy. There are many ways to skin a cat, and then all of us have seen various methods of doing the same procedure. I think we've already experienced ULBD, we have seen PSLD, we have seen Descendo, and then there's now the new kid on the block is a spinal endoscopy. And I would see these pictures being shown in conferences, and then I would also think that I should do this one day. And with a small 8 mm incision, I was a non-believer. I would say, how will a 3 centimeter or 4 centimeter fragment come out through that small incision? And then believe me, it is still possible. So why spinal endoscopy? All of us know why. I will not waste much time on this. And then how is the most important. Of course, first we all have to have the mindset and we have to become believers. And then only we will be progressing on to this particular new technology. And of course, we need a capital expense. It does cost some money to put up the setup. It cannot be done with the instruments which are already available, unlike in Descendo. and it does require some initiative from either the surgeon himself or from the institute, and then we have to have the set of equipment to deal with it. Most of the hospitals will have say an endoscopic tower, a laparoscopic tower. So probably the screen, the HD screen, all those light source will always be available. But there are certain equipment like the endoscope itself, the endoscopic instruments, and also the RF, the radio frequency ablator that is required in this particular technology that we will have to invest and then start doing this. Of course, there are a lot of such fora which are available. For example, tomorrow's workshop is one such example where trainings are being conducted across the country, and then even on YouTube, one could probably learn many of these procedures. Of course, I wouldn't advise any of us to do really that, because recently there was a report in the paper where one person tried to do a laparoscopic cholecystectomy using a YouTube video, and the patient died with disastrous consequences. We have to undergo formal training either by seeing, observing, and also with hands-on and cadaver workshops. And then there are other two methods which I'll just mention a little later. Case selection is most important, so that we select the initial cases well, so that it keeps us on the path of motivation, and then it encourages to do more. Otherwise, it's very easy to get discouraged by early failures, and then you will just give up, which is much easier, and go back to our comfort zone of doing a micro discectomy. But I think we should persist, and then we can see better results. As Dr. Vishwasena just now mentioned, that initially it used to take 3-4 hours for a single level, and now it's just been 30 hours. So there is a learning curve which exists with any new technology, and that holds same with the endoscopy also. You review your own cases, you go back to your cases, you do your post-op scans diligently, observe why there was a failure or why it was a success, and then I think we all learn better and then become better surgeons for the patient's sake. And then you can also discuss these cases across lot of WhatsApp groups are available right now where such cases are being discussed and presented. I think that's a very, very good forum for us all to share our cases, and then also share our fears and tribulations. And when should we start spinal endoscopy? And then the answer is absolutely now. So there was a survey conducted in Thailand, a written survey for surgeons, and to enumerate the reasons why they would not take up spinal endoscopy. And the commonest cause, as you see, is lack of support. Now the industry is also geared up. A lot of Indian companies have come up with people who are trained to identify and help you deal with the instrumentation. As I said, training sessions are being held across the country. So lack of support is not a very good reason. The second reason, afraid of potential complications. Agreed, it's a new technology, and then people, especially neurosurgeons who are already in established practice, will be very difficult for them to accept a complication. As even Dr. Sushil Patkar said in the morning, it's very difficult to accept complications as you age. But the thing is, if you don't fall, you will never learn to ride. So that is also there. And then I think the complication rate overall in endoscopy across the literature is also being documented to be far lesser than open surgeries. So it is encouraging to take up this new technology. Long operative time, I do agree. It's in the beginning, it's a really tedious one to do, but towards the end, it's much easier. And then depending upon the case that you choose, it's very easy for us to go and then do that procedure. One reason that I don't agree here is doubt about advantages over conventional techniques. Believe me, anybody who has seen patients operated by even simple microscopic or Destando or spinal endoscopy will agree with the advantages, not only in terms of decompression, but also the patient comfort. And there are absolutely no long-term effects of recurrences or reprolapse rates or impartial or partial decompressions with those patients. So I think doubt about advantages over conventional techniques should be removed as one of the reasons for not taking up endoscopy. As I said, we should be taking up this procedure now before it's too late. The important two factors which are affected by your own learning curve is, of course, the duration of surgery and also the outcome. We're always afraid for outcome of our patients. Frequently, we see, especially in clinics with in an established neurosurgery practice, where our post-op patients are sitting with our pre-op patients. And if the post-op patient comes and says that, no, I've come for suture removal, but I'm not very happy with the surgery. I had a lot of pain in the post-op period. My problems are still the same. You can be assured that the pre-op patient will not be seen when you call him next. So it's important that we do target-oriented. We do result-oriented surgeries, especially being a neurosurgeon, especially in realm of spine, so that we keep a track on our outcome. It is affected by learning curve, but apparently literature says not much. Complications, yes. There could be certain specific set of complications in endoscopy, like say fluid-related problems. Unlike Destandu or tubular microdiscectomies, the medium of operating here is the fluid. And if we are using fluid injectors to maintain the pressure, sometimes the fluid can percolate into the epidural space and cause severe headache and neck pain. So it is advised to keep the pressures down to around 30 to 70 millimeters of mercury. And in the first few cases, I did have a lot of fluid seepage into the surrounding tissues in the lumbar spine without, of course, any specific side effects for the patient. But that has come down significantly now with my handling of the sheath and the endoscope. The gap between the sheath and the endoscope, and if you keep moving them too much, the fluid can escape into the surrounding tissues and leading to some fluid accumulation in the subcutaneous space of the lumbar spine. Bleeding, of course, is a major deterrent for any person who wishes to take up spinal endoscopy, and then we have to learn methods to curtail and also to control this bleeding. There are various tutorials or various sources and courses which of course tell you how to control soft tissue bleeding, how to control bone bleeding, how to control epidural. I will not go into much detail there. And then everybody's learning curve is their own, and then they will learn it by themselves. Durotomy, as I said, the incidence of durotomy is far lesser here. One advantage, as soon as you open the ligamentum flavum, the fluid pressure itself pushes the dura away, and whatever adhesions are there between the dura and the ligamentum are almost taken care. It's almost like you're doing hydrodissection, and then the chances of durotomy are actually far lesser in endoscopy, fluid medium endoscopy, than any other method. Root injury, of course, if you land in a wrong place and handle the root improperly, you can have root injury. Dysesthesia is the commonest side effect noticed in the beginning of our career, but mostly described in the transforaminal root and not much in the interlaminar root, because dysesthesia is supposed to be because of the irritation of the dorsal root ganglion. Reprolapse rates, as I said, are not much with the visualization and the magnification that the endoscope offers. It is possible to pick up every single fragment that you see on the scan, and we can progress far medially to the opposite side across the midline through an ipsilateral incision and then take out all specks of calcium. So reprolapse rates and partial decompressions are almost reduced compared to microscopic surgery. There are two major methods of training for endoscopy. Like any new technology, you do need to train. The commonest is the mentorship, where established neurosurgeons who already have a practice, it becomes very difficult to break away for a certain period of time to go on a fellowship, formal fellowship, and then come back. So it is better to identify a KOL, the key opinion leader in that particular field, have a mentor, have a discussion, go and watch him do cases, scrub up with him, learn hands-on, and then you can do it, say, over the weekend or once in a month or twice a month, and then slowly you will start. And then you can have him as a support for you to discuss difficult cases, and then you can discuss all your problems and the advantages. I think that's the best form for practicing neurosurgeons to take up this particular technology. Proctorship is a more formal fellowship courses which many places do offer, but it's for a little protracted period of time, let's say 3 months or 1 year, and may be difficult for practicing neurosurgeons. I found my mentor in Dr. Sukumar Sura. He's actually my MS General Surgery in Stanley. I mentored him. I was 1 year senior to him during Stanley for MS General Surgery, but now the roles are reversed, and then he's my mentor for endoscopy, and then I think we learn from each other. This is the way I found mine. You have to find yours. There are certain tips to overcome based on my own learning. The commonest is the fatigue, because it's a long duration surgery for the beginning surgeon. So you have to handle the endoscope properly so that it doesn't lead to fatigue with your hand. Of course, you can have an assistant hold the sheath for you. The other problem with the endoscope, a fluid related endoscope, is the floating sheath. In fact, the first conversion that happened to open surgery, I will present my series. The first conversion happened because we could not dock it properly, and we always look for a bony landmark for us to dock, like in tubular or Destando technique. But here the sheath is floating, and you need to be able to identify all the tissues under very, very high magnification. So you should be able to handle the sheath and the endoscope for long periods of time. You only have one hand for you to go and then manipulate and then do what you want to do. So handling the endoscope with a proper ergonomic technique at the correct shoulder height becomes very important for us to keep doing these procedures for 2-3 hours on end. Hand-eye coordination, as I said, endoscope handling, of course, is not very new for neurosurgeons now, with endoscopic pituitary surgeries becoming more common. But I think it comes very easily to arthroscopic orthopedic spine surgeons. And we as neurosurgeons are trained more under microscope than the endoscope. So I think the hand-eye coordination comes a little late, but of course it's not a major issue to master. Variable scope depth. Here, the scope and the depth of the endoscope itself should be varied for us to keep getting a closer picture, and also to zoom out and then pick up thicker tissues to take it out of the sheath. Handling of drill is again a very, very important learning curve associated instrument, and we should be able to handle well. Of course, with diamond drills being available, though the surgery is slower, but it is far safer to do so. And as I said, the other things, motivation, the case selection, also in the counseling, the pre-op consent form, you should be taking the consent at the beginning at least, that you might convert the patient to our comfort zone, that is a microscopic discectomy. So that will save us a lot of trouble as to what will I tell the patient. I've agreed the patient to do an endoscope, and then now I'm converting to microscopy. To get out of the situation is more important. For that, you have to prepare for it beforehand. Tell the patient that you might convert, and then that solves a lot of issues. Pre-op planning, that is reading our MRIs, are very, very important, where we have to identify where the hard fragment is, where the soft fragment is, where should we land. Sometimes the landing is dependent on the pathology. Is it a lateral recess stenosis? Is it a shoulder disc? Is it an axillary disc? Should we drill the superior process? Should we drill a lot more of the facet? So such things have to be planned on the pre-op MRI, and that will save us a lot of trouble, especially calcified discs, dealing with it. Whether we should... Yes.
Please conclude your talk.
Yeah, sure. I'll just skip this for the interest of time. This is the battlefield that we go to every day. The routine docking is at the spinophacetal junction, the laminofacetal junction, like in the L5S1. And this, I think I'll just briefly show you these are steps of surgery that we have done, and then of course it's available on most media. And then I'll skip this video, I think, for want of time. So we have done about 18 cases as of last month. Not much, I agree, and there's a lot of scope for improvement. But we see that we have done both L3-4, I mean all three, L3-4, L4-5, and L5S1. And I've had one complication, which is partial foot weakness in an L3-4 discectomy, and the patient improved in the follow-up in the first 2 weeks. Conversion to open, I'll just add a brief. The first patient that we converted was because we could not land properly. The second conversion was we had already entered into the disc, but we thought the ideal space we did not enter. And then the third conversion was because it was a very, very calcified disc and we were not able to proceed. And all patients were discharged within the first 24 hours. Of course, as is expected, the VAS score improved greatly, and then at 3 months' time, it remained the same. And operative time, there was a significant decline from about 200 minutes to 134 minutes in the last case. And then also the induction to incision time has also significantly improved. I think the OT team is now more aware of what to do. So that is also part of our operating time. As I said, the incision, after a while, it will be very, very difficult even to look for this incision. The patients will look at this, and then of course, this will increase your patient load. So it's time to pick up this technology very soon for selected cases. Few selected post-op scans I will show you. The pre-op, post-op of both L5S1. This is L5S1. You can also see my first few cases where I have left behind part of the medial osteophyte, the medial part of the disc. And I'll just quickly run through last. This one patient had an L3-4 disc. The skin burns was because of the pain relief that he could not obtain with Ayurvedic oil. And you can hardly see the scar in the second one. This is the patient who had a mild foot weakness, which improved on 2 weeks follow-up. You can see that the complete discectomy has been done at L3-4 and is completely relieved of all the pain. This is one of our patient again who had a large L5S1 and has had a very, very good post-op scan and also a functional outcome. So knowing when to stop is also very important. So this is the end point of most of our discectomy surgeries, where we see that there are no osteophytes, the root is very free. Lateral to the root, we have done a partial discectomy. The lateral recess has been decompressed, foraminotomy has been done, and then we have also removed all loose fragments that you can see the root, and by retracting you can see under the root also, and we can go all the way up to the midline. So, of course, there's a lot of things to be done, but I think this is beginning, and then all of us should be, whoever is not doing this, I think it's a technology worth having, and then there's a long way to go for me. So conclusions, of course, the real MIS is this in terms of incision, hospital stay, and also the muscle, and the indications are very, very quickly expanding in this endoscopy. And then comparable, if not better, patient satisfaction with this particular method. Very, very minimal complications. And being neurosurgeons who are used to doing interlaminar microscopic or Destando technique, this is a technology which is very, very easy to adapt. Thank you.
Okay, we'll move to the next speaker.
I would like to call Dr. Vijay Parihar from Jabalpur. He's going to speak on endoscopic anterior cervical disc preserving surgery. This side.
So, good afternoon, and thank you, organizing committee, for giving me the opportunity. Respected chairpersons and dear friends, I'm going to talk about the endoscopic anterior cervical disc preserving surgery. I'm Professor Neurosurgery in Government Medical College, Jabalpur. ACDF is quite a standard technique for cervical disc herniation, and it's safe, effective, easy to learn and practice. And I think it is one of the few techniques which we would like to practice immediately after the training, and we're quite satisfied with our result. But there are limitations with this technique, like reduction in the disc height, adjacent segment degeneration, pseudoarthrosis leads to the implant failure. So the rationale behind the disc preserving surgery is why the disc preservation is required, because you doesn't require motion, fusion is not required. You preserve most of the natural discs so that you preserve the motion. There is a less chance of adjacent segment degeneration, and you directly enter to the target, so there is no manipulation of the cervical cord or the root is required. And even we have seen that the artificial disc has been failed after certain period of times, and it is not very cost effective in the low and middle income group income. To collaborate the endoscope in the disc preserving surgery, the endoscopic disc preservation is also an effective in cervical myelopathy, myeloradiculopathy, and radiculopathy. Endoscope gives a better visualization. It gives a 360-degree as well as angle vision to look around the corners. We have a sufficient number of experience. We published in 2014 first, and then 2018 the cervical disc preserving surgery. So the indication, the significant anterior compression in form of central disc, lateral disc, or disco-osteophytic compression, or even the disc behind the vertebral body. We usually do the one level or more, two level, not more than two level, because it takes quite a long time. And you certainly did not want to do the surgery in such kind of cases where there has been a significant bony compression from the anterior sides. And also the large disc, if it goes migrated behind the vertebral body, it's difficult to take out, but there are transcorporeal root is there. So careful select your patient. There is many contraindications, like if there is significant posterior compression, there is a congenital canal stenosis, if there is an unstable spine, large migrated disc cover the more than half vertebral body, previous operation at the same segment, compression more than 2 level, dense OPLL like in this picture, it is difficult to take out by the drilling by the endoscopic approach. And if there is a significant reduced disc height which causes the secondary foraminal stenosis, usually required the ACDF. The initial surgical technique remains the same as the ACDF principle. Surgery has to be done in general anesthesia. Supine position, neck in a slightly extended positions. The localization is done with the various localizing devices. The skin incision is just medial to the sternocleidomastoid. You make a corridor between the brachioesophagus and the carotids, and the real confirmation as level is important. Before you dock the endoscope, there are some points that one should approach from the symptomatic side. If the patient has got right-sided symptom for radiculopathy, you can approach from the right side. If it is on the left side, you can approach from the left side. In symmetrical compression, you can go for the right-sided approach. And also, in a cranially migrated disc, it's better to go from the right side. In caudally migrated disc, it's better to go from the left side. So, if you dock the endoscope system, we use this EasyGo 2 system. These are consist of sequential tubular dilator system. It is nothing with a tube which has got an endoscope inside the tube, and which is fixed into the by the telescope holder, and rest of the instrument is the same which we are using is the ACDF technique. So this is the after docking, and then this is the setup. So once you confirm, and then you create an inverted funnel opening to either central of the disc for the central middle of the disc from this for the central disc, and the lateral for the lateral approach. The end cartilage should be preserved to avoid the fusion, and the thin layer of uncinate process has to be kept to protect the vertebral venous plexus injury or vertebral artery injury. Use the angle instrument. We always open the PLL to assess the adequacy of the decompression and also subligamentous. This is the you can see the funnel type of opening, a small opening in the and then the larger opening at the. This is one of the video of central disc C6, C7. This is the docking. Initially, we use a larger trocar. Now we are using smaller 15 mm trocar. Fix. You can see a longus coli of this side, longus coli of other side. Small opening was done. Drilling of the superior small part of the superior and inferior vertebra. And taking out the disc with the help of curate or the Carrison punch. And once you reach to the posterior limit, then the further axial drilling was done for the posterior osteophyte. And then by making with the help of blunt dissection and the Carrison punch, the last part of the annulus taken out, and this is the fragmented this is the disc compressing the cord. You can see a rent in the PLL. The further opening of the PLL to decompress the theca. By using the blunt probe, we assess the adequacy of the decompression. Hemostasis is achieved. Standard surgical instrument, same as we used in the CDF. This is the post-operative MRI. This is the follow-up sagittal alignment after 6 months. You can see a small hole here, and there is no change in cervical spine alignment. This is the two level E56 and C67. This is a case of left-sided E67 disc. I operated in a live operative workshop. This is the insertion of the scope. You can move 360 degree here, 280 degree, sorry. So this is cranial, this is caudal, this is medial, this is the left-sided. Small amount of longus coeli has been coagulated. The lateral most part of the body has been drilled. I'll skip. This is the small hole. So there are limitations also, because if there is a significant reduction in the disc height with foraminal stenosis, you cannot do the endoscopic disc preserving surgery. Multi-level foraminotomy or cord decompression also required a lot of time. And one need to do the comparison with the standard mortality in terms of disc height, cob angle, and adjacent segment degeneration, not only radiologically, but also the clinical impact. There has been a theoretical possibility of recurrence also, and it has got a steep learning curve. Complication is same as any anterior cervical: hematoma, esophageal injury, vertebral artery, root injury, and neurological deterioration. If you see the literature, it has been found that any type of cervical discectomy, fusion, or the disc arthroplasty has got the similar kind of the result in terms of cervical sagittal alignment. So we have also have a good number of experience from 2014, and then 2018 we have published in the World Neurosurgery. So we have a minimal follow-up of 6 years of these patients. We're doing the posterior approach. I think our next speaker, Dr. Rajesh, is going to speak about, and we also have a recent publication in World Neurosurgery about the posterior approach to the endoscopic approach to the cervical spine. So to conclude my talk, endoscopic anterior cervical discectomy is a safe and effective procedure. It has got an alternative to the surgical management of cervical disc disease, and it preserves the most of the natural disc to preserve the motion preserving as well as to avoid the adjacent segment degeneration. The long-term follow-up with comparison with the other surgical procedure is required to detect the progressive disc degeneration, monitor its clinical results. Thank you for your kind attention.
Thank you, Dr. Vijay, for your talk. I think we are running short of time, so we'd like to call the next speaker.
Okay, we'll invite the previous speaker. He arrived, Dr. Vishnu Vardhan. His topic is role of RF and laser in endoscopic disc ablation.
Hello, good evening, respected seniors and my dear colleagues. My topic is the role of lasers and RF in endoscopic spine surgery. Basically, I am doing the endoscopic spine surgery from past 5 years. Most of my surgeries are the transforaminal endoscopic. So, transforaminal endoscopic surgery, like open surgeries, hemostasis, and like in open surgeries, how we do the hemostasis. The lasers and RF will help in the endoscopic surgeries, interlaminar or the transforaminal surgeries. If you see the evolution of the endoscopic surgeries, that transforaminal surgery or the interlaminar surgeries, there is a lot of evolution is there. Initially, they started with the transforaminal, interlaminar, and from cervical, dorsal, and lumbar. For any success of the surgery, we need the proper instrumentation for the surgery, and HD camera for visualization, and there should be fluid irrigation, proper fluid irrigation in interlaminar or the transforaminal surgery. In the proper removal of the soft tissue dissection or the bone dissection is important. And for all these things, coagulation and ablation of the soft tissue is. For the coagulation and the ablation of the tissues, especially, these two things are most important, either RF or the lasers. Now, what is the role of the RF or what is the role of lasers, where we will use generally? If the disc is extruded outside and it is causing compression on the narrow root, and if it is in the foramina or extraforaminal, we can remove with the Kerrison punch easily. But when the disc is lateral or contained disc, it is close snugly compressing the narrow root. In those conditions, or the fragment is stuck in the foramina, in those conditions, we cannot completely remove the fragment. So Kerrison punches. In those cases, these lasers or RF will help. So laser is nothing but light amplification by stimulated emission of radiation. Laser itself, energy is transferred into the heat to vaporize the disc tissue. Basic functions of the lasers are, when it is transmitted through the optical fibers, it acts as a light source, or when it is focused on a point, it will cauterize, or it will vaporize the soft tissue. The unique features of the lasers are that they are monochromatic and coherent waves, directional is uniform direction. If you see the generations of the lasers, the first generation, second generation, third generation, if initially they used to do the surgeries with the Nd:YAG laser or CO2 laser, followed by the now most of the people are using the Holmium laser. Now the advanced lasers are the thulium lasers, where the thulium is most important. The tissue absorption of the thulium is very high, and the penetration of the tissue is very low, and the clearance of the surgical field is very good. So in the third generation, we'll see the fibers are the straight fibers or the side firing fibers. So in the side firing fibers, we can avoid the injury to the main vessels like vena cava, aorta, or iliac vessels. So if you see, these are the common lasers we use in the medical field, especially CO2 and KTP lasers, Nd:YAG lasers, Holmium lasers, thulium lasers are commonly used in the spine. They are divided basically based on wavelength and penetration of the depth. Actually, if you see the thulium is 0.1 to 0.2 depth penetration will be there. So as the depth penetration is minimal, the thermal injury will be very low. The standard differences between the holmium and the thulium are the holmium there will be a pulsed mode, and the thulium we can use the both pulsed and non-pulsed mode. And the more thermal injury with the holmium, as the penetration is more, depth penetration of the tissue is more. And the thulium, the depth penetration is less, so the heat generation will be very less, and the epidural heat generation will be very less, and the injuries will be very low. And the limitations to these lasers are the damage to the normal tissue while doing on the pathological tissues, and the high cost of the generators, and the noise, and the health hazards. The lasers will injure the eye retina. We should take care of the eyes. So this is the laser fiber, how we will pass through the working channel. So through the working channel only we will pass the laser fiber, and we will ablate the tissues. The small video of the thulium laser. Outline. Especially this thulium laser will have a clear surgical field with good vaporization of the tissue and the tissue ablation. there will be no wobbling, and the surgical field will be very clear. And the tissue ablation will be very clear. Evaporation of the tissue is very clear. In the other lasers, there will be a lot of debris while doing the surgery, and there will be wobbling, and all these things will be the same video. These are the generators of the holmium laser, and this is the thulium laser. Actually, nowadays the lasers are a lot of innovations and evolutions are coming in the lasers also. This is the laser what we are using, the portable laser. This is thulium laser is a portable laser we can carry at any place, and these are the fibers, 200 and 400 micron fibers. And what we use is the 100 heads and 30 watts power regularly. The RF missions they are starting from the 350 to 320 megahertz to the 4 megahertz. These are the RF mission. There will be two types of the RF mission: the 90 degrees probe and the steerable small diameter bipolar radio frequency. And the uniportal and biportal, how we use the RF probe. Here the plasma RF will have a very less thermal injury, even if you are close to the dura 2.5 mm distance, even if it is a low thermal injury. So how we will avoid the complications are with the short duration of the uses of the RF and the constant irrigation of the fluid, most important. In our experience, most of the surgeries are done with the laser surgery only, laser only, and a few surgeries only we did with the both RF and the combined. Complications are very minimal. Redo is only one surgery, and infection is one surgery, and dissociation pain are the 11% and 8% conclusion. In conclusions, laser and RF both have the unique role in endoscopic spine surgery. Tissue evaporation and ablation is more good with the thulium laser, and the paresthesia symptoms are less with the laser. Thank you for your kind attention.
Thank you, Dr. Vishnu. So I'd like to call the next speaker, Dr. Rakesh. He would be speaking on endoscopic posterior cervical discectomy.
Good afternoon, everyone. After listening an excellent talk by Dr. Parihar about interior cervical foraminotomy, we move on to full endoscopic monoportal posterior cervical discectomy. So cervical radiculopathy is one of the most common presentation we see in our outpatient clinic, kind of cervical radiculopathy. Options are ACDF is basically gold standard. Disc replacement is into market for so many years, and the posterior disc preserving surgery are MIS cervical laminoforaminotomy. We are doing it for almost a decade, and for last 2 years we have switched over to endoscopic posterior cervical discectomy foraminotomy. So basic concept is disc preserving surgery, targeted fragmentectomy, no need of expensive implant. Basically an ultra minimally invasive surgery where minimal approach related morbidity is there, minimal tissue trauma, less postoperative pain, less analgesic requirement, and shorter hospital stay. The patient selection has to be very stringent. So ideal patient is severe radicular pain of 4 to 6 weeks duration, not responding to conservative measures, focal neurological deficit. Treatment mainly resort for foraminal and posterolateral disc herniation with radiculopathy. Like this kind of patient is an ideal candidate. This is 667 foraminal disc, foraminal soft disc with no cord compression. This is ideal candidate. On axial, it's predominantly foraminal disc with a soft disc. Your contraindications here are associated symptomatic myelopathy, central disc herniation, pre-existing instability, significant mechanical neck pain, and presence of kyphotic deformity at the index level. This kind of broad-based disc should be avoided. Neck dominant symptoms with bilateral foraminal stenosis, it's preferred to do anterior ACDF rather than posterior foraminotomy. This is a case I want to share with you. This is a young lady presented with her acute onset triceps weakness and severe radicular pain of C7 dermatom, and MRI showing foraminal C6-7 disc herniation, no cord compression, predominantly foraminal acute disc. This is an X-ray. So basically, surgery is done under general anesthesia. Patient is in prone. On C-arm, you will see medial pedicular line and locate the C6 level with a needle and mark with a needle. In lateral, you confirm that C6-7 level. Then you dock, make an incision. This is a dilator. Then you put a sheath over it, take out the sheath, dilator, and then you operate through this sheath. So basically, you first entry with dilator. There's a single dilator system. Then it's a sheath. The sheath diameter I use is 9.6 millimeter. Then you put a scoop. So as soon as you put a scope in, what you would see is medial, this is lateral, this is rostral and caudal. So use RF and disc forceps to take out these muscles and identify the anatomy clear. So our target is to see this V point. This is rostral lamina, this is caudal lamina, this is lateral mass, and this is interlaminar window. So you dissect and make sure that you dissect it properly, and then you start drilling. So your drilling should involve superior aspect of lateral lamina, or 2 to 3 millimeter of lateral lamina, medial third of lateral mass, and the upper 2 to 3 millimeter of lower lamina. So basically a keyhole kind of laminoforaminotomy we would create. This is a hooded burr we are using, drilling upper lamina, and now started drilling lower lamina. One can use cutting burr as well, or use a diamond as well without protection once you are confident about it. And then you get a punch here, 1 or 2 millimeter punch, and then extend the laminotomy and extend into the medial foraminotomy. Here more work is done on an inferior lamina. Try to go beneath the root in a window between cord and the root. This foraminotomy is being done. Punch out the medial third of the lateral mass. Now you can see this is rostral and ventral and dorsal root, and then you fish out with the blunt dissector. The best part of this surgery is you don't see much of bleeding, which is always a worry when you are doing posterior surgery. So the disc fragment is being taken out. Then you use grasper or disc forceps and take the fragment out. Don't be satisfied with just one fragment. You try to fish out more fragments. You dissect it, and there are some more fragments. You take it out. Then you can see very well decompressed root. See rostrally, mobilize the root. There is no more compression there. You can check it from the inferior as well. Well mobilized root, no more compression, and you are satisfied. This is the end point. Post-operative patient had complete relief of pain, and you can see very little incision through which we worked. Tricep weakness recovered over 6 weeks. This post-operative MRI, you can see excellent decompression with minimal footprint behind, and this is 3D CT showing very small window through which we worked. This is another case, C5-6 foraminal disc herniation, not responded to conservative measures in the position. And same way, you put and mark an incision, dilator sheath, and then you dock. And basically, you do a soft tissue clearance, identify this V point, rostral, caudal, make a laminotomy using drill and punch, as I've shown, and then you identify this corridor, cord, and root. And at this junction, you dissect, you will find the disc. It's a huge fragment, you can see. You have to take some time here, avoid cord retraction, and slowly find dissection and try to bring the fragment out, and the fragment is out. And you make sure at the end that the root is well decompressed. Yeah, now well decompressed root, and that's the end point. And here again, post-operative MRI showing excellent decompression and very minimal footprint. The next case, C6-7 foraminal disc herniation. Again, the steps are same. identification of V point, take out the fragments. This is the nerve root at the end, and this is what it looks at the end. So our post-operative protocol is ambulation on the same day. Patient is being discharged on the next day, and there is no cervical collar required here. Complications is in all posterior foraminotomy, post-op paresthesia if there is too much of handling, neurological deficit if there is a cord retraction, there is a small risk of CSF leak, and post-operative instability if you take out too much of lateral mass. The biggest advantage I see is less intraoperative bleeding, and others are like it's ultra minimally invasive surgery, so smaller incision, minimal soft tissue trauma, shorter hospital stay, less post-operative pain, faster return to work and daily activities, and basically it's a motion preserving surgery. Points to remember: learning curve is there, so begin after getting sufficient exposure of the lumbar cases. Case selection has to be proper. This is the ultimate thing. Basically, your identification of proper case has to be there for posterior surgery. If there is associated medial disc or hard disc, then it would be difficult. Then you may have to just do a posterior foraminotomy. Your sheath position has to be proper. It should be as close to lamina as possible. And don't start fenestration till you identify proper anatomy. As I mentioned, proper identification of V point is important. At times, whenever there is severe compression, there may be some epidural bleeding. Don't get panic. It's basically a venous bleed. It settles down with some time and effort, and avoid cord retraction at all cost. And with that, I would end my talk, and I invite you all to MISAPCon at Gandhinagar on next month. And thank you.
Thank you, Dr. Rakesh.
No questions? Okay, good job. Thank
Thank
you.
you.
We'll invite the next speaker. Actually, the next speaker, Dr. Gupta's talk will be done at the next session. So we'll invite the next speaker, Dr. Dandapani. His topic is endoscopic studies for large intradural extramedullary tumor. Okay.
Respected teachers, my dear friends, I would like to thank NSSA, Dr. Savit, Dr. Manasar for giving me this opportunity to talk on the philosophy of endoscopy for large spinal intradural tumors. So first, I would like to clarify the difference between minimally invasive surgery in relation to various access ports and endoscopy we have. Sometimes we tend to get obsessed so much about the fancy access systems and use of endoscope in every surgery that which sometimes tends to violate the principle of minimally invasive surgery. Minimally invasive surgery means you tackle the target with least collateral disturbance. So with how much ever beautiful video we show and we use endoscope in our routine surgery, and then finally we have done a complete laminectomy for a simple disc or for a small thing, then that means it doesn't make sense. So anything which does not violate the principle of minimally invasive surgery should not be valid. Otherwise, if I am using endoscope and my microsurgery colleague is using microscope, but his bony opening is less compared to mine, then I cannot boast on that. So ideally, as spine surgeons, we have to evaluate based on the post-operative CT scan how much penetration or removal of bone we have done and soft tissue damage we have caused. That is the most important thing which will change the outcome and which will make it superior compared to any other microsurgery. We have been talking about endoscopy or minimally invasive surgery for spinal intradural tumors for the last 10 years. When we started presenting it and showing in conferences, someone even commented that it is madness to talk about minimally invasive surgery for such tumors as this. But here I'll describe the method in whatever is apparent madness. So when we published this in the spine journal, it was having the highest impact factor at that time among the spine journals. This was the first report of a minimally invasive or endoscopic surgery for a tumor which is in the CV junction. And also in this we have reported on tumors up to 6.8 centimeter, and it was the largest at that time. So in that we have kind of classified two kinds of approaches: intermuscular access and paraspinous access. So depending upon the long axis principle, whichever is best for a particular tumor, you can utilize. And then we have like these are the so many of the access ports we have available. I think sometime back we have a presentation by Destendo, ECGO also, Dr. Vijay Pariyar had spoken, matrix tube. So many systems are there. In this, we have comprehensively reviewed which system is having what advantages and what disadvantages, and how to decide on which system to use for various tumors. And as like sometime back, Dr. Vijay Pariyar and Dr. Yadav sir series was there. That was the largest. And then we had reported this in the Spine Journal. So in that, we had reported on 34 cases. And the largest tumor was around 6.8 centimeter, which was largest in literature at that time. So basically, when we actually, there were lots of criticisms, but this particular journal, when we submitted, there was not even a single correction. It was accepted directly. So basically, and in these last 10 years, I think everyone is have started to do endoscopic surgery for intradural tumors. And actually, it is a good thing. Actually, the philosophy is very important, that it is possible to do a targeted therapy for even large tumors without causing any collateral disturbance. And then we have described various techniques how to handle the tumors. This came in neurosurgical focus in this year, and I'll just show some video. And then recently we had reported the first minimally invasive in literature for a pure anterior meningioma in this area. And here also, this also I'll show some video. See, basically the principles of minimal access spine surgery remain same. You have to have a good localization, because if our localization is wrong, then ultimately we have to go one level above, one level below. Finally, it will become like any surgery. Then you have to use the right access system. That we cannot be dogmatic, because things are evolving. And but whatever is convenient to us, we can use. We have to have a good illumination and visualization. Here comes whether endoscope, microscope, or exoscope. So, and then we have to learn to use coaxial instruments rather than bulky instruments, high-speed drill, and tailored bone removal. This also I have highlighted before. No point of doing a wide laminectomy. Then you call it as an endoscopic surgery. And tumors, the most important thing is you have to know the plane of the lesion. The meningiomas are in a different plane compared to schwannomas. So if you enter the right plane, you will do a safe, quick, and wonderful surgery rather than you are in the wrong plane. Like meningiomas are extra-arachnoidal. We have done surgeries on a lateral meningiomas without a single drop of CSF coming out. And schwannomas in the lateral part, they are also extra-arachnoidal. So getting into the right plane makes things very easy. The localization is very important, and surface localization is useless. You have to localize at the time of bony opening, and various systems are available. So either we do interlaminar procedure without any bone removal, or we do small fenestration. And I already told extraarachnoidal tumors how sometimes we violate the intraarachnoidal. And for illumination and visualization comes whether you are using microscope, exoscope, or endoscope. The advantage of endoscope is angled optics are possible. 30, 45 degrees, 60 degrees is possible, which is impossible to do with microscope. So only when we are using angled endoscope, you are utilizing the full potential of endoscope. And in relation to exoscope and microscope, exoscope has a little wider field of view and deep depth of focus. Both superficial and deep structures you see in one go in exoscope. In microscope, it is shallow depth of focus, you cannot see it. So basically, hemostasis, dural closure is easy in this. Endoscope, it becomes cumbersome. So for schwannomas in the dorsal area, when we know the pathology is very sure, in that Spine Journal, we have described sliding delivery technique, in which you don't need to give incision and opening as long as the tumor. Because in cesarean section, you don't give the incision length as much as the height of the baby. The incision in cesarean section is smaller compared to the height of the baby. So for schwannomas, you can do a limited bony opening even for large tumors as this, and then you can gently slide and separate them extraarachnoidally from roots, and then you can take it out. And then we have described this for tumors like this. We have like this is one case which was published in Neurosurgical Focus. I'll just show how we are doing this sliding delivery. Here we dock the system and then we open the dura just over the tumor, so that directly we enter the tumor. And though the aim is to remain extraarachnoidal, sometimes we get into the subarachnoid space. And then we roll the tumor outside, and then any root which is densely adherent needs to be bimanually dissected, cut, and then under neuromonitoring. And then closure you do with clips in an angled way. So this was there in Neurosurgical Focus. So and this is another thing in which we have reported lateral rolling technique. In lateral rolling technique, basically this was a single level lesion in which we create a gutter laterally, and then the tumor is very much anterior. So here we wanted not to handle the spinal cord at all. So we, using exoscope and then endoscope, we roll the tumor into the lateral gutter so that we don't handle, and then we excise the dural attachment. This was a meningioma. So these we have used in C2 schwannomas, C2-3 multilobulated schwannomas, and such kind of any pathology, even intramedullary pathologies, we can use this. And this was a case of hemangioblastoma. Hemangioblastoma is actually good because it is surfacing lesion. So these are some of the results in which all time of tumors, almost 95% of the tumors, we are able to do it with some form of minimally invasive method. Again, I am not obsessed about using endoscope in all, but endoscope gives added advantage of angled optics. So it is safe and effective for tumors as large as 7 centimeter with better angled and panoramic visualization. And hemostasis and dural suturing has initial learning curve. Clips can be used to close dura or dorsolumbar spine, but we don't do it for cervical spine because sometimes it causes constriction. Thank you.
Okay, well done. Thank you. Any questions, comments?
So we'll go to the last speaker. Endoscopic strategies for migrated lumbar disc herniation by Dr. Ankit Gupta.
So first of all, I would like to thank the organizers for giving me this opportunity. So my topic for today's presentation is transforaminal endoscopic strategies for migrated lumbar disc herniation. So I'll be mainly speaking on transforaminal techniques. So I'll be briefing my talk in these four topics, which is I start with grading, then why we need to learn about the migrations, how they are graded, and how to approach these migrated herniations, what are the problems, and how to solve these problems to get the desired outcomes. So I'll start my presentation with this one of my case, a 52-year-old male with severe right leg pain with failed conservative treatment came to me with this L4, L5 high up migrated disc herniations. So you can see here there is a hypertrophied facet, and there is no space to see where is the exiting route. So it is better to lend in these patients extraforaminally and then walk on the superior articular process and drill it. So that's the video. So I have dock on the superior articular process, middle of the superior articular process, drilling it, making a space for the sheath, and then this is the tip of the SAP. So we also drill from caudal to cranial direction. So tip of the SAP is drilled to see the epidural space. A little more drilling is required, then this exposes the foraminal ligaments. So these are the ligaments which we cut. And once you cut these ligaments, you are on the disc, and that is the exiting route at 3 o'clock. So there is a lot of adhesion. Probably patient had some injections before he opted for surgery. So we remove these adhesions to make this route mobile, and then we push our sheath and retract the route and remove this fragment. So this decompresses the root and patient is absolutely pain-free. So all herniations which are displaced away from the index end plate are called as migrated disc herniations, and they have been categorized or graded in six types. Anything beyond these two lines are called as very high migration, and anything beyond these two red lines is high migration, and between these two lines is low migration. There is one modification given by Ann et al. They have placed another line at the middle of the inferior pedicle, and anything beyond this line is considered to be very high grade migrations. So anything beyond this foramina has become challenge for us, and so we need to widen this foramina to get access to the migrated lumbar disc herniations. So coming on to the patterns of the migrations, the caudal herniations are more common than the cranial herniations. However, the up migrated fragments are more common with the upper lumbar cases, upper lumbar levels, and into the elderly patients. However, the clinical significance in the literature is not known. So in various papers in literature, the failure rate for high migration is up to 15% as compared to the 2% in the low migration. And for these patients, the foraminoplasty is a better option. It improves your craniocaudal mobility, and that's how you can target these fragments. So typically all up migrated herniations laws at the axilla of the exiting root, and all down migrated herniation laws either at the axilla or at the shoulder of the traversing root, and that's why the trajectory is different for both these cases. Low migration herniations and lying here can typically be removed by inside out or outside in conventional technique, whereas for high migration, your docking is different, and it is advised to use outside in or what we call is epiduroscopic approaches, ending at the junction of superior articular process or and inferior pedicle, or at the tip of the SAP for the up migrated herniations. So this is the paper by K.C. Choi, who his results you can see here, the favorable outcome in 90% cases. But if you see in high grade up, the failure rate, the remnant fragments and revision are higher. That's why the high and very high grade should be planned meticulously, and these herniations may need more than one approach, and only experienced surgeons should do these cases. So this is another case which is very high migrated herniation. You can see here the L4, L5 herniation. Again, patient has right side pain with subtle weakness at hip and knee, and I docked at the tip of the SAP, as you can see in the C-arm images, and then drilling the superior articular process and making a space to get entry into the epidural space. These fragments then can be taken out by mobilizing these fragments with articulating spatula, or sometimes we need curette, and these can be taken out in your vision and then can be pulled. And you can see here the very well decompressed dura, the epidural space, and all removed fragments. And that is the exiting route at 1 o'clock. That is the exiting route. That is the post patient walking on the next day, and the post-op MRI suggestive of adequate removal. These up migrated herniations very frequently have multiple fragments. So if you dock conventionally at the tail of the herniation, you may fail to remove these fragments. So you have to target these fragments by targeting either at the belly or if possible, by other routes or the fundus of the fragment. These are some useful instruments: articulating spatula or curette, flexible grasper or drill, which is very imperative. And a lot of approaches has been described in literature, like para-PSLD, landing at the tip of the superior articular process, transforaminal approaches, suprapedicular approaches, suprapedicular retrocorporeal approaches, and transpedicular. And all one should be aware of all these techniques. Sometimes we may need these techniques.
or L5S1 migrations because of the small foramen and larger facets and high like crest. Sometimes it is difficult to tackle transforaminally. So it's better to plan these patients interlaminar because of the wider window, and they can be taken out easily. So another patient sees a 65-year-old female having right hip and knee osteoarthritis and coming up with the left leg pain, not able to walk. And she underwent surgery 10 years ago at the same level. So I was expecting a lot of addition here. So again, starting extraforaminally at the junction of superior articular process and pedicle helps to take these fragments out. So that's a small video again, landing at the junction of or the base of the SAP. That is the base of SAP. Drilling it out, and because she was already operated 10 years ago, so there were a lot of adhesions and scarring. So we have to be careful. Plunging instruments blindly may lead to injury to root or dura. So the SAP is drilled. Space was made here, and some scarring tissue was removed, and then we found the fragment and removed these fragments. Multiple fragments were taken out, and there was some calcification, annular calcification also adhered to the dura. So that was also removed. So that is the calcified part annulus. So that was removed. Small part which was very much adhered was left there. So now that is the decompressed traversing route, and this was the patient walking on next day. So to take home message for for selected cases and very well planned patients, the transforaminal endoscopy is effective choice for these herniation, migrated herniations, and you may require foraminoplasty in high or very high migrations. Target the belly rather than the tail of the herniations. And for very high migrations, one should not try these herniations early in their learning curve. Thank you.
Okay, thank you, Dr. Ankit, for the nice presentation. So I think we finished our last speaker, so we'd be going to the next session.
Thank you, chairpersons and all the speakers. Now we are moving on to the last session for today. That is endoscopy 2. I would call upon Dr. Chung Ki Chong, Dr. Rajesh Reddy, Dr. Tirumal for chairing the session.
Good evening, everyone. For the last session of the day, I would like to invite Dr. Girish Datar for talking on technical nuances and outcome of full endoscopic monopolar interbody fusion. Dr. Girish, please.
Yeah, good evening, everyone. Thanks a lot for this opportunity. I think the odd man in here, I'm an orthopedic spine surgeon. Nevertheless, I've been working in endoscopy for the last 15 years, trained by Dr. Tony Young to transition from transforaminal surgery to interlaminar surgeries to more complex procedures of interbody fusion. So here I present with a small presentation on the concept of interbody fusion. So posterior interbody fusion. So we know that transforaminally you can perform an interbody fusion under local anesthesia. You can perform it interlaminar. For Indian scenario, the interlaminar or the translaminar surgeries are more apt because our patients come quite late and there is a need for good decompression. So classical PLIF, which was being done, which is purely translaminar surgery, transition to TLIF, wherein we do a facetectomy to increase the corridor so that we are able to put cages with a larger footprint for good interbody fusion and for also decompression. It helps in quite a bit of decompression. In endoscopy, it's a combination of both of them. It is neither a TLIF, pure TLIF, it's neither a PLIF, but it's transfacet. So you can modify the way you go inside. If it's a primary case where no surgery has been done before, you can do a translaminar. If a primary surgery has been done before, then you can go absolute transfacet through the joint itself so that you have a virgin corridor to get inside rather than spending time in dissecting the tissue. So why do we need to change? Multiple factors, we all know about it, why we need to change. Reduces access trauma on the paraspinal musculature, which definitely reduces the possibility of an adjacent segment disease. Ability to operate under very clear field because the eye is inside the surgical field. Much less blood loss, able to visualize inside the disc for excellent end plate preparations, which will ensure that you have a good interbody fusion. Patients can be mobilized practically, most of the patients on the same day, some patients on the next day. So 24 hours is primarily what you look at. So the patient can be mobilized, which reduces the hospital stay. So is it feasible? Definitely feasible. If you can do it as an open surgery, it is quite feasible. Here you can look into the anatomy. Abundant amount of room in the foramen, in the lateral recess, in the Camben's triangle. No matter which kind of fusion you do, it's all transcamben through the Camben's triangle. Whether you retain the facet or you remove the facet is completely different, but it is all through the Camben's triangle. Here you can see the different measurements. So there is abundant amount of room to put a interbody cage of adequate footprint. So the surgical steps of endoscopic interbody fusion can be just put down into 5 different points. One is the docking of the endoscope, which is absolutely important. Decompression, end plate preparation, cage implantation, and then you augment it with posterior instrumentation. So I'll run you through a small representative case which will explain most of the things. Is a 57-year male with pain in the back lower limbs, predominantly on the left side. It's quite a targeted surgery, but only when you see that there are too much of compression on either side, you practically go ahead with the decompression first. So I always put it that an interbody fusion is an extension of a decompressive surgery. You extend the decompression surgery. Look at the axial sections of the MRI, quite a bit of stenosis on both the sides. So you need to do a good decompression here, which is absolutely mandatory. Sorry, I missed out on the last part. So you can see the instability here. Now, instability is also contributing to a lot of neurological symptoms. You have to do a decompression, you have to fuse here. So to achieve a stable spine here, painless spine here in this patient. So the next part is going to be the technology and tools. You require a little bit of most of the tools that you use in stenosis decompression are to be used here. A little tools vary as far as the access is controlled. So the most important thing, as I told you, is the dockings that you get inside. You have to be parallel to the disc space. Now, this is important for decompression. This is not mandatory. You can get in oblique. You can still do a posterior decompression very well on the ipsilateral, on the contralateral side. But for interbody fusion, you need to have parallel to the disc height, disc space, so that you get a parallel ending. So I'll just run through decompression. You start. So I'll just pass on with this because short of time here. I'll show you just. So the end plate preparation, again, these are small animations which are there, but I don't think I have time for that. So you practically get inside here from here, and then you do a proper decompression using different kinds of tools. So you create a safe corridor for yourself. Then you can do some amount of oblique tilting, and you can put in your instruments to leverage it to do your decompression. So cage insertion is again the same. So you're going inside, you're using a kind of a retractor. You can use a sleeve, you can use a retractor, either whatever is comfortable to you. Get into the safe corridor And once you get into the safe corridor and confirm that you have retracted the neurological tissues, you are able to now put in a good size cage. So this is the kind of corridor that you create. Angle it a little bit so you can have a good retraction and get inside with the interbody cage. So here we run through this short video, docking. So your docking is important, as I told you. The next thing that is going to come is going to be the extraspinal clearance, where you do the clearance of the spine area between the two laminae here. So you can use a wand, you can use an RF, whatever comforts you can use. So important thing is to strip off most of the soft tissues, because this is the bone that you're going to harvest for your grafting. Try remove all the soft tissue right in here, because once it comes out, it is a very small piece of bone and it's extremely difficult to remove the soft tissue. Then you can use your Kerrison raunches as much as possible so that you can harvest a lot of bone. I prefer doing a removal of the inferior articular process piecemeal. Some people take it as an en bloc. Both techniques are fine, but osteotome is a good instrument, which is a low energy bone cutting, so you can remove. So you have a lot of viable cells, and which also helps in union. The contralateral decompression, as I told you, it's an extension of decompression, interbody fusion. So you confirm that you have decompressed properly on the ipsilateral as well as contralateral side. Here you see the ipsilateral side. Now, after the contralateral side has been done, you do a complete flavectomy on either side, ipsilateral as contralateral. And the last part is going to be insertion of the cage. So you prepare your corridor in between the pedicles, retain the part of the pars covering the exiting route, which will protect the exiting route when you are putting your cage. So you have to deal only with the traversing route. There is a connecting vein here at the inferior border, which needs to be taken care of. And the cage insertion starts at the medial pedicular line. So you have a big corridor for you to create. Discectomy standard tools. Use the gross tools to remove the disc mechanically, and then under vision using an angled curette, you can remove quite a bit of the entire part. So you can prepare about 60% of the disc. I wouldn't say it is 100%, 60% of the disc. So you size it well, put in a bone graft, and then you can put in your interbody cage insertion. So you can, we normally put normal size cages, regular cages. We don't put expandable cages. You can put large size cage, place it anteriorly wherever you want. This is 11-degree lordotic cage, 13 size. Decompression of exiting route is not required in all the cases, but in cases where you have a compression, definitely you need to do a decompression. This is the tug of bone and the ligamentum flavum, which you have left behind initially when you want to, before you put in the cage. So you do a good decompression to see that the root is completely decompressed from medial pedicular border to the lateral pedicular border and extraforaminally if required, if you find that there is going to be a problem. And once the decompression is done and everything is there, you finish final confirmation on ipsilateral as well as contralateral side that you have done an adequate decompression. Any loose part of the bone or soft tissue that is remaining needs to come out. You cannot leave it there. So take it out, confirm your decompression is complete, and then you progress ahead with posterior fixation instrumentation. This is the cage, the final construct. You can see some skin incisions. We put in a mattress which is normally removed 24 hours. This is the final construct on AP and in the lateral. Thanks a lot. I'm short of time. Sorry, I overshot.
Thank you, Dr. Datar. I'd like to invite Dr. Sukumar Sura for his talk on full endoscopic spine surgery in the elderly.
So good afternoon, everyone. So after excellent talks by my previous speakers, I want to touch upon a topic where it is going to be the future of spine endoscopy, especially the elderly patients. So full endoscopy in spine surgery, especially elderly patients, the volume or the number is going to increase. The indications are going to increase in the years to come. So as you know, in stenosis, it can be the ligamentum flavum hypertrophy, either the lateral recess or central canal, facet hypertrophy, or the spurs, especially in the facet spur, or the annulus degeneration, or the bony spurs in the end plates, or the facet causing foraminal stenosis. These are the common situations where we see a symptomatic patient, especially elderly patient. Whatever the spine is degenerated and you have a radiological deformity, don't go by the radiology, treat the symptoms rather than the radiology. So try to address the pain generator. Either we can do posterior approach as we do in standard with microscopy or open approaches. The same way we can deal with endoscope, or we can deal with transforaminal approach, where it's a posterolateral approach to go through the triangle of Cambin, where my previous speaker, Dr. Ankit, clearly mentioned about the approach. So when we are dealing with a isolated foraminal stenosis, most of the elderly patients, the common there are definition confusion with who is elder. What is the definition of elderly? So the commonly accepted age is around more than 65. We consider them elderly nowadays. So there are patients where isolated foraminal stenosis, which leads to simple radiculopathy, no back pain. Such patients, just I go through the case examples here. So this 80-year-old male having a radiculopathy. So you can see a foraminal stenosis in such patient. So I have docked because it's on the right side. So right side of our screen is cranial. I'll just run through this. It's a lack of time. So you can see I'm using a flexible drill, which is articulating drill. I am drilling the superior articular facet. This already Dr. Ankit Gupta showed. So all we need to remove the superior articular facet till the tip and open up the corridor of the foramen and the lateral recess. So once we have done this, you can see medially, you can see the yellow ligament there. So you open up. Here patient has a end plate osteophyte. That's the end plate osteophyte. You can see the end plate osteophyte is raised. I'm using a punch there. Then I use a drill also to drill. So that's osteophyte there. I'm just trying to. So these are very common in elderly. So we need to understand. So I'm just drilling this osteophyte. This drilling of this osteophyte is key to the pain relief. Even if you do a good recess decompression, if you don't remove this ventral osteophyte, patient will not improve. Once it is done, then I'll just. You can see now the fat is nicely falling down. It's a junction of exiting and traversing area. You can see now that's a traversing and exiting area. Completely free now. Now I'm removing the ligament. So there are various tools which already Dr. Ankit has shown. So they are flexible curettes, which are very important in transforaminal surgery. So once it is done, so the outcome should be such that where the exiting route and the traversing route junction is free. So that's the osteophyte which I am working on medially now. So now that's the traversing route. That's the traversing route. You can see entire traversing route and the exiting route. That junction is made free. That's the hump which I was talking about. That's the exiting route, traversing route, and that's the exiting route. So this is very important, and this is a pre or post op. You can see what we have attained. We have not violated the facet joint here. That's the advantage of transforaminal approach. So one more patient, pediatrician. So I just done a good foramen decompression here. See, you can see the traversing route and the exiting route, which I just to tilt the sheath. You can see the exiting route also here. So this is very important. I'm tilting the sheet now, so you can see at 9 o'clock, you can see the exiting route. So this is the pre-op imaging of a patient with left radiculopathy, no back pain. So it's a pediatrician by profession. So I operated this 7 years back. He's still under follow, so he's happy. So that's what the outcome. You can see the outcome. So pre and post, the foraminal volume, how much we have increased, still keeping the intact joint. So that's what we have achieved. So this again is a 80 plus lady. She had a isolated pain with a facet spur. She was not fit for general anesthesia. So this I did under local. So just drill that facet transforaminal approach, and you can see the pre and post. You can remove that facet spur, and this is a post-op. So that's a traversing, and that's a exiting route with complete removal of the facet spur. So most of the time isolated foraminal stenosis, this is the best approach, transforaminal approach. Biggest advantage is that you can do it under local or epidural analgesia. So interlaminar approach is the approach which is now the most accepted approach, because for the surgeon it's convenient, anatomy is more understood and fast. You can do it very fast. So just to go through the cases. So it's a 82-year-old severe neurogenic claudication. These are the cases we see often in our day-to-day practice, and with no back pain but claudication pain. So just when go posteriorly, the idea here is to drill the laminofacet area and decompress the traversing route, and the opposite recess, as Dr. Datar said, it should be done. The opposite recess should be seen as the same ipsilateral. What neural elements you see, try to see, should be mirrored on the opposite side. Only then your result is good. And nowadays we remove the flavum en bloc. That's the best way to do it, because you don't injure. The chance of dural injury is very less. That's a bilateral ligamentum flavum being removed en bloc in a monoportal. So you can see the entire ligamentum flavum, the butterfly is removed. That's a ligamentum flavum removed. And this is outcome. This is what I was telling. So you can see the cranial, that's a cranial thing. The caudal lamina, the lateral, that's a root exposed nicely. That's a firm disc. So no need to touch in elderly patients. That's a axilla. That's a opposite root, the shoulder and the opposite disc. So you have done a complete decompression bilaterally. Bilateral roots have been decompressed. The thecal sac has been decompressed from the shoulder, or you can say the pedicle to pedicle decompression. So this is a post-op. This is what any spine surgeon wants in the end. So again, this case where patient had a disc and also stenosis. So this also we see often. So we can do a discectomy and again doing a good decompression. We also see such cases. This was a 82-year-old general surgeon, came with paraparesis. So we thought he had a multi-level stenosis. We offered him multi-level decompression. To our surprise, this patient had a bleed, the hematoma, in between the two layers of ligamentum flavum, both superficial and deep layer. You can see that's the ligamentum flavum layers. That's the hematoma. So I removed the hematoma. So that was the reason for acute deterioration. He came with acute paraparesis. So that was hematoma. So remove hematoma, completely removed, and we did a 3-level decompression. And patient regained his power and is absolutely fine now. And this is you can see the decompression post-op after 3 months, and this is the scar after 3 months. In an 82-year-old, this is what you want. Just go through the cases. A severely scoliotic lady with just radicular symptoms. We had a bilateral L5, L4 radiculopathy. So we just did a bilateral decompression. This is post-op. So the next common thing in elderly is a facet cyst. So you most often you see there is no need for TLIF in such patient. Now there is enough literature for facet cyst. Just a decompression is enough if patient doesn't have instability and back pain. So this is pre-op, post-op. You see the window we have created, and this is post-op scan. So you can see the decompression and the volume we have generated. And this one more case, Air Force pilot here. So you can see a facet cyst on the right side. Someone tried CT guided aspiration but failed. Just 2 minutes. So we did a excision, and this is a decompression, and this is post-op. So dorsal again in elderly, you can deal with OIL. So they can do very well, and you can see the results after a year. So completely decompressed. Again, this is one more case. We can do it easily, and this is a post-op. Again, cervical we have started doing regularly now. This is a elderly man with 2-level stenosis with only myelopathy. So then we did a 2-level decompression, and this is a post-op outcome. So there is no need for lateral mass fixation. When a good lordosis is there, you need not do it. And fusion, as already Dr. Datar said, I do en bloc resection of the facet. Either way is okay. And these are some case examples. Grade 2 listhesis, till grade 2 we do it very commonly. It's very easy if you follow the principles of endoscopy, and you can do same as what you do in open surgery or any MIS surgery. So this is one more case. Done. So it's a 2-level endofusion again. So we have our own experience of elderly patients, 128 patients with predominant male patients, and predominantly they fall in between 65 to 75 patients, 75 years. And predominantly our technique is interlaminar because we want to use a bone cement, good reduction. It's easy posteriorly. Thank you.
Thank you, Dr. Sura. I'd like to call Dr. Sampath from Bangalore for endoscopic thoracic fusion. Dr. Sampath.
See, all this work I have done, it is at NIMHANS only. Now I am working in this Sridevi Medical College. It is newly opened medical college. So I will be talking about this thoracic spine fusion. See, why I am showing this picture, I think you may be wondering why this person is showing when there is no surgical intervention which is not required like this. So we are going in a circle-like thing. So first we started with the macroscopic surgery, then microscopic surgery. Now at present is endoscopic surgery. Tomorrow what surgery will come, we don't know. May come this one. See how the Kubja lady requesting Lord Krishna for her disability. And next one is without using anything, see how this lady becomes straight and most beautiful and all. So I think we are going towards this. All the things, see, you may wonder, see, I told you macroscopic. What happened to macroscopic instruments? Now we are discarding. The microscopic instruments, what we are doing, that is also going away. Now endoscopic instruments, after sometimes in our audience only, you may discard the present instruments also and going for this. So that is why yesterday when you was commenting on other departments, so we have to think all the department into consideration. See all these things what we talked about, the congenital things. The pediatric surgeon in future, he may come out with no congenital malformations at all. Then whatever surgery what we are doing is not required. That is where I am thinking. I don't know, you may think what if foolish fellow is talking like that. It may come 100%, it is like that only. So our treatment is incomplete when you don't know the pathophysiology of it. That is why patient recurrence or whatever it may be, but our understanding is not there. That is why they are coming with the recurrence. So unless we know those things, our surgery will be incomplete only. That is why so many recurrences and all which is coming, but still lifelong they will be suffering only. This after the Krishna, then again the next year which is started, say Hippocrates. So he started Hippocratic ladder and also board. So this is the way he started treating. Now we are treating in a different way. So we are going back to zero. So these are all the ways of treating this. Spine surgery especially because this is the spine conference, I am showing only this. So in this, India stands first in the literature itself, in the management of any medical pathology, the spine. So India stands first. Then later on, Egyptian, then European history which starts. So now I am not going to details of those things, how these instruments which are developed like that. So this is the first endoscopic concept which is developed. We know before that only. You know hundi where in temple, in front of temple they will keep hundi. In that we will be putting coins and all. So if you're a clever fellow, if you want to take out, you will use a small pinhole appearance like that. Yeah, another fellow will come, some small instruments, with that you will pick out the all coins like that. The same way what endoscope is doing, same, nothing else. There is no difference. But the people will talk in a different sentences, different words like that. But it will be a new for us. So this is, once you know the anatomy of the spine, this all vertebrae. So this is Roy, Weinstein, or Magliar, all they have studied independent bones, vertebrae, and analyzed and how what is the shape and size of the vertebrae. So this is the, so whatever we was work on, this is the main etiology for that and entry point for these things. And this is the anatomy of the pedicle, height and also width of the pedicle and also directions. So what is the advantage of this endoscopic surgery, anything at all? So it gives the panoramic view, easy dissection, minimal mesial injury, reduced blood loss, reduced epidural fibrosis, fast stay, and functional recovery will be fast, and especially elderly people because it's a minimally invasive surgery. So under local anesthesia or epidural or regional anesthesia can be given, operated in a short period. So when you come to thoracic surgery itself, the commonest surgery what they were sympathectomy or hyperhidrosis using endoscope. So after that endoscope, they come to disc herniation or discectomy, then stenosis for decompression, corpectomy if there is any disease of the body of the spine itself, or the tumors. Then if there is any kyphoscoliosis or you want to fuse anything, then it will come for the scoliosis correction and all the things using endoscope itself. So contraindication for thoracic, not for anything else. Because of severe respiratory failure, we may not be able to achieve this area, or because of severe adhesion, we may not be able to reach the area. So limitation is because we will be doing with one lung functioning, another lung will be totally rest. So with the rested lung may have complications. That is the limitations for that. So people have done different types of fusion through this using endoscope. So some of the complications, it is a regular complication. If you touch a nerve, there is a problem. You may injure the nerve itself, or if you totally cut the nerve, or neuropraxia like that it may be. Pneumothorax, why it comes? Because of this injury to the surface of the lung, it may cause bleb. Then once it is reversed back, sometimes because of airway difference, it may rupture and it may cause pneumothorax. But most of the surgeons had this pneumothorax following surgery. And then after that, sometimes pulmonary embolism, lung atelectasis, that is because of this collapse of the lung for a long period, so that secretions which are collected there, that may be difficult to evacuate. So some few patients have developed lung atelectasis. See, majority of the TBs, they have lung atelectasis. Then blood loss, it depends upon the surgeon, how he manages. Then chylothoracic, that is the area where aorta, inferior vena cava, and thoracic duct which is be running. So we should be careful about that structures. Then sometimes implant failure, then pneumonia. Then when we are doing it, we may not be able to reach the area. So we may convert into open surgery. So I have operated 12 cases. Out of that, 5 cases of port spine, 1 tumor, 1 trauma, 3 traumas, and 3 cases aborted. Why I aborted these cases? First case, it was a nightmare for me. I could not identify where is the lesion itself. So I converted into thoracotomy. Then after that, once everything was clean, when I retracted the lung, so I could see a nice pulsating tumor. It was arising from the aorta. It may be because of traumatic pseudoaneurysm maybe. So immediately I closed and referred. Then another thing is adhesion. So that is also I could not do any surgery for this. Then I will show you some of the videos. This is the cox spine. So we may not enjoy so much things when we see the endoscope, see the how the abscess, cold abscess, which is projecting towards us itself, and it's a multilobulated abscess, and the area of involvement is so huge. You see, that is why it's a panoramic view. You see, under microscope you would have not seen so much thing. So this is the cold abscess which is draining. In open surgery also you would have not seen this type of pathological elimination. So after that excision of this wall, then I could drill the osteomyelitis bone. Then I could see that is the dura. And the little dura is torn, the arachnoid which is projecting there. After that, I could seal the area. So after adequate decompression, all the initial stage, because of shaking and all the things, everyone could have undergone all these things. This is the cage I am placing in between. Go fast or so we have to be very careful when we are handling this. Once it goes inside, then it is very difficult to take out. So till that time, that thread has to be there. That has to be cut at the end. Most of cases. Next. Next video. This is the one tumor case. Initially, because of that pain, immobility, because of movement which is causing pain, so it was used. Then as the tumor was growing, again patient deteriorated. Then we did all these things. Four portal, so different instrument has to be paused. So that is the tumor. Tumor being decompressed. See the dural tube. Again cage. Post-op. One more. The time is there, I'm showing. A traumatic one. This anteriorly, that is the dural, whole dural tube. Identify. Graft characteristic. Because of that shortage, I placed one cage also along with that. Thank you.
Thank you, Dr. Sampath. Now I invite Dr. Cho for his talk on UBE lumbar fusion, the future of lumbar fusion surgery.
May I request Dr. Rajesh Reddy sir to come onto the stage, please?
You please change this video.
It takes time, and my name is Jung Gi-jo. My last name is a little bit complicated, especially difficult to pronounce properly. That is too complicated last name, but that's not my fault. My father decided my last family name like this one, and my topic is the biportal endoscopic fusion, and this is from my personal experience and just from my experience and gut feeling, and not about advantage, disadvantage, or literature review or something like that. I just skip all those things and then go to the next one. And fusion has been regarded as a final solution to various spinal disease. And during my career as spine surgeon, I did everything. But now I just do OLIF and endofusion only. I abandoned all of other fusion method. I just do both of them. And you know, in the year of 2019, the first report of UV is published on paper. Both of them from Korea. They are actually my friend and student. And after first report of the UV fusion, already there is more than 700 papers published, and most of spine surgeons are crazy about UV surgery. It's extremely popular in Korea, and it's not even not for Korea. It's worldwide. Foreign doctors come to Korea learn UV fusion. And there are several surgical instruments developed, especially designed for UV fusion. And you can see this curette and small cuffs, guide, and bone chip impactor, even specially developed fusion cage are introduced in Korea. And I'm going to skip this one. And this is my personal impression of on each type of fusion surgery. MIS TLIP, easy, most familiar, fastest, but nothing special. ALIP, very good method, but bothersome without access surgeon. OLIF, for me, is easiest and safest. And UV fusion is very fancy and attractive, but challenging. And still, even after more than 1,000 cases of UV surgery, I do not feel completely comfortable during surgery. And I prefer OLIF over UV, and I'm a strong believer of the power and effectiveness of indirect decompression of ALIF and OLIF. That's the reason why I still prefer OLIF over UV fusion. Considering my experience, the UV fusion are very few and very rare. 29 cases only. And L5S1 is most common site. And interestingly, there are 4 cases of ASD fusion extension. And complications were rarer than I concerned. Just one temporary radiculopathy and one duratia. And operation time per level are decreasing, but still around 2 hours, more than 2 hours, including percutaneous pedicle screen. And as you know, most of those papers suggested that cost of pain and hospital stay decreased compared with MIS TLIP. My data also shows the decreased hospital stay compared with MIS TLIP. But technically, there are some hurdles, even for experienced UV surgeon. And first, the soft tissue dissection is extensive compared to simple decompressive surgery or laminectomy. You should dissect all the facet joint and accessory spinous process and transverse process and outside of the lateral facet. There is always very bloody. You know that most of the blood supply comes from the outside of facet joint, so you will encounter with profuse bleeding from artery during the dissection. But you should do complete subperiosteal dissection for safe and complete surgery. If you omit this one, you will be in trouble. So you need to complete subperiosteal dissection for endoscopic fusion. This is the most important part for the tip of SAP and isthmus and accessory spinous process and transverse process. And then bone removal. We need a lot of bone removal compared with laminectomy or discectomy, but with the small and weak real system or calcium punch, it will take a lot of time. So you better use osteotome. Osteotome is very convenient and powerful compared to drill or calcium punch, and it's very useful for gathering bone chip for later use as a bone harvesting autobone. So you better use osteotome during the removal of facet joint and isthmus. But it also takes time. Even with the osteotome, it takes time. And next problem is for bleeding. Under the endoscope, especially for the water medium endoscopic surgery, even with a small amount of bleeding obscure all the operation field. Bleeding can stop everything. You can do nothing with the bleeding. Especially bone bleeding is very bothersome. And you know that bone wax is oily. Bone wax hates cold water. And you can wax bone wax in the cold water. That's the problem in the UV surgery. Sometimes it's very tricky, and in that case, I recommend the use of RF. You can weld bone wax with the heat of RF, and sometimes RF itself stops bone bleeding. And then disc space preparation is another technical hurdle. Most of the endoscopic spine surgeons proclaim the complete and thorough and careful end plate preparation is the strength of the endoscopic spine fusion. For me, it takes too much time. It's kind of tedious and time-consuming compared with other means of fusion method, something like T-lip or OLIF. We can do less than 10 minutes, but in endoscope, you need a lot of time to prepare complete end plate preparation and removal of whole disc. Even after struggle, you can see this clear end plate preparation. And next problem is the blind spot and blind side of endoscope. For right-handed surgeon, from the left side, you can see and protect exiting nerve root and then avoid injury of the exiting nerve root during the insertion of the cage. But for right side approach, cannot see anything because the cage blind the dura margin and exiting nerve root. You can injure dura or acting nerve root. That's the problem. So now we are developing a kind of the a dura guide or a nerve root protector for these means. And I have one case of neurodeficit. He has some kind of ischemic spondylolisthesis. I struggled during the surgery, and finally I put the cage in proper position. But you can see I crossed the midline, and finally I get a right cage position and reduction. But it takes more than 4 hours for me. And endoscopic fusion is not safe. This patient operated on another hospital and came to me. You can see the cage is inserted into the bone and then protruded into the spinal canal. And then I did the push deeper, the cage deeper, and additional laminectomy to reduce pain and symptoms. And this patient had a Cauda-Equina syndrome after fusion. There is no perfect and absolutely safe surgery. UV fusion also has complication. And one thing I prefer over OLIF is the fusion extension, because we can avoid painful dissection through the scar tissue, and we don't need big incision. We just made not working. Sorry. This is the final product. And she left hospital 4 days after surgery. And this is my take-home messages. For surgeon, UV fusion is very attractive and challenging and up-to-date surgical technique. And for patient, it is less invasive and less painful, which is very important for them. There are many things to solve. There are many difficulties to be we should deal with. But I would say that the UV fusion will be the at least mainstream of the lumbar fusion surgery in the foreseeable future. And thanks again those who come to Korea and participated NSSA 2024, which was held in Seoul, Korea. Without your help, that meeting cannot be successful. Thank you.
Thank you for finishing on time, sir. Any questions, please? I have one question. The reason, what did you notice for the graft extrusion, the cage extrusion into the canal? Could it have been avoided by using expandable cages or anything?
One expandable cage. Yeah, we have developed one expandable cage. And
what could be the reason for the cage extrusion into the canal? Or it could have been avoided using expandable cages?
The thread was gone. He tried to remove, another hospital doctor tried to remove the cage when he realized that he put the cage into the body, and tried to remove during the trial. The kind of the thread of the cage was gone, because for that reason I cannot remove.
Thank you. I call upon Dr. Jayesh Ardana to talk on cervical spine endoscopy, expanding horizons. Dr. Jayesh, please.
First of all, thank you, Manas sir and Dr. Savitra, for this opportunity. So this is unbelievable, Dr. Chung. You have shown that OLIF cage can be put through endoscopy, and that's what it remained. So also I believe that future of spine surgery is absolutely endoscopic spine surgery, whether you believe or not. Second is the genetic vaccine or medicine for prevention of degenerative spine disease. Third is artificial intelligence in the spine surgeries. And fourth, down the line of 10 to 20 years, I believe that all the spinal implants will be converted into biodegradable and bioresorbable implants. This is the future of spine surgery. In this ladder pattern, we should, gradually raised one by one and cervical spine endoscopy from somewhere in the top. There are many reasons and anatomical importance things which today I would like to discuss. Why this endoscopy is different from lumbar one. Look at this case, 33-year male. neck pain, C6 radiculopathy without any deficits, classical right side paracentral disc prolapse, young patient. So usually the surgical options we offered in the OPD. Fusion surgery, absolutely standard. We can ask for classical SCDF, but you know, if there is a female, we can explain there is an anterior neck scar. Adjacent segment disease 2.5% per year. Now, we should also explain the option of motion preservation surgery, and these are the artificial disc replacement. Of course, there is a chances of heterogeneous ossification, but today Dr. Kim has shown that the result of HO is, outcome is absolutely less in many years. It can be given. Then we, particularly for paracentral disc prolapse, is a beautiful option of posterior cervical endoscopic discectomy. Whether you do tubular or via endoscopy, it is a real motion preservation surgery. So these are the horizon for anterior and posterior approach. So for anterior disc prolapse, whether central disc prolapse or paracentral disc prolapse, endoscopic SCDF, you can go for endoscopic artificial disc replacement, that is anterior option. For unilateral disc prolapse, paracentral one, you can go for endoscopic lamina foramectomy. This was not before, but Dr. Lim has recently described the paper of more than 200 patients in which multiple level compression, which more than 3 level compression. It is a very good alternative by single incision, that's called jumping technique, in which you definitely can avoid laminoplasty as well as posterior cervical fusion. It's a complete, motion preservation option. For single level, small IDM, yes, posterior endoscopy approach. These are the horizons of cervical endoscopy. Now, I would like to emphasize some points why cervical endoscopy and what is the difference between cervical and lumbar endoscopy while we're differentiating. So first point, that is the docking point. This is the V point where exactly whatever you use the destandu or the tube or whatever. This is the docking point, that is a V point. Exactly between the lamina and this apex of the V is in the facet joint. Now this V, the idea is you convert V into U. Partial upper lamina, partial lower lamina, and 10 to 20% of facet joint, which allow you expose the cervical nerve root, which is supposed to be decompressed. Now, what is the difference between lumbar endoscopy? You see in the cervical spine that nerve root exit in the foramina to one level above the pedicles, above the level of pedicle. So it means you will find the nerve root in the lower half of or lower 1/3 of foramen. In lumbar spine, lumbar foramen, you will find in the upper 1/3 of foramen. That is number one. Second, this nerve root will see in lumbar spine that now exiting nerve root or traversing nerve root will be going away from you while operating. In cervical spine, it will directly coming to you. That is a gross difference. Third, this is the lamina facet junction, which is a docking point, and exactly while we are working, there's the vertebral artery is just 3 to 4 millimeter away in the depth. This is very, very crucial. You cannot be a straight and lateral, you always have to be medial. Now this is the one level decompression. For two level decompression is possible, in which you have to drill one full lamina and partial adjacent lamina. For 3 level, complete one lamina, half above, half below. So these are the bone decompression level. Now this V point is, as you go from above to downward, from C2 downward to up to C4, the V point overlies the nerve root. You can see here, it's overlies. It means you just open the lamina and just facet joint, you can see the entry point of foramen. But as you go down in C5 and C6, this you will find the dura, because this nerve root is entry point is very lateral, so you may require sometimes 30% and 40% drill, and literature wise 50% facet can be drilled. Position for posterior approach, neutral, almost your little bit flexion of the chip help to open the foramina. Now AP view is very important because you need to dock exactly on the lamina of facet point. You use full endoscopic system or you use destandu. This I am showing the video of destandu, obturator, outer internal cannula. So this V point I was talking about, the right side C6, C5, C6 disc prolapse, upper lamina, lower lamina, this V point. When you start drilling there, so ligament of flavum supposed to be free before you remove it because there is a chances of CSF leak. Almost same is same, step is almost same like lumbar. As I told you, there are three difference. One, you cannot retract the dura. You cannot retract the dura. 10% or 20% of facet joints initially supposed to drill. So you keep in mind that this is the nerve root which is coming to you, not going against you. Second point, in the lumbar spine, we always remove the disc through axilla. Here you should remember that you have to drill superior and inferior to nerve root both the side because you have to decompress from both. So 360-degree means cranial, caudal, and beneath the nerve root all should be free. You cannot retract the this thecal sac. But yes, I suggest that you remove the disc prolapse first, then let it be pulsatile, and then you can retract the nerve root. Before that, you cannot even retract the nerve root because if you have a hard osteophytes, then patient may have a C5, C6 weakness in the very high chance. So what is the end point? You're supposed to undercut the facet till it, it is entering into the foramina, it can exit from the foramina, and it should be completely pulsatile. Now, this one of the patient which was initially operated by canal stenosis anterior approach, then secondary canal stenosis developed. Patient was elderly, so I decided to go from back. In which landing point should be over the lamina, not on the V point. So it is a two-level decompression. You're supposed to drill and make the lamina thin. The drilling starts from the base of the spinous process. Here is the facet. Make it thin. Now look at the mobility of the system. This is one of the reasons that by single incision you can approach up to 3 level. The other problem with the cervical spine endoscopy is bleeding. You are struggled with a lot of epidural plexus bleeding, and the key is you use a lot of gel foam, put it inside beneath the facet joint, and it will give you easy. If still not controllable, you just use a Surgicel or Surgiflow or Flowsil. It will very helpful. You remove the inner cannula. You can use a Surgicel, Flowsil or Surgiflow. Will stop. Now you can see here that the base of the spinous process with the number 3 diamond drill you can drill, and the 2 level of decompress you can do achieved easily. You can go also opposite side. You just drill the base of the spinous process and you can give a space of 6 to 7 millimeter to the canal, which is good enough for pulsatile dura for 2 level or 3 level. Yeah. Complete 2 level decompression. Now this is 3 level decompression in which more than 3 level compression is there. So from here to there, you can see that both the side is completely free, the dura. Now we can see that for 1 level, this is the opening, and for 2 level, this is the bony opening, and for 3 level, look at the posterior column, spinous process completely intact, facet column is completely intact. So there are 2 advantages. One is absolutely stable, no need of laminoplasty, no need of lateral fusion, and third is a complete motion preservation surgery. So what this is a good study. Sebastian is compared that if you do a posterior cervical endoscopy and it compare with the open one, and so follow more than 10 years, and he sees that there is a 4% recurrence rate after SCDF, 6% recurrence rate after PCD. Clinical is similar. If you do open cervical discectomy and if you follow for more than 5 years here, we can see what happens to the kyphotic rate? So for open surgery, the 5-year follow-up out of 162 patients, 30 patients underwent, means 20% rate of progressive kyphosis. To do with the either tubular or endoscopy, there is no progressive kyphosis. What if you supposed to do endoscopy in straight spine or little bit cervical kyphotic patient? Still, if this study compare less than 10 degree and more than 10 degree of lordotic patient and shows very safe, no kyphosis. So other advantage of endoscopy over tube is because it has a 10 times of magnification. So facet joint removal requires 0.98. That is only 10% compared to the 30%. Another case, yeah, unilateral. We have seen a lot of cervical IDM today. So in one side, small IDM easily can be operated. So the endoscopic decompression and discectomy is a good alternative, an equal clinical outcome, and give you some motion preservation with the single or multiple cervical disc herniation in which posterior approach is indicated, not in all cases. Thank you so much.
Thank you, Dr. Sadhana. Any questions?
Excellent presentation. I think we used to opening up the spine, retracting a lot of muscles and stuff. This is the way forward, either full endoscopic or destandu or tubular. I think this is going to be the future. But I have an observation to make. So many of the presentations are about isolated cervical disc prolapse. Majority come with radicular pain. So we have a different way of looking at how we treat them. So if it is a cervical disc prolapse, single level lateral without deficits, I would do a simple lateral interlaminar epidural injection. And we have had a series of more than 600 cases. We have had to operate only on 2 people among these cases. I know it sounds very odd in a forum of neurosurgeons, but this really works because I feel in cervical disc prolapse with radicular pain, you just have to take care of the acute phase. Majority of times, people do well with conservative treatment also. But the way I look at it, I think first should be intervention, pain intervention. If it doesn't come down, then you go for surgery. Because that way we are avoiding a surgery and the patient comes back to functionality in a very short time. So, and it's a very easy technique, and for neurosurgeons or spine surgeons to take it up doesn't take much time. In and out is like 7 to 8 minutes. There's nothing, there's no blood loss. Put a band-aid and send him home. This is talking from my experience, and I think this should be tried out by other people and have discussion about what their results are. Or if somebody has experience, I heard Nupur in Nimans is doing this stuff. So any other people who have experience in this stuff in the hall, I would like to know.
So I think all the cervical spine surgery, so the common standard is first 6 weeks, all we are agree that we give conservative treatment. That conservative treatment may include medicines, physiotherapy, maybe steroid, local steroid, everything. Of course, surgery is indicated after 6 weeks with failure of all conservative treatment. So I do agree. If there is a recurrence after pain block, yeah, we can go for that.
Thank you. Dr. Sadhana, one more question. How about if there is an osteophyte complex along with the disc, do you still go via posteriorly?
Yes. So I think we had a discussion with Dr. Chandan, I guess. There are many studies and it shows that if you are operating from posteriorly, with a hard disc, which is hard osteophytes, then only open foraminectomy is indicated. No need to go inside. No need to drill. We should not try retract the nerve root and drill that osteophytes. Many studies it shows that there is a post-op weakness for that. If you open the foraminectomy, you decompress it from 3 sides, good enough.
Thank you. May I call upon Dr. Anshal Gupta for technique and versatility of PSLD surgery?
I'm thankful to
Dr. Manas sir, Dr. Savit sir, and Dr. Kalyan sir for giving me this opportunity. Faculty chairpersons, seniors, and dear colleagues. So let's discuss regarding the technique and versatility of PSLD surgery. So full endoscopic spine surgery is the most advanced minimally invasive spine surgery, and which is becoming the gold standard for the lumbar decompression surgeries. And during decompression by endoscopic spine surgery, we are aiming to preserve the facet joint and muscles to maintain the stability. So this is a diagram. It shows that endoscope is very near to the pathology. It gives us the added advantage that pathology is very bigger and clear, and we have advantage of mobility and look around the corner. So this is a study of my last 1 year cases. We operated 62 cases and all cases improved. We had one incidental durotomy which was managed conservatively. I used the cinoscope, which is 12 degree, 113 millimeter in length and 5.7 millimeter working channel. So my indication of the cases have been the paracentral foraminal disc and the central disc herniation mainly at L5S1 region and some cases of the L4, L5 region, the Kester disc, recurrent disc herniation, calcified disc, lumbar and the lumbar lateral canal stenosis, synovial cyst and the facet cyst. And I have tried the para-PSLD for extrafemoral disc in 2 cases and succeeded very well. And some OLIF surgeries for low-grade spondylolisthesis cases. So anesthesia remains a general anesthesia as of now, and we operate in the prone position on the standard adolescent operating table with the medical bolsters. So these are the special surgical instruments that we have discussed multiple times in the previous presentation. So this is the endoscope, cinoscope that I use. And this is my first case, which is having the paracentral disc herniation. So after clearing the soft tissue, I'm just doing the lateral flavectomy. And once this lateral flavectomy that we do, which is then we see the neurostructures, we go to the shoulder of the traversing nerve root, use the RF, clear the portion, and then advance our sleeve to look for the disc fragment. And we just tease out with the RF probe, this extruded disc fragment comes out, and that we remove it very gently, carefully, and the work is done. So here we can appreciate this. Yes, this fragment is coming out. And in the last, we use the RF probe just to do the annuloplasty and look any other free fragments are there or not. So this is my second case, L4, L5 disc down migrated and paracentral with the rent in the center. And this is a surgical video. We needed to do the laminotomy, upper laminotomy, and lower laminotomy, and the middle fascectomy using the drill to increase the interlaminar window and to work into it. So I use the diamond burr 3.5 millimeter. And after that, again, this standard lateral flavectomy. And once we do the lateral flavectomy, I'm just, yeah, we can appreciate this is the middle fascectomy that I'm doing, just going lateral to the traversing nerve root. And we have to be really very gentle. We have to identify the structures. This surgery is done in saline irrigation with standard 30 to 40 millimeters of mercury pressure for the gravity assisted fluid irrigation things. And once we comes to lateral to the traversing nerve root, then using the nerve root retractor, I just use the RF probe to look for the disc. So I could not find the disc. Then I'm coming and looking at the axilla, and here we can see the extruded disc, and now easily, yes, easily, yeah, this is the disc. So easily we can appreciate the extruded disc fragment into the axilla, and using the nerve root probe, we just tease out and remove the disc fragments. We have to be gentle always, that there should not be any dural injury. removing the disc fragment. Then we'll be using our nerve root probe to look another disc fragment, and then then we remove it, and we'll achieve the good decompression in the last. Good free compression, pulsatile nerve root. So this is another case. Here we can appreciate the lateral stenosis, quite significant. So once we dock and we just clear the soft tissue, then we use a drill to increase the interlaminar window and do the upper and lower laminotomy. And till the point we reach to the upper attachment of the ligamentum flavum. So here we can appreciate the attachment of the ligamentum flavum, and we pass the Harrison rongers, endoscopic Harrison rongers, and remove the ligamentum flavum slowly, steadily, and clear the foramen ipsilaterally. This is the lateral recess decompression that is we are doing. To be gentle, we have to understand that these are the chronic compressions, and there can be adhesions. So this is a foraminectomy, and in the last we just do the discectomy, annuloplasty in the last. So by drilling the base of the spinous process, we are able to achieve the over-the-top decompression and bilateral traversing nerve root decompression. So this is the case of grade 4 stenosis. So the steps remains the same: clearing the soft tissue, using the drill, doing the laminotomy, upper and lower. This is a big, huge ligamentum flavum that we have to be gentle, have patience, remove the ligamentum flavum slowly, and we have to do the over-the-top decompression, do the bilateral foraminectomy, and do the decompression very well. So in the last, we could see the disc was quite hard, so I just did the laminoplasty. The decompression was done. So this is a post-op MRI that we can appreciate that there is quite a significant decompression has happened. So this is the case of grade 1 spondylolisthesis. I did with this was my first case of spondylolisthesis that I operated. And I took the help of Dr. Sai Dilip as the proctor. So with the PSLD, I did the decompression, and then transcamin case insertion was done. So slowly we landed into the camin space, then put the serial dilators. We put the serial dilators. We prepared the disc space properly, and then again put our endoscope to see for the decompression. And while putting the cage, we were always monitoring that. So we were monitoring that we are not harming that exiting or traversing nerve root. And then in the last, we were able to achieve this the case insertion. So it was so a sparing surgery, kind of OLIF case insertion. And this was a case inserted and intraoperatively AP and lateral views. Patient did well, discharged on the third day. So advantages of fully endoscopic spine surgery is the improved visual quality. Directly, we are directly at the target. Magnification is the advantage. We can look around the corner, and there is very less injury of the facet joints, as we have seen the post-operative MRI, and very minimal post-operative back pain. And there is reduced collateral damage. Patients are really very happy, and they are asking themselves coming up and asking for the endoscopic spine surgery, one suture surgery. And there are definitely there's superior aesthetic result. There is no dirty scar, and the recovery is faster. Conclusion: the fully endoscopic interlaminar decompression technique has good results and can deal with almost all the extradural pathologies. Thank you.
I have nice presentation. I have very basic two questions.
Yes.
The case you show the pure disc herniation at L45. At that case, you use intralaminar PSLD device. instead of using transforaminal?
Yes, sir.
Is there any specific reason why you choose intraminal approach?
Sir, I think for the transforaminal, yes. For this, if this as a first, it was the L4, L5 lower lumbar levels, L4, L5, and L5 S1. Even for the central disc, I will go to via interlaminar approach. Transforaminal is my choice if it would have been L3, L4, L2, L3 level, higher up, higher lumbar levels. Second thing, I always see the bulge of the disc. If it is going above the facet line, then I prefer the interlaminar. If it is below the facet line, then I use the transforaminal approach. Last but not the least, in the transforaminal approach, I used to do it. Now the numbers are less. So the end point of decompression, I was not very much sure that all the fragments have been removed. So this was a limitations I felt. So my numbers automatically came down for transforaminal, mostly interlaminar now.
Do you use usually you routinely use raminoplasty or remo?
Yes, reamers. I use reamers, manual drills. I have the endoscopic burst drills. I do the foraminoplasty in all the cases.
Okay.
Outside out approach and outside in approach.
Okay. Let's move to the next topic. Okay. Next topic will be the high-grade spondylolisthesis. That's right. And endoscopy internal participant. That's okay. High-grade spondylolisthesis correction by UV. Tricks and nuances by Dr. Dash.
Respected chairpersons, Manas sir, for giving me the opportunity. We'll discuss about the indications and the biportal endoscopy, which is we call as 4 endoscopy. With 2 ports, we'll do everything, including fusion, decompression, and all these procedures. It is photo. We have to, discectomy, even the MLD is the gold standard. We have to move beyond discectomies, which are canals, stenosis, and fusions, which I think UB is designed for those versatility. And we'll discuss, this is how move to 2 ports. It is like 2 ports. With laparoscopy, we have 4 ports. Here we have 2 ports. That's why biportal. See the incisions is very, very minimal. 2 ports, the facial incision will be bigger, but the skin will be ultra minimally invasive. The triangulation, now this is something why endoscopy is infamous. The blind spots of endoscopy. Now patient comes and we do open surgery fusion. Patient says, wow, my claudication has improved dramatically. Now I'm able to travel more than 5 kilometers. But when they do endoscopy, somehow in the beginning phases I have understood, they improve, but more than 1 kilometer, not that 5 kilometer thing. So you have to see the lorry has bigger blind spots. You have to understand the blind spots of endoscopy. See wonderful decompression. L45 single scan. People will say, wow, what a decompression has been achieved by biportal. Now you see this from here to here, wonderful decompression. But there is something here. We have to look for this. This is known as the blind spot of endoscopy. Because we cannot go to the exiting route. We do not feel, we think the exiting route is the stepson of the traversing route. We have to work more on the 4 quadrants. You see the decompression is really, really good from here, here. Everything has been decompressed, but see the scan. Only one scan, which is known as a blind spot. So you have to work more on the blind spots. So in biportal, you can squeeze through the canal because it's a 4 scope. It is not a bigger scope. The scope is 4 the camera is 4 You can squeeze through the lamina and do this under the cave work, which like cavers do. Now it's a drone video. You can see we can pass through there with the tunnel and everything, and we reach a structure which is known as the cord and the root. And this is the exiting route which we are seeing. So this is, now we'll discuss about the topic. It is about high-grade listhesis correction. We'll discuss about the listhesis correction. This is the biportal interbody fusion triangulation. We triangulate on the point, we make the incision on the point where we're going to put the screws. So same ports will be used for the decompression, cage to put the cage, and for the decompression, and for the fusion, and for the screws, everything to 2 ports. So that is why we call it. So you can see, we can have how big we have made. This is the intradiscal space, this is the root, and everything is under wide vision. So you have to understand 4 mm scopy is a bigger scope. It has bigger pixels. So it can go through any corner. It can give you higher pixels so that you can do the work in a better way. So what we call is now the generation of ultra minimal invasive spine surgery. So we are moving from minimal invasive spine surgery to ultra minimal invasive spine surgery. So we'll discuss the steps of this is something when you do the fusion, you have to take care of the facetal arteries, which are very notorious, can have directly bleeding, notorious bleeding. So you have to take care. So basic concept is whenever you are doing a facetectomy, first coagulate on the lateral border of the facet, then do the facetectomy. Otherwise, if you pull it, it is going to bleed. So this is how we do the end plate. This is how we do the end plate preparation. We shave it. We completely shave it, and the same port we are putting the cage. And the same port we'll use for the fusion process. The screws will also go through this. And there is a technique which is known as a retraction of the root by the cage itself. Because you know the lateral border of the cages are smooth. So cage can work as a retractor, or else you can put a additional retractor which is known as a bifid retractor. So this is the advantage. The technique fuses. Just mind my words. The technique fuses because you do a wonderful end plate preparation. Sometimes when you do in open surgery, whatever you curate, you don't know what you are curating, whether you have curated the end plate. But in UB, the scope will go inside and selectively separate the cartilaginous end plate from a bony end plate, the way we do in a ACDF surgery. Separation, perfect separation. The fusion will happen at the end of much earlier than the other things. So technique fuses. This is how we do the end plate. I'm going there and selectively taking out the end plate, cartilaginous end plate from the bony end plate. So fusion happens earlier. So this is the bifid retractor I'm talking about. You can see the bone chips inside. I use all the facetal bone inside, and then we put the cage. This is the retractor, and now we are putting the cage through this retractor. 2 incisions, 2 screws, everything is over. Don't need any additional ports for the surgery. You can see the case, everything under magnified vision. So another thing, I was talking about the 4 mm scopy. You can see there is something I have found in the surgery. There is which is known as exiting root neurolysis, which is a very important thing because in high-grade listhesis, the patient does not only have a back pain, they also have leg pain. The reason for the leg pain is these adhesion tissues. These arise because of continuous hammering of the exiting root by the facets. So these are the adhesion tissues which you see I'm removing from here. These are like a glove. It was covering the things like a glove. So you can do a 4-quadrant neurolysis and you can remove everything. The root, you can do a wonderful, this is a contralateral root, and you see I'm working on the contralateral exiting root. I'm removing after the ipsilateral exiting root, I'm working on the contralateral exiting root and I'm doing the surgery there. So then we'll move and we'll put so 4-quadrant decompression is very easy with biportal endoscopy with a much magnified vision. So this is another case. You can see I've done a multi-level canal stenosis. I've done a fusion with decompression of 3 level. So you see how easy, how magnified the vision is in UB because of the 4 mm scopy, because the scope is bigger, the camera is bigger. So you can see everything clearly. This is a multi-level canal stenosis. I'm working on the contralateral facet. I'm doing the facetectomy. More bone is needed just to put as a graft. So you can use any general instrument in the surgery and do the surgery process very well. So this is, I would say, this is like open surgery inside, and externally it is just minimally invasive, very minimally invasive, which we call as ultra minimal invasive surgery. This is a contralateral work we are doing. Now move to the ipsilateral side and do the annulotomy. Then we'll do the end plate preparation. And from one level, I am able to do multiple end plates, multiple correction like the end plate we are doing. So you'll see the final film. So this is the final film. From here to here, I have done almost a hemilaminectomy. I have done a fusion, everything. So inside the same work we are doing, we are removing all the ligamentum flavum. We are working on the exiting root, which is the main reason for the blind spot for the failure in endoscopy. So this is a grade 3 high-grade listhesis. You see there is absolutely no space between two the vertebral bodies. So there is absolutely no space. So I am not going to distract anything by putting screws on the opposite side. Only with the cage, with the dilators, I will do the surgery and will have a wonderful correction achieved. So First, we'll do the interlaminar window. Then we'll remove everything. When you are going for a fusion, preserve all the bones. We avoid drilling in cases of decompression. Now, in grade 3, high-grade listhesis is very difficult to find the disc space. Sometimes what we do, we take the help of the C-arm, but your eye go inside the cambium strangle and you can beautifully see the thing. So now I'll again see this is scar tissue which I was talking about, which is always missed on the exiting route, which is a reason for the radiculitis in high-grade listhesis. So you can remove this white scar tissue, which is very difficult to do it microscopy because of trickling of blood. But with the water, we can do it wonderfully well. So I'm removing the scar tissue from this side. Now I see in the disc, this is the cambium strangle exactly in front of you. You can do anything you want under vision. So the clarity, the pixels you get, this is a retraction we are doing. Now we are putting the shaver. Now, once I went inside the high-grade listhesis, another finding I find, which is known as the Grand Canyon sign. When I went inside, I saw the end plates were trying to fuse. The end plates are not parallel. It is like waves. It is like waves, like a Grand Canyon. So what we did, we drilled it. We entered the canal and started drilling the unparalleled walls of the Grand Canyon. So you can see this unparalleled walls. So I'm going inside. You can see how unparalleled it is. I have moved to the PLL, ALL, anterior longitudinal ligament here. So this much of disc we have removed. Sometimes if you do indirect decompression, you don't realize how much disc is left behind. That is a reason for delayed fusion and everything. But here you can see, go there, drill everything and make the end plates parallel. So this is the drilling we are doing. This is going inside, drilling the end plates. So my drill is going inside the end plate. I'm not outside the canal. I'm not in the lamina. So I'm drilling it, making it better. Then I'll put the cage. So this is the cage going in. So cage itself does the correction. You don't need any additional instrument for the correction. You see, this is again another thing. And now I have started putting dual cages. So 2 cages will be there. We'll put 2 cages. So I'll show you that. So then we'll move to the end plates. 2 cages will increase the surface area for fusion. So you can see here 2 cages inside, dual cages. So this is how we do the distraction without putting any cages on the contralateral side. We'll just because the body is lying, you can do the distraction well, and we put dolphin nose cases which will hit the end plate and make the correction wonderfully well. So these are the cages, and now you put it in a desired location. These are the corrections we have achieved. You see from here how we have corrected to here without any distraction, just with a cage, which is a 12 number cage. So this bigger the case, better work you do. Complete facetectomy, everything can be done with Biportal. These are the high-grade listhesis which has been corrected well. These are the listhesis corrected well by unilateral screws. So now because you are not damaging anything, unilateral screws are enough. The cage fuses, not the screws, we have to understand. So this is something we have done with virtual reality. This is the triangulation process, and this is radical association which we are trying to tell. And this is my YouTube channel. You can subscribe to get all these videos. Thank you so much. Thanks for the patience.
Okay, wonderful presentation. Is there any comment or question about this topic? I totally agree with your opinion about the drilling the end plate to flatten the parallel surface until we get parallel space. That's the key success in high-grade spondylolisthesis surgery, especially in the endoscope. Something like we do anterior cervical discectomy, we are doing drill of the osteophyte, then create flat space, and then put the cage to correct the kind of alignment and disc distraction. So we need the same maneuvering for posteriorly to reduce and align correctly after cage insertion. Same concept, I think. Is there any question or comment?
I thank all the speakers, and I conclude this session. I thank my co-chairs. This marks the end of today's session. Thank you.
Thank you so much. That marks the end of the scientific session for NSSA 2024. That's going to be held here. Tomorrow we are having the How I Do It sessions and the hands-on workshop. Couple of announcements as usual. The certificates are available at the Torrent stall. Please collect them. They will also be available tomorrow at KIM Secunderabad.
Everybody who signed up for the hands-on, please bring your scrubs that you should have collected from the INTA stall. Otherwise, you'll be forced to use the scrubs at Kim Secunderabad, and we are not guaranteeing the cleanliness of those scrubs. And finally, we're going to have the general body meeting here right now, so please stay in the hall. And that was not finally. Buses will be available to take you from the hotel to the gala banquet at the hotel park. Those buses will leave at 7:30, and similarly, buses will be available here tomorrow morning at 7:30 a.m. to take you to Kim Secunderabad. Just because I got asked this question, nothing will happen here tomorrow. Both the How I Do It and hands-on sessions are at Kim's Hospital, Secunderabad.
Yes.
Okay.
போயிட்டாங்களா சார்?
These are so good going on. Your call too in between. I saw it at around 4:30. Frontidectomy was revisited again today. I was just thinking, we lost touch long back. We haven't- आज का सर पसंद है ना क्या चले हम लोगों को कोई कस्टम्स नहीं है ना सर